This is one of the most commonly used drugs by everybody inside EMS, from EMTs, advanced EMTs, and paramedics, the drug aspirin. Aspirin, the mechanism of action, you gotta know, is classed as an NSAID medication. The MOA of this drug is its anti-platelet aggregation. What does that mean? So, if here's my coronary artery vessel, okay, and it is clogged up with plaque, sticking to each other. Platelets are sticking onto the plaque in my coronary artery, and I'm having an active heart attack. This drug goes in there and says, platelets, would you please stop sticking together, making the clot worse? That's what aspirin does. That's why it saves lives. Okay. Indication would be chest pain patients, ACS. Okay. Now, a pearl about I want to tell you. In the emergency setting, besides someone having an allergy to aspirin, it does not matter if they're on a blood thinner. It does not matter if they're on whatever it is. If they've called 911, which is a rare event to do, and said they have active chest pain, and they're showing cardiac-related symptoms, aspirin will save their life. Obviously, the blood thinner hasn't done that good a job. Obviously, if we're having a heart attack, possibly, give the aspirin, no matter what they say. It is not going to hurt them, okay? Now, aspirin is given for ACS and chest pain. Allergy is in the emergency setting is really the only reason not to take it. Again, this is one of those situations we talked about, like earlier, other drugs. If you call 911, things will change. If you're having a heart attack, well, I need to save your life here. I need to do something, so I'm going to give the aspirin. Okay. Now, adverse effect, yes, there could be some GI symptoms, right? Yes. Okay, taking aspirin and any NSAID can cause GI symptoms like heartburn and reflux. But again, you're calling 911 for heart attack related symptoms. You're getting aspirin. So we will not withhold aspirin. Everyone's getting aspirin if they have cardiac chest pain related symptoms. We're not holding it back no matter what they say. I recommend it. Besides, they're allergic to it. Okay? Don't do any more harm. Dose. Simple dose. If you have teeth, you need to be able to chew it up. 324 milligrams orally. Someone has dentures, get the dentures, you gotta chew up the aspirin. Special consideration, this happens a lot. They'll say, oh, I had chest pain, I took an aspirin. Well, if you took an adult aspirin, that's not the correct way to take it. It's okay, that's great. I'm still giving you the 324 of my baby aspirin. Okay, you're gonna chew it up. Either way, it's not gonna hurt them also. It's a wide range of aspirin. I could overdose on it, okay? Now, going back, a lot of people take one baby aspirin a day. Again, that's great, but finish the dose. So one is 81 milligrams. Give them 3 aspirin to complete the dose, okay? That's a recommendation. They took 2, give them 2. Complete the dose. They need the full 324 for that effect to work. And by the way, not an exam, but out in the field, when in doubt, just give them the 324. Because aspirin has such a range. If you're unsure, I always say, you know what? Here, just take the 324. That way you know you gave it and you know they have it. My recommendation to you. Nitroglycerin is part of our chest pain protocol. Now, nitroglycerin, what it does, it relaxes the smooth muscle of the vessels. It's a vasodilator. Big pearl alert. It decreases preload or demand or workload coming back to the heart. That's what the main effect is. Decreasing preload, the heart can relax, and it's also going to open up the vessels. Okay? Indication, chest pain, acute coronary syndrome, and obviously CHF. Okay, these are your big 3. Contraindications, allergies, hypotension, ED meds in the last 48 hours. I'm going to skip the specials. Let me explain this. So with nitroglycerin, the drug is going to be a vasodilator. So it's going to lower our blood pressure essentially. Okay, we're not giving it for that reason. We're giving it to help treat the ACS, right? The CHF, right? The heart failure. Okay, but if we vasodilate and widen the blood vessels, we could have a hypotensive emergency. So any patient that has a blood pressure lower than 100 systolic, the top number, we will not give nitro to them. Now, in my recommendation, from what I've seen out in the field, every single time I give nitro, the blood pressure will go down by at least 20 to 30 points. Which if I'm at 130, I'm going down to 100. If I'm at 100, I'm going to 70. See why you don't give it? Right? So be very careful. If the blood pressure is under 120, under 130, you're playing with fire. Okay, be careful. Okay? Which is why my other special consideration is if you give nitroglycerin as an IV infusion, okay, we're going to talk about it. You should have 2 IVs in place. One for the drip and one for, in case the drip has an adverse effect of too much, you get hypotension. Now, headache and dizziness are common, okay? The dose. If I'm giving it, and here's the hierarchy. The first thing, let's say we're an EMT, we're going to assist the patient taking their own nitro. It could be a paste, it could be a spray, it could be a tablet, sublingually, okay? The dose for that, or you giving it as a paramedic yourself, is 0.4 milligrams, one dose, sublingually every 3 to 5 minutes. So here's the situation. Chest pain, 10 out of 10, ACS, vitals are okay. They didn't take any ED meds in the last 48 hours. I'm going to talk to you about that in a second. Hang on. We give one dose sublingual. Any effect? Nope. We do a second dose every 3 to 5 minutes. Any effect? Nope. Third one. Any effect? No. That includes the patients if they actually took doses 2. Okay, now, if that don't work, we can try an IV infusion of nitroglycerin, which is in a range. Okay, again, we want to know the appropriate range, anywhere from 10 mics a minute to 50 mics a minute. The dose tends to be larger in CHF versus ACS. The maximum dose that we would ever go to would be 400 mics a minute. That's powerful. Start low, work your way up. Remember the pearl, we talk about lowering pressures, okay? God, if we can just set them up for success, that's great. Just getting this started is unbelievable out in the field, okay? Now, ED med decision. My advice is special consideration. If someone has an ED med on their med list, I typically will not give nitro. Now, is it a contraindication? No, it is a consideration. It's a contraindication if they took it in the last 48 hours. But patients could lie to you, or they could forget because they're having a heart attack right now. So it can be tricky. My advice, if they are adamant that they haven't taken the ED med in the last 2 days, they're adamant about it, and they're in a situation, we know nitro can really help the patient, right? Right. Their blood pressure is in a good place, especially if it's maybe on the higher side, like a CHF event, right? And we get it early on. Do an IV first. Get some IV access, and then go for it. They said they didn't take it in the last 48 hours. Go for it and document it. My advice. This right here is our main EMS drug for nausea vomiting. Ondansetron, Zofran, generic brand. Zofran is used to treat nausea vomiting. Special consideration is, in some studies, Zofran has caused some birth defects, okay? So I would caution and consider, do we really need to give Zofran right now in our ambulance, right? If you really need to, go for it. It's not a contraindication, it's a consideration, okay? So indication is for nausea vomiting. I've used this drug a ton. Contraindication, allergies, adverse effects, dizziness, drowsiness, headache. The dose is 4 milligrams is a standard dose, but you can give 8 milligrams at a time, okay? So you can do 4 milligrams, doesn't work, let's say 5-10 minutes later, do another 4 milligrams, that works. You can give 8 milligrams right away. You can play with it, okay? It's a pretty safe drug. I would just try 4, then go from there, try 8, but you can use, you will see, 8 milligrams is a possibility, but like test question, 4. You can follow another 4, make it 8 for the whole dose. IV, IO, it actually comes PO too. Okay, it'll dissolve in your tongue, pretty cool. And IM as well, okay? This is Zofran, quick and easy one for you. This right here is another one of our hallmark EMS medications. We're talking about albuterol and the duoneb piece, ipratropium. Now here's the deal. Albuterol can be given by itself, okay? Ipratropium needs to be paired up with albuterol to make the medication known as duoneb. I'm going to get into the details just to give you an idea. If you're giving this as a drug in a nebulizer, you can give somebody albuterol by itself, or you can throw ipratropium in there and call it a duoneb. It depends on what you want to do, and there's no right or wrong. But I'm going to explain what they do, and you as the medic or the EMT will make the situation. So here we go. Albuterol acts on the beta-2 receptor. Okay, so albuterol is a beta agonist. All right, so what it does, it turns on, it selects the beta-2 receptor and turns it on. But remember, with all beta blockers, if we turn the beta-2, they're twins, the beta-1, little crossover effect, so we're going to have tachycardia as well, and that's one of our adverse effects. We open the lungs up and get bronchodilation, which is what the drug does. It opens the bronchial tree, which is great if someone has indications. Asthma, anaphylaxis, COPD. Now, it is unsure how it exactly works, but albuterol can be given to patients with hyperkalemia. It helps to shift the potassium where it needs to be. Okay? Now, I don't know the exact details on that. No one really does, to be honest with you, but it is shown to work. So here it is. It is actually an indication for hyperkalemia. Contraindication is allergy to the drug. We do not give this drug to patients with rales. If a patient has rales bilaterally, if they have pulmonary edema, if they have heart failure, we do not give it to the patient. My special consideration is if a patient has a history of CHF, watch out. Be cautious, okay? Have CPAP ready just in case. Get it out. It doesn't mean you can't give it to a CHF patient who has it in their history, but we do not give albuterol to people with active CHF. No. This is for AAC, asthma, anaphylaxis, COPD, and hyperkalemia. Weird one, but it's cool. Okay, dose, 2.5 milligrams in a nebulizer. That's if we give albuterol by itself. Now, what if we give ipratropium? Okay, by the way, I didn't mention generic albuterol, brand name Ventolin, ipratropium, brand name Atrovent. Okay, ipratropium. Ipratropium, like our friend atropine, it does the job of going over to the parasympathetic side and blocking acetylcholine. So, when we block acetylcholine, it's an anticholinergic, we're going to dry up secretions. So, if someone is having asthma, where they get tightness, and they also get hypersecretion of mucus, which is why they have a cough and their chest is tight. That's asthma, right? So if I give ipratropium, I can dry up those bad secretions. Sounds good. Okay, now, here's the thing. My special consideration with ipratropium is, what if you have an ammonia patient who's coughing up green or yellow sputum? The body is coughing up these secretions to get it out of the body. Kind of like how when you have alcohol poisoning, you're vomiting to like get rid of the alcohol. So my special consideration is this. Do we really want to dry up and harden the infectious secretions in the patient with ipratropium? My pearl, and it's not a rule or a law of the land, just a thought, okay, using my brain, you can use yours too, is if I have an ammonia patient, I'm just going to give them albuterol by itself. Let them cough up the nasty stuff and get it out of the body, okay? My recommendation, it's not a rule, not a contraindication, a consideration, okay? Indication is the same as this, just an allergy. Really, there's no real big adverse effects with ipratropium besides what I just mentioned, okay? Dose, 0.5 milligrams. You do not give ipratropium by itself. You must mix it with albuterol. So you have your neb, you open the neb, you squeeze in an albuterol packet, which is 2.5 milligrams. You squeeze in an ibuprofen packet at 0.5. You put the top on, you connect it, and the oxygen dose you connect to, 6 to 8 liters per minute on the neb. 6, 8, both fine. You can play with that. And obviously, you want to make sure you have the patient on end tidal as well, nasally if possible. That helps. Hey everyone, welcome back to the EMS Med section. In this video, we're talking about levobuterol Xopenex. Now, MOA is very simple. It's going to act on the beta-2 receptor. When we act on the beta-2 receptor as an agonist, what's an agonist? It binds to that receptor. The drug goes in and binds to it. We act on beta-2, we bronchodilate and open up the lung. Remember, beta-2, we have 2 lungs. The indication is for asthma and COPD, basically reactive airway disease, okay, asthma, COPD. Now the contraindication is going to be just an allergy to the medication, obviously. Adverse effects, tachycardia, palpitations, anxiety, tremors, okay? Remember, now you're probably wondering, why is that? It's a beta-2 agonist. Well, the thing is, if a drug acts on beta-2, there's always a crossover into beta-1, no matter what happens in the body. So that beta-1 effect shows up as an adverse effect. So when you give this drug, like albuterol, you will see an increase. Now the difference here, the main difference between levobuterol and albuterol is levobuterol is given every 20 minutes, where albuterol is given more frequently, okay? Dose 1.25 milligrams via neb every 20 minutes. The big special here is, remember, to monitor your patient on EKG, and don't forget to still do a 12-lead EKG. Just because you're a patient you're treating for respiratory, you're giving a drug that's going to increase their heart rate. So do a 12-lead EKG, make sure everything is up to par. I'll see you next time. Activated charcoal is a very popular medication at the EMT level. Now here it is. Acadose, activated charcoal brand, Acadose, activated charcoal generic. Activated charcoal is an absorbent, I'm going to explain in a sec, is an absorbent antidote. It's a black powder that binds and absorbs to ingested toxins. So let's picture this. We have a toxin, an accidental overdose that was ingested going into the stomach. Activated charcoal goes in there, binds to it, and basically deactivates it, right? Now this is a very funny thing, but if you roll with me with this, you know when someone goes in and they deactivate the bomb? It's basically what's happening here, okay? You have the toxin, it's about to get all throughout the system, and then in the stomach, the charcoal binds to it. Oh, okay, we're not gonna have a deadly overdose here, okay? So indication is an oral GI poisoning. It doesn't work though in corrosive or caustic overdoses, and if you're allergic to activated charcoal, it won't work either. Nausea, vomiting, constipation, flushing, sweats. So think about it. We're not throwing up the toxin. It's in us, the charcoal binds to it, and then it goes through the system with the charcoal causing constipation, and then leaves through the feces, okay? Dose, 30 to 100 grams PO adult, 1 to 2 grams per kilogram is going to be pediatrics. Now, here's the big thing with anything oral in medicine. We talked about, aspirin, ibuprofen, activated charcoal. Patients got to be alert and needs to be able to follow directions if you're going to give it as an EMT out in the field with activated charcoal. Hey my friends, everyone, I'm back here with glucagon. Glucagon is one of my favorite drugs. It's got an interesting story. Let's talk about it. Now, glucagon, you might see a brand name. Could be like a glucapen. I've seen those things. There's a few things out there, but mainly there's really no brand name. It's just glucagon. It's pretty much what it is. Now, the MOA. The MOA for glucagon is we're going to go to the liver, which stores glycogen stores. Glucagon's going to go into the body and say, hey, look, Mr. Liver, what I want you to do is I want you to transfer your glycogen into glucose. And then as release that to the body, thus saving the life of your patient. Life-saving drug. Now, here's the thing about this drug. I'm going to go skip down to this because it makes sense. This drug will increase your blood sugar levels, your blood glucose, if you have glycogen stores in your liver. If you don't have any glycogen stores in your liver because you've been hypoglycemic for so long that you used them up, they're gone, there's no more left, it's not going to work. The drug's not going to work. So that's my special, no liver stores, won't work. Now the other indication here, we have hypoglycemia. We also have calcium channel blocker and beta blocker overdose, but you got to increase the dose a lot. So you look here, contraindications, just an allergy. In the emergency setting, there's no adverse effects. Excuse me. Diabetes, and then we have calcium channel blocker overdose, which is going to cause basically severe bradycardia. Now, we look here, you're going to need about 5 milligrams IVIO given over 3 to 5 minutes, IVIO, for that severe bradycardia is going to be caused by this calcium channel blocker, beta blocker overdose. Now with pediatrics and your adult over with diabetes, 1 milligram IM, muscular, 0.5 milligrams for a PD dose. Remember, no glycogen in the liver, it won't work. So if this drug doesn't work, that means they got no stores. You got to figure something out. Hey my friends, welcome back to the EMS Meds section. Going to be talking about dextrose, D50 versus D10. Pretty simple one, but we're still going to go through it all the way. Here we go. Now, dextrose, there's no brand name for it or generic. It's simply dextrose. Could be 50%. It could be 10% in an IV bag. Those are the two most common ways to give the drug. Now, what I like about D10 is it can be given to a variety of patients, right? That's why I actually like it better than D50, and we're going to talk about that in a sec. Now, the drug, what it does is it elevates the blood glucose level of the patient very fast, very rapidly. You're giving it IV, okay? Now, contraindication, really, there's none in the emergency setting for this drug. The adverse effects you want to watch out for, which is right here, really are necrosis with D50, and also you could give too much dextrose and go from hypo to hyper. Okay, that's the big one. Now here's what I want to talk about here. The dose is basically, are you going to give an amp, a whole, as they call it, an amp, like sodium bicarbonate comes in an amp, same with D50, a full dose, a full amp, 25 grams of D50, or you get a titrate to effect and keep checking the blood glucose and drip in the D10. My special consideration is my D10 theory. So let's talk about this a little bit. So the beauty of D10 is I can drip in D10 for a child. I can drip in D10 for an adult. I don't have to worry about the major necrosis effect of putting this giant amp, worrying about getting a giant IV. I have a lot more options to play with. In an EMS, the more options I can have, the better. So I personally don't even use D50. I always go with D10. So that's my recommendation to you. Do what you want to do. But I love D10 and I couldn't wait till we had it because it's just so much more smoother. And the other thing I find too is when you give D50 a lot of times, even if you cut it in half and you give half the amp, and I get that stuff, guys, you don't have as much control. With the D10 I can titrate. I can drip it in. Okay, I've hit my number. Let's do a maintenance drip, right? With the D50 it's like, I give, I can't take back. My advice to you guys, that's what I personally do and what I recommend. Naloxone, generic, brand name Narcan. Now we know what this drug does. We may have heard about it before. Let's dive into the details for your drug card. Naloxone, Narcan, is a drug that reverses the effects, the bad effects of opiate overdose. Remembering that, we talk about so many opiates in this course. In Prescription Meds Master, we talked about the at-home, the pill opiates. There's the opiates we carry in the ambulance. We talked about those. Naloxone Narcan, it's going to block down that mu opioid receptor that all those act on. Okay, and it's going to, remember, If we block something down, it's an antagonist, right? An antagonist blocks the effect. So what it does, if I overdose on heroin, okay, and I am attached to that mu-opioid receptor, Narcan goes in there, kicks it off, and then blocks any more heroin from going on there. That's what it does. It competes, and it wins at the receptor site. Now, the indication obviously is opiate overdose which an opiate overdose means you have respiratory depression with your opiate overdose. Just being, for lack of a better word, high on opiates doesn't mean you overdosed on it, okay? You will see many patients in the ambulance that are breathing just fine, but they've taken opiates and they end up in your ambulance. You don't need to give them Narcan unless their respiratory drive is being affected. What I recommend you do with a patient in that state, where they're on the borderline, you put them on N-Tidal and have the Narcan ready. My recommendation. Okay? Contraindication, none, because if we are giving Narcan, they've overdosed and their ventilation rate, the respiratory rate is too low, which means they're going to go into respiratory arrest if they're not already there, and in cardiac arrest. So in this situation, you could say yes, allergy to the drug, but I mean, you're going to pass away, so no, I'm saying none. Adverse effect, when they wake up. So is the adverse effect when they wake up? If you give Narcan too quick, for example, IV, we call it a hot shot. If you go, they'll wake up, they'll be confused, agitated, altered mental. I mean, I remember doing my clinical. I remember one time in a preceptor, they hot shotted the Narcan and they ripped out the IV. Okay, so that can happen. Okay, so slow, start small. It's been a theme this whole medication time, but it still applies. Dose. If we give it intranasally or an auto-injector or IM, or if we give it IM, it's 2 to 4 milligrams. Hang tight for a special consideration. IV, IO, if we give it in the vein, 0.4 to 2 milligrams. Always start low in Narcan and bring it up, because you don't want to have this happen. You wake somebody up, great, then they rip out their IV and they're all agitated. Now, we can't always control that, and I understand that, but I'm trying to give you an idea. Start slow, work your way up, okay? The whole goal of this Narcan is just to get the patient breathing again. We don't need them to go from 0 breaths to agitated. We want to get them in the middle where they're awake and breathing. That's where we want to go. Special consideration. Just so you're aware, if someone overdoses on fentanyl or a mixture of opiates, you may find that you will need to either double your dose of the dose that I gave you here, or what you'll need to do is you'll need to give multiple doses of what I gave you here. So let's say you have a patient. Let's say you give 2 milligrams or 4 milligrams intranasally. They don't wake up. You might need to give another dose. Now, the key thing to remember is IVIO works like literally within like 1 minute they're awake. Intranasal or IM, it can take 5 to 10 minutes, usually about 10 minutes or so for effects. So remember that. But end of the day, if they're in a respiratory arrest or they are, a very, very low respiratory rate, we have to get them awake. That's paramount. A very important drug we need to know cold is Romazicon. Now, here's a brand name, Romazicon. Okay, here's a generic here. Okay, flumazenil. Now, here we have the drug card. This drug, the main feature of it, it's a benzodiazepine antagonist. So what does that mean? Well, it goes to the receptor site where the benzodiazepines bind and it blocks it down. So what happens is the central nervous system that is depressed, well, now it's not depressed anymore. We can save a patient's life with this drug. You know how Narcan is the antagonist, the blocker for opiate overdose? This Romazicon is the antagonist or the blocker for benzodiazepines. Remember what a benzodiazepine is, by the way. It's a sedative, and it causes you to get into respiratory depression, bradycardia, hypotension, just like opiates, right? Xanax, Versed, right? Valium, Ativan, Okay, name a few. So MOA, benzodiazepine antagonist, blocks the action of benzos in the CNS. Just like Narcan blocks the effectiveness of opiates like heroin when you overdose. It reverses the sedative effects, so they wake up. Okay. Indication, reversing the CNS depression from benzo overdose. That's the only reason you use it. Okay. Now this drug, if you know about Narcan, you're watching this video, if you push Narcan too quick, they might have a violent reaction. This drug usually always has a violent reaction. But it can save someone's life, so we have to use it. Contraindications in the emergent setting, just hypersensitivity or allergy to the drug. That would be the only way we wouldn't use the drug, right? Adverse effects: agitation, violence, restlessness, nausea, vomiting, dizziness, seizures, right? Okay, those are your adverse effects. Now here's a dose. Now, remember with dosing, depending on the area, it could always be different, but here's a good standard dose. 0.2 milligrams IV, up to 1 milligram would be the adult. Pediatric, 0.01 milligrams per kilogram with a max dose of 0.2 milligrams. Remember, anytime we have a PD dose, the max is always the lowest of the adult. Just remember that with any drug. Specials. You want to get an EKG and vital signs. And the final piece is you want to watch for violence or withdrawal symptoms. If you give this drug, you will have withdrawal symptoms and violence. The patient's going to wake up almost like a bad Narcan effect. It's going to happen with this drug, but if someone is overdosed on Xanax and they're going to die, we got to give the drug. Obviously, it's going to be better for the patient than that. Make sense? Ramazicon. There it is. Diphenhydramine, Benadryl. Remember this before we even start. An allergic reaction is one body system. If I have hives by itself, allergic reaction. 2 or more body systems is anaphylaxis. Anaphylactic shock is when we have hives, wheezing, nausea, vomiting, stridor. See, 2 or more body systems, my skin, my pulmonary, my GI. 2 or more means we're in anaphylaxis. Anaphylactic shock is when our blood pressure is under a systolic of 90. We can't perfuse our organs. Now, we know about that. Benadryl can be used in a simple allergic reaction, like it's available in the pharmacy, over the counter. Or it can be used as part of the anaphylaxis treatments. Both we can do in EMS. I've had patients where they've called the ambulance, they go to the ER, they have severe hives. I give them Benadryl and we watch. Okay? So just to give you an idea. Now, MOA. It's going to block the H1 receptor. It's an H1 antagonist. Okay? It blocks that receptor. The class, it's an antihistamine medication. The indication, simple allergic reactions, 1 body system. Anaphylaxis, 2 or more body systems. And anaphylactic shock, yes. The last one, though, is EPS reactions, extraparietal dystonic reactions. Now, most commonly given from antipsychotics can cause the reactions. Stiffness, okay? What that is, you want to have this ready. Special consideration, have this ready if the patient's on Haldol or if they've just been given Haldol by you, okay? You can get called for this. I can't move, stiff, okay? Benadryl solves it, okay? Contraindication is you can actually be allergic to Benadryl, okay? Adverse, most people know this. Benadryl can make you tired, drowsy, dizzy. Some people will actually abuse Benadryl because they can't sleep at night to treat insomnia, okay? Now the dose, 25 to 50 milligrams is your standard dose. IV, IO, PO, IM, okay? Now on the pediatric side, you would give essentially 1 milligram per kilogram of body weight for a pediatric, okay? Not to exceed the adult dose. This is our adult range. Hey everyone, welcome back to the EMS med section, talking about famotidine generic, brand, Pepcid. Now you might have heard this drug from your local grocery store, your local Walgreens, Rite Aid, right? CVS, okay? It's true. This drug is available over the counter. It's used over the counter for GI, heartburn, antacid, stuff like that. You're going to learn more about it today. Let's talk about it EMS use-wise. Now, this drug, its mechanism of action, it's an antagonist. What does that mean? It blocks. It's an antihistamine. It blocks the H2 receptors, blocks them. Antihistamine drug. Antihistamine, that sounds like Benadryl. It does. Why do we give this? Anaphylaxis or allergic reactions in EMS. Okay, you can use it, and based on your protocol, this may be in your toolbox. You got to know about it, and you might get quizzed on it. Contraindications: an allergy to the drug that's going to help you with the reaction. Okay, so you might have an allergy to Pepcid. Don't take it. Okay, the adverse reactions are going to be nausea or abdominal pain, pretty common. Now the dose, 20 milligrams IVIO. Here's the big deal to remember. My special consideration for this drug is, remember, this drug also inhibits GI secretions. You're looking at a medicine, you see Pepcid. Doesn't mean they have anaphylaxis. It means they're probably taking it for their GI. So remember that this drug will help anaphylaxis and GI. That's Pepcid. There is a lot to talk about with epinephrine. Epinephrine, if there's one drug that I would carry in EMS, it'd be epinephrine. It does so much. So we have a lot to unpack here. So let's start with basics and get more advanced and more critical. Here we go. Epinephrine, what it is a sympathomimetic. It mimics the naturally occurring epinephrine in our body. Remembering that epinephrine is the player of the sympathetic nervous system. Now, when the drug, epinephrine, is put into the body, it acts as an agonist, which means it turns on the alpha-1 receptor, the beta-1 receptor, and the beta-2 receptor. What do we get with all that? A lot. Alpha-1, vasoconstriction, increased blood pressure. Great. So could we give this drug for someone with a low blood pressure? Could we give this drug to somebody with a bradycardia? Beta-1 is going to increase the heart rate, increase the strength of the heart. Yes and yes. Beta-2, we act on that, it opens up the bronchial tree, bronchodilation. Could we give it to somebody with tight lungs? Yes. Could we give it to somebody with stridor to open that up? Yes. Okay, pretty cool. Now, indications. Why do we give it in cardiac arrest? We give it epinephrine in cardiac arrest because it's the strongest drug to restart the heart. Essentially, we're trying to get the heart to come back to life. I think about like jumper cables, like the car. It's a chemical way of using epinephrine, okay? So, I've split the board here, okay? The drug epinephrine, it's the same drug, but we're giving it in different concentrations. So 1 to 10,000 simply means you have more fluid. We do not put 10 cc's of fluid into someone's arm or leg as an IM injection. About 2 cc's the most you're ever going to put into somebody's arm or leg. Okay? This is why we give the 1 to 1,000 concentration. It comes in a little ampule, and we're able to give that in the IM route and also the nebulized route for stridor. Okay? This side, cardiac arrest, the dose right here, we're going to get into it. Hang with me. The 1 to 10,000, it comes in a box, epinephrine, like a gold box. That's for cardiac arrest only, okay? Now, let's continue here, okay? Now, what does epinephrine do as a whole? Cardiac arrest, 1 to 10,000. Everything else, 1 to 1,000. What's everything else? In this case, it is asthma, anaphylaxis, COPD, our mnemonic, AAC, okay? Stridor, we'll talk about that. Epinephrine can also be used as a drip, we talked about, okay? 2 to 10 mics a minute, it's a good dose, okay? For an epi drip, that would be for severe bradycardia, severe hypotension as a last line, okay? Just throwing it out there, just so you are aware. Contraindication, allergy, tachycardia, if they're already hypertensive, if they already have high blood pressure, or if they're already tachycardic, if they have an allergy, which would be kind of weird because it's in our body, but we go with it, okay? We always put allergy on a drug card. We always do it. We wouldn't give it, okay? Adverse effect. Well, if we're going to raise you up, we're going to get anxiety, restlessness, tremors, okay? Right? Palpitations, okay? The cardiac arrest dose is 1 milligram IVIO every 3 to 5 minutes. Remembering that the 1 in 10,000 epi is only given IVIO, it's too much darn fluid. It's got to go IVIO. Can't go in the arm or the leg. Where the 1 in 1,000 side, our main dose for AAC, asthma, anaphylaxis, COPD, is 0.3 milligrams, right? For example, the EpiPen is 0.3 milligrams. EpiPen Junior is 0.15. Now, if I can give you one dose for all the epinephrines out there in the world, for pediatrics, it's 0.01 milligrams per kilogram. If you just do that when you're giving any type of epi, you'll be fine, okay? Put it down here. 0.01 milligrams per kilogram. You're given any epi in any situation, if you do that, you'll be okay. Strider, adult patient, 5 milligrams in a neb, you can treat Strider, okay? PD, just do this, okay? It's always served me well, okay? Now, special consideration. Elderly patients, if you give epi, you better do a 12 lead. You better do serial 12 leads, and you better also keep them on a heart monitor because you're giving an elderly patient a potent vasoconstrictor with the heart, okay? So look for the heart effects. So that's what we got here, and we just covered epinephrine. Remember, if I give you a last pearl, 1 in 10,000 cardiac arrest, it's too much darn fluid. 1 in 1,000, everything else, that's your IM injection. That's your consideration for asthma, anaphylaxis, COPD, nebulized Strider. And remember, yes, this can be used for IV drips, for severe bradycardia, and severe hypotension. Yes, there it is. Hey everyone, we have the drug here, norepinephrine. Generic norepinephrine, brand is going to be Levophed. You may have heard the saying, Levophed or leave them dead, okay? This is the strongest vasopressor that we got. It's an agonist, the MOA. It's an agonist on the alpha-1 and the beta-1 receptor. Alpha-1, remember, potent vasoconstrictor. Beta-1 is going to increase the heart rate and contractility force of contractions, okay? Now, indications. Septic shock. You know, a time where we need to clamp down because in septic shock, we're in vasodilation. So we need a pressor to bring us back up because the body can't fight like in hypovolemia. In hypovolemic shock, the body's releasing epi, norepi like crazy, and we're clamped down. In septic shock, it's just, there's no ability to do that. We lose that. So that's why it's indication. Also, we have here post-resus hypotension. You get a patient back, they're hypotensive, norepi drip. Contraindication. If they're already tachycardic, if they're already hypertensive, don't give it, obviously. Allergic, don't give it. Adverse effects, if they're awake. Palpitations, anxiety, tremors, okay, tachycardia, too much. Dose, 1 to 30 mics a minute. And it's very important, this drug should probably be given via a pump or an IV flow device, but really via pump I'd recommend. Special consideration, it's the strongest drug we got, one of the strongest that we carry. It's a last line drug. So remember that, it's a last line of defense drug, norepinephrine. It's strong. Next drug is dopamine. Brand name, Intropin. Never heard anyone call it that before, but it is the brand name you need to know. Dopamine is what everyone calls it. Now, before we start, just so you're aware, dopamine is not a push drug. It's going to be come in a bag, usually pre-mixed, and we're going to hang that drug. Okay? Now, here it is. A lot of stuff here, right? Biggest board we got. Let's go. So, here's the key. I'm going to read this to you, and then we're going to discuss. I'm excited. Hope you are too. Dopamine is a sympathetic agonist. It's a catecholamine that it's naturally occurring as well, that acts on alpha-1, beta-1, and dopamine-1, dopamine-2. Some may call it the dopaminergic receptors, okay? Which effect depends on the dose. We're going to talk about it, okay? Now, let me explain this to you, okay? Here it is. Depending on the dose of dopamine that you give, whether we give the low dose, the medium dose, or the high dose, we get a different effect in our patient. We give dopamine to our patient when they are severely hypotensive due to cardiogenic shock. This is a drug we give to patients who are in cardiogenic shock, all right? Now, you can see here, notice the effects. If I want alpha-1 to turn on, which we know causes increase in blood pressure, which we know causes vasoconstriction, that's the high dose. Alpha-1, clamp down, we give the high dose. Medium dose, we get beta-1. We get increased heart rate. Okay, we want a low dose. What we get is the D1 and D2, the dopaminergic, or you could just say dopamine, D1, D2 receptor. We get increased blood flow to the kidneys and the intestines. My old instructor would say, you go with the low dose, it all goes to the gut. Okay, that's what he'd say. It all goes to the gut. Okay, so that's what he used to say. Bradycardias, also, you can use dopamine. If atropine doesn't work, you can try dopamine. Okay? And I'm going to scroll through these, and then we're just going to wrap up. Okay? Contraindications, adrenal tumors, hypovolemic shock. Huh? Why? If this drug, Evan, if this drug increases the patient's blood pressure and they're in hypovolemic shock, their blood pressure is low. Why not give dopamine? See the special? Fixed volume issue before dopamine. Here's why. Dopamine is not going to solve a volume issue. Dopamine is not going to solve a volume issue. That's the big pearl here. So dopamine is going to solve a weak heart, a cardiogenic shock issue. Oh man, our heart is in trouble. It needs a boost. We need to increase blood flow because the heart isn't pumping. That's what we give dopamine. Dopamine is not what we give to patients who are bleeding out. They need blood, okay? Not dopamine. You got it? Okay, cool. Adverse effects. Nausea, vomiting, very similar to epinephrine. Anxiety, restlessness, nausea, vomiting, headache, nervousness, palpitations, because it's going to bring you up. Especially the higher the dose, the more adverse. Now, we say something in medicine called titrate to effect. So what we mean by that is, what effect are you looking for, and that's a dose that you give. If you want to increase blood flow to the intestines and the kidneys, low dose. That's D1, D2 receptor. Now go up. Medium dose, that's going to be beta-1. So it's going to be up here, actually. It's going to be an increase in heart rate. Okay? Beta-1. Alpha-1, clamp down, vasoconstriction, alpha-1. So, low dose, increase the gut, D1, D2 receptor. Beta-1, medium dose, clamp down, alpha-1, vasoconstriction. Okay? So here is the doses. So low dose, 2 to 5 micrograms per kilogram per minute IV drip infusion. Beta receptor, 5 to 10 micrograms per kilogram per minute. And the alpha dose, the high dose, 10 to 20 mics per kilogram per minute. P dose, it's the same dose, but on your exam you would just write 2 to 20 micrograms per kilogram per minute for PDs. Special considerations, dopamine, very similar to our friend that we talked about in another video, dextrose. Dopamine is very caustic to our tissues here. So if we have an IV, it's not actually in the vein, and we just put in dopamine, it's going to really cause some necrotic tissue in that area where the site is. So make sure you have a clean patent IV first and secured well first. And remember, dopamine does not fix a bleeding out issue. It fixes tries to fix, and nothing in medicine is absolute, tries to fix a cardiogenic shock issue. There it is. That's dopamine. Hope you enjoyed it. One of the biggest drugs on this whole course. This right here is one of our main cardiac meds in EMS, an advanced level medication for ALS providers. Amiodarone, also known as cortisone, generic brand. The MOA. Amiodarone is a sodium, calcium, and potassium channel blocker. We are going down with that heart rate. That's what I want you to remember. It's also, the class, it's an antidysrhythmic. So what it's going to do, if we're in a bad heart rhythm, we're going to solve it by doing this. Okay? It's a blocker of all these. Indication is VTAC, VFib, and wide complex rapid tachycardias. Okay, now what does that mean? VTAC, well, if we're in VTAC, we can be in a rest or awake with a pulse, right? VFib, we have to be in a rest. A wide complex rapid tachycardia could be a lot of things. It's on there. Contraindications, allergy to the drug. If they're already bradycardic, well, they're going to go way down. They're going to go into a rest. We don't want that. Dizziness, drowsiness would be adverse effects. Now, here's the meat and potatoes you got to know. Amiodarone, giving the drug, okay. We know it's for VTAC and VFib, okay. Is the patient stable or unstable based on their blood pressure and their mental status? If someone is in cardiac arrest, they are by definition unstable. And then we have a stable, okay. We have to define that. And then we got to treat that. So with the arrest option is over here, okay. The cardiac arrest option is 300 milligrams IVIO. Then when our next round comes, 150 milligrams IVIO. Okay? Now, would be very, very rare, but it happens. Someone's in front of you and they have VTAC, but they got a pulse. Okay, they have a pulse. Okay? Whether they have a pulse and they're stable, or they have a pulse and they're unstable. They have a pulse. Okay? Over here, they have no pulse. We give this right here. No pulse. They got a pulse right here. 150 milligrams, IV bag, 100 mLs, hang it up, throw in 150 amio, over 10 minutes. The special consideration is recognize. Cardiac arrest, amio, you push it. Everything else, if they're awake and got a pulse, you drip it. There it is. Hey my friends, back here with another video. We got lidocaine, xylocaine. Now the MOA here is an antiarrhythmic medication. First thing I want to tell you about the drug, it's a sodium channel blocker. It's going to slow the impulse of the electrical conduction, and it's also going to suppress any ventricular ectopy on the EKG. Okay, that's your MOA. Okay, now the indication is going to be for VTAC and VFib. This also could include pulseless cardiac arrest VTAC, or it could be VTAC with a pulse. VFib we know has no pulse, cardiac arrest. Okay, so contraindications. Obviously, a bradycardia, we're not going to give this, and if they're allergic to it. Now, let's say we talk about adverse effects. Well, if it's cardiac arrest, the patient, we're trying to get them back to life, so there's really no adverse effect. If we're giving it VTAC with a pulse, your patient might get some of these symptoms: anxiety, nausea, vomiting, drowsiness, dizziness, stuff like that. Okay? Now, the dose is very simple. It is 1 milligram per kilogram IVIO. There it is. Now, here's what I want you to know as far as the special considerations. Anytime we give an antiarrhythmic drug, we should be monitoring our EKG. We should be doing a 12-week EKG after giving the drug, if available, if we have time, okay? Just consider it. It's a special consideration. And secondly, remember that lidocaine is the second in line. So we're only giving lidocaine if we tried amio It didn't work. So now we go to this. That's what lidocaine's for, basically, inside of EMS. Our next medication here is atropine. Now, the biggest thing with atropine that I can tell you is I want you to think about what we talked about in A&P. Sympathetic versus parasympathetic. Acetylcholine is the player in the parasympathetic side, while epi and norepi is the player on the sympathetic side. If we block a player, the other side wins. So in this case, okay, atropine is an anticholinergic drug. It blocks acetylcholine from doing its thing in the body. If we block down acetylcholine and its receptors, what happens? Sympathetic wins. So we get a sympathetic response. If we block a side, the other side wins. So atropine says, sympathetic, let's block you out. Block acetylcholine. Sympathetic, come on up. Okay, here we go. So what we get in this patient, and why we give it, is we get a sympathetic response, basically without going to epi and norepi. We do it by blocking the other side, blocking the acetylcholine. Indications is bradycardia. It makes sense. If I'm in a bradycardia, I can use atropine to bring the heart rate up. Cool. Now it also works as an anticholinergic agent against nerve agents that could be harmful to you, like weapons, and our organophosphate poisoning. Okay? Two different doses we're going to talk about. This side's organophosphate and nerve agent. This side's bradycardia. We'll talk about it. Contraindications is just really an allergy to the drug, and obviously some adverse reactions. Anytime we give a medicine on this that's going to, bring up our sympathetic side, what we want to think about is hot flush skin, tremors, tachycardia, restlessness. Okay, the dose on bradycardia side, 0.5 to 1 milligram IVIO every 3 to 5 minutes. This is for bradycardias. Okay, notice this. This side over here, okay, nerve agents, organophosphate poisoning. Okay, you're on organophosphate. Give 2 milligrams. Do we see an effect? Okay, try 4, try 8. Some protocols even tell you just give as much atropine as you can until you're out of it. Okay, so every 5 minutes we give 2, doesn't work, we give 4, doesn't work, we give 8. Keep doubling till it works. This is atropine, dose for organophosphate. Pearl, when in doubt in your brain, I'm on a quiz, organophosphate poisoning is more atropine than the bradycardia dose, which is right here. Okay? Now, special consideration, RSI. Huh? When we go into intubated patients, we can get something called reflex bradycardia. So reflex, it's an event that's happening. Bradycardia, a low heart rate. Why? When we intubate the patient, it can cause that reflex bradycardia. So if we give atropine as part of our preload mix, what happens? Well, we're saying that reflex bradycardia ain't going to happen because we already pre-treated them with atropine. We're on the right side. You see what I'm saying? Here it is. This is one of the main EMS drugs, adenosine, brand name Adenocard. In one word, adenosine is a chemical cardioversion. That's what it is. So when we actually defib our cardioverted patients, we're resetting the heart. Adenosine is a chemical, a medical way, a medicine way to actually do a cardioversion. Let me explain. So MOA, the biggest thing is it acts on the SA node, the AV node, and reduces the conduction time, thus resetting the heart. So we give this drug to patients who are in SVT and other rapid tachycardias. This is an SVT drug, okay? The big thing to remember, we use adenosine, primary SVT. We could try it, special consideration, in rapid wide complex, but we don't jump to that first. That's another drug we're going to talk about, amiodarone. Okay? Adenosine could be a backup for rapid wide complex tachycardias. But for SVT, which is a narrow complex tachycardia, it's first line. SVT, adenosine. SVT, adenosine. Contraindications. Well, if someone is bradycardic, we don't give the drug because we're just going to bring them more down. That doesn't make sense. Allergy. Now, you'll see I wrote in plain English here. Faint feeling, dizziness, anxiety. Why am I saying this? Let me explain. The medical term would be a near syncope, okay, for a faint feeling. But let me explain why I've told you about this. When you give the drug adenosine, the heart will stop and reset for a period of a few seconds, okay? You'll actually see it on the EKG. The patient will have a feeling of doom. They'll be very anxious for that amount of time. The heart is literally resetting. So think about like resetting a clock. It takes a few seconds. Same thing with the heart, okay? So they may feel like they're not going to pass out on you, but they may have a near syncopal feeling, like a doom feeling, an anxious feeling, dizziness feeling. When you give the drug, it's going to happen. The dose, 6 milligrams IVIO. Doesn't work, try 12 milligrams IVIO. Okay, PD dose, 0.1 milligrams per kilogram. There it is, okay? So, and same deal. Now, depending on your protocol, you can go from 0.1, doesn't work, try 0.2. Just to give you an idea, okay? Depends on your protocol. This is the proper PD dose on national, okay? Special considerations, like I told you about earlier, consider for a wide complex TAC. So if we have an EKG and it's an SVT with a bundle branch, it could be a wide complex tachycardia on EKG, but it's an SVT, but it has an aberrancy, it has a bundle branch on it. So adenosine would actually work in that case. Now, if it's VTAC, will adenosine work? Maybe is actually the answer to that. Probably won't work, but they say we can try it. AHA, we could try it. This is the main drug for SVT. This is one of the most common EMS meds. You gotta know this one cold. Metoprolol low pressor is the brand name. So metoprolol generic, low pressor brand name. Here's the MOA. Anytime we see a drug that ends in OLOL, it's a beta blocker. Okay? This is the one that we carry in EMS. The patient can also take this at home in a pill form, but we carry this in EMS for this reason. The drug is a beta blocker. So metoprolol, what it does is it acts on blocking the beta receptors in the body. We know if we turn the beta receptors on, if we turn beta 1 on, we get increased heart rate, increased contractility of the heart, increased blood pressure. What if we block the beta 1 receptor with a beta blocker like a metoprolol? It blocks, it selects. I don't want to block beta 1. Let's talk about that in a moment. We get the opposite effect. We lower the heart rate, we lower the blood pressure, we lower the contractility of the heart, strength of the heart. What's good if our heart rate is going 200 and we're rapid AFib or rapid A-flutter. And this could be used as a backup, which I'll put in here, as a backup, I'll put it over here, in SVT. Okay, it can be used as a backup. Okay, so adenosine, let's say you have a stable patient with SVT, you try adenosine 6, you try adenosine 12, doesn't work, you try this next. Okay, now here we go. Indication, rapid tachycardias. Contraindication, obviously if they're bradycardic or hypotensive, we don't give this, we're going to put them in a cardiac arrest basically. Allergy to the drug, of course. Now, what are the adverse effects? Well, the adverse effects is someone who takes this could end up being bradycardic or hypotensive, right? So think about it. This happens commonly with the pill form of low pressure. Someone has a new medication, their blood pressure is getting better, maybe they don't need the med anymore, they keep taking their blood pressure medications, it's normal, now they take it, it goes too low, right? Dizziness could be it, okay? Dose, 5 milligrams IVIO every 5 minutes up to the dose of 15 milligrams. So 5 milligrams, did it work? Wait 5 minutes, 5 milligrams, did it work? 5 milligrams, I'm out, move on to the next drug. Okay, that's what we do. So 5 milligrams IV should do the trick. Okay, I've never had it go to 15 milligrams ever, okay? But just so you know, it's out there. You never know. Here's my special. My special consideration is when you have a beta blocker and a patient takes one at home, or in this case, you're giving the beta blocker, there is always a crossover effect. The beta blockers are like twins. If you affect one, you'll affect the other. So what that means, if I block the beta-1 receptor, and this drug's goal is to block the beta-1 receptor, by default, even though this one selects the beta-1 receptor, the beta-2 receptor still gets blocked as well. So like I'm sorry. When we give the drug albuterol, for example, it acts on beta-2, right? Yeah, it acts on it, turns it on. So we open up our lung fields. But if we block the beta receptors, we might get a little bronchoconstriction in our lung fields. So if a patient has asthma, COPD, it's a consideration. If we're treating a life threat like an AFib of 200, we consider it, but we need to save their life. This is a special consideration. Diltiazem, cardizem, is one of our backup drugs for SVT. I want you to remember this is our main calcium channel blocker in EMS. Primarily, the indication is for rapid tachycardias like a rapid AFib, a rapid A-flutter, and as a backup, if adenosine fails in a stable SVT patient, we can try diltiazem or cardizem. Now, which one do we use as the backup for SVT? Cardizem or talk about low pressure? Which one do we use? It's up to you. It makes no difference. You can try both. Okay. Now, generic diltiazem, brand cardizem. It's a calcium channel blocker, not a beta blocker. This is a calcium channel blocker. What it does, it blocks down the calcium channels, thus lowering the heart rate, lowering the blood pressure. Okay. We already talked about the indication. Just like a beta blocker, though, it's the same style. So contraindications, if they already have a slow heart rate, if they're already hypotensive, don't give it. You will kill your patient. Okay. Allergies to the drug. What are the effects? Well, of course, we're bringing them down. Every time I bring somebody down, they can get dizzy, they can have near syncope, they could obviously get a bradycardia or hypotensive states, right? So these are the causes. Dose? I'm gonna give you 2 doses because in some protocols, and by the way, I'm giving you 2 doses so you know to pick it up on a test. They might give you this one or this one. Both are right. So the range let me say this first. The range that you'd give an adult patient diltiazem is anywhere from about 10 milligrams to a max dose of 20. We call it 15 milligrams, it's right in the middle. So if you said you give somebody 15 milligrams IV diltiazem, sounds great, okay? Now sometimes though, the dose could be milligrams per kilogram. So 0.25 milligrams per kilogram, not to exceed 20 milligrams in the actual dose, okay? So depending on where you are, depending on the question, is 0.2 milligrams per kilogram right? Is 15 milligrams or 20 milligrams right? I would say 15 milligrams is right on the money, okay? Special consideration, you're dealing with EKGs, keep monitoring EKGs, and print off an EKG while you're giving this drug. My advice. Hey my friends, welcome back to the course. Today we're talking about EMS meds. We got calcium chloride and calcium gluconate. Now, really not much to speak of here versus chloride and gluconate. As the intro to this video, remember this simply. Chloride comes first. So that's going to be the 1 gram dose. Gluconate comes later in the alphabet with the G, so add a gram. It's going to be 2 grams. We're going to talk more about this, but that's the preview or the preface to this video. Now, calcium mechanism of action. It's an electrolyte in the body, very simply. Okay, acts as an electrolyte, and it's going to increase cardiac contractility, basically the strength of the heart. That's what it does. Pretty simple. Okay. Now, the indications for it in EMS-wise, I'm going to give you 3 reasons. You can put the third one in your drug card, but these are the 2 main ones. So obviously, the first one we're going to talk about is hyperkalemia. If you have too much potassium in the body, calcium helps that, number one. Number two is calcium channel blocker overdose. If I overdose on a medication that's blocking my calcium channels, if I flood those channels with calcium, I can get it off. So you're flooding what is causing the problem, which is the calcium channels. With calcium, it reverses it. Pretty cool, okay? Now the third one is, you'll find funny, is hypocalcemia. You don't have enough calcium, so I'm going to give you some calcium. Fair enough, okay? So I didn't write it down, but you could put it down for a third one. It's not common. We're going to know that in EMS, but it's not impossible. So there it is there. Now a contraindication is, my friends, it's just calcium. Could someone be allergic to calcium? I guess. Be weird, but hey, anything's possible. We always put in contraindications allergy no matter what, okay? So let's just say allergy. That's about it, really, when we're talking about the drug. Now here is the adverse effects I want to talk about right in the middle. With calcium chloride, that could be an issue. The adverse effect, you start an IV, and maybe the IV isn't that good and you have tissue necrosis. So that could be an adverse effect. And you're probably saying, Evan, what about all these crazy adverse effects that the drug might have? It's just an electrolyte, so it's nothing crazy. Which is why I always say, if you see a patient with positive signs of hyperkalemia or a calcium channel blocker overdose, do not be scared to give calcium. It's just an electrolyte, my friends, but it does a whole lot when you give it in an IV. Okay. Now, dosing, remember, we have calcium chloride, C comes before G. So we give 1 gram to calcium chloride, 2 grams to calcium gluconate, okay? So look here, 1 gram IVIO over 5-10 minutes, 2 grams IVIO over 5-10 minutes. That's a good rule of thumb, okay? It's a good rule of thumb. Now, here's the big one. Let's say you got a patient. You're giving them sodium bicarb and calcium in the same line. You want to make sure you flush that line out fully before giving the other drug. Could be the first one, the second one, doesn't matter how you're giving it. Flush it out. What I recommend that you do, let's say you're going to give someone sodium bicarb. You give it, okay? Now you want to give calcium. Take 1 flush it out completely. Just take, for peace of mind in your documentation, take a second flush and flush it again. And now give the drug. That works. This right here is one of my favorite EMS drugs. I call it a wonder drug because it does so much. It's a simple electrolyte called magnesium. Now the mechanism of action of magnesium, it's a smooth muscle relaxant. It relaxes smooth muscle around the body. It is indeed an electrolyte. Magnesium does so much. You're about to learn about it. Indications for magnesium. Remember, it's a wonder drug. It has 3 pathways. There's a pregnancy, eclampsia, 3rd trimester pathway. We're going to talk about it. There's a cardiac pathway, torsade points, wide complex tachycardia. We're going to talk about it. Okay, polymorphic VTAC, torsade points. We're going to talk about it. The respiratory pathway, asthma, COPD. Now, you can see here, indication, eclampsia, active eclamptic seizures. That would occur in 3rd trimester. Number 2, asthma, COPD flare-ups. When beta-2 agonists, like so let's say we have an asthma patient, or COPD. We're doing continuous nebs. We're doing epi. We're not getting the results we're looking for. We would then try MAG. It's a last line medication, right? Number 3, torsade points. That's polymorphic VTAC, to give you an example. It's a style, okay, that we can see called torsade points. Very rare, but it's always on exam because it's important to know this. Now, I put here none for adverse effects and none for contraindications. Not because I love the drug, because in an emergency setting, if you have an eclamptic seizure or you're going to die from asthma, COPD flare-up, or the torsade points, there's no contraindications. And magnesium is a simple electrolyte, so it's kind of hard to be allergic to magnesium. It's kind of weird, okay? Not impossible, I guess. I don't know. Think that makes any sense though, so I'm putting none. Adverse effects, same deal. I'm putting none because this is a life-threatening maneuver. Now, one adverse effect that you could put down, if you give magnesium too fast, you can have an adverse reaction. So a special consideration is slow IV push, which is why for 2 out of 3 of these, we actually do an IV drip over 10 minutes, mixing literally taking a 100 cc normal saline bag, taking the magnesium, putting it in the bag, and then dripping it over 10 minutes. Okay? Now here are the doses. Listen up. I have it labeled 1, 2, and 3. So 1 matches 1. So eclamptic seizures. Dose, it is 4 grams. You're going to drop 4 grams of mag. You're going to put it in a 100 cc normal saline bag. You're going to put it into your IVIO, and you're going to drip that in over 10 minutes. Okay? That is for eclamptic seizures. Remember, eclampsia is the biggest dose. Okay? Then we have the middle dose, asthma COPD, which is number 2. Okay, we're going from big dose to lowest dose. So 2 grams IV, drip, IV drip. So with asthma, you tried epi, you tried continuous NEPs, you tried CPAP, not working out. We're going to go ahead and do an IV drip over 10 minutes. So we take 2 grams of mag, put it in a 100 cc normal saline bag, and then drip it in over 10 minutes. Asthma COPD pathway. Number 3, this is a slow IV push. Now, could you put this into a bag and drip it in? You could, but torsade points is literally someone in VTAC, so we're going to push it. A little, even more of an emergency than these great emergencies. Okay, so it's a slow push over about 4 to 5 minutes. I would, for a test question, I do 5 minutes. 1 to 2 grams, slow IV push, IVIO, to 1 to 2 grams. Okay, now, special, if you give it push, you gotta give it slow. Literally over 5 minutes. We don't want an adverse reaction. This is one of my favorite drugs, magnesium. In this video, we're going to talk about sodium bicarb. Very simple. It is an alkalizing agent. That's the MOA. It's going to increase the patient's pH. It's an alkalizing agent. So, what's the adverse effect? You might get too much of a pH boost, causing alkalosis. Okay, now, we give it for tricyclic antidepressant overdose, like Elavil. Okay, you can look the drug up. It's called Elavil. It's a prescription med. TCAs, well, you can hear what it's for, basically. It's antidepressants. They're not very common, but some older doctors may still give Elavil to drug. TCA overdose. Cardiac arrest, we'd give it if, hey, we think they have a hydrogen ion acidosis, meaning they're too acidotic. Let's give them some sodium bicarb, write a code, H&Ts. Let's try it out. Allergy is going to be the only thing. But are you going to be allergic to sodium bicarb? Kind of weird, but we always put allergy. Alkalosis, the dose is 2 milliequivalents per kilogram, whether it's TCA overdose or cardiac arrest. Some places might say 1 to 2 milliequivalents per kilogram. I go with just straight 2. See what your instructor says on this one for your class. But you can't go wrong with either 1 or 2 milliequivalents per kilogram. I go with 2 personally, based on your local area. But consideration, if you got calcium, my tip, you got to flush the line out vigorously between calcium and sodium bicarb when you're giving it. What I do, let's say you're going to give sodium bicarb, flush it once, flush it twice, give calcium. There it is. Hey everyone, I'm back here with Regland. We have our generic name right here. We have the drug Regland. Now here it is. Regland as a drug. There's many we're going to talk about. We're going to talk about a few other medications. Zofran's been in our library here for a while. And Regland is another drug that's going to be an antagonist, block dopamine down to cause its antiemetic, essentially block down the dopamine receptors, thus causing your nausea, vomiting to go away. Okay, So it's going to block the D2, the dopamine 2 receptor as an antagonist. That way, you stop nausea, vomiting. Okay. Now, there's two main indications: nausea, vomiting, and also you can use it for migraines too. Again, how you use it is based on your local area, but you should know about these things. Contraindication really is just simply an analogy to it. Adverse effects. Well, there are some adverse effects here I want to talk to you about. You could have a GI effect, which is pretty interesting. So it actually can also, as special consideration, reduce the GI reflux. So it can be used for that too. But it can go too far and cause GI irritation. I tell it like it is, my friends. Interesting though. Now, the thing about Reglan is, if we give a drug, you know, like Haldol, right? If we give Haldol, we can get stiff, we get stuck, right? Same with Reglan. When we get stiff, we get stuck. If you notice, when we mess with our dopamine, we have a potential to actually have an extraparietal or dystonic event, okay? So something to know about. Dosing is dependent on your protocol, but really here, we're looking at 5 to 10 milligrams as a national standard. 5 to 10 milligrams, IV, IO, IM, it's Reglan. Okay, my friends, we're back here with the drug Compazine. Now, Compazine is an antiemetic drug, okay? You can see here, it's a phenothiazine drug. So phenothiazine antiemetic. That's what it is, okay? Now, indication: nausea, vomiting, or migraines. Sounds a little familiar. Reminds you of our friend Reglan, right? Sounds familiar. Allergies, or you want to caution alcohol patients because it can be dizzy and drowsy when you get too drunk. And if you take this medication, it may have that effect. So you put two together, not good, right? Dose, it's pretty similar to the other drug, 5 to 10 milligrams, okay? IV, IO, IM. The IM dose is 5 to 10 for IV, IO. Big thing right here about this drug, and any drug you give for a migraine, if you're giving a drug for a migraine EMS, you want to make sure that the patient has a history of migraines before you give these drugs. So if they don't have a history, your protocol might not allow it, okay? They might need to be, checked out in hospital first. If they have a history with the same symptoms and a good story, here it is. This drug is Motrin, ibuprofen. I bet that many of you have used ibuprofen probably many times throughout your life, or know someone who has. It's a very popular drug. It's over the counter. Now, do we have it in EMS? Most areas, yeah. Most areas, yeah. So, Motrin's brand name, ibuprofen's generic. Now, I'm going to start with a big pearl here. Just going through this. This drug is an NSAID medication. I'm going to actually start with the specials and mix things up. Let's go down right here. An NSAID medication, if someone says they're allergic to, let's say, aspirin, for example, which is also an NSAID medication, or another NSAID medication, if they're allergic to NSAIDs, then that means they're allergic to ibuprofen. So watch out for that. You got to remember it's an NSAID. Okay, so watch out for that. Okay, now let's go to the whole drug card. Motrin is an NSAID medication, okay, that acts peripherally as an analgesic. Okay, has anti-inflammatory, analgesic, and antipyretic effects. An NSAID medication means it's a non-steroid drug, but it has these effects. So when we say it acts as a peripheral analgesic, that means it doesn't act on the CNS, right? So you have the CNS system and then the peripheral, that's what we're going with. Okay, it acts in the CNS, not an opiate. It's peripheral analgesic. Okay, anti-inflammatory. It has analgesic properties, pain relief. Antipyretic means it can help reduce fever. Okay, indication is for mild to moderate pain. Now, could you say, oh well, if you have a fever, could you give it? Sure. Okay. Sure. Right. Inflammation. Sure. Sure. They all go hand in hand, usually, okay? Hypersensitivity to the drug. We're talking about this. Active GI bleeds, asthma. Whoa, what? Let's talk about it. So NSAID medications, long story short, they're not good for your stomach. They can cause flare-ups, as you'll see in a second, heartburn, stuff like that, with long-term NSAID use. So you want to caution this, okay? You giving somebody ibuprofen with an active GI bleed wouldn't make any sense, okay? So, but it is there. Now, asthma. Why is that a contraindication? So, just so you're aware, it's not a full contraindication. It's something that you should caution. So I put it down here too in special considerations, caution in asthma. So this drug, when given, it can have an effect on the bronchodilation of someone's lungs. So if someone's having an acute asthma, ibuprofen might not be the best drug because it can have effect on how well you bronchodilate. Now the adverse effects, GI irritation, drowsiness, dizziness, renal impairment, heartburn, dose, 200 to 800 milligrams PO would be adult, that's the A. 5 to 10 milligrams per kilogram would be the pediatric dose. So there it is, ibuprofen. Remember, it's not a steroid. It does not act on the CNS. It's peripheral acting. It's an NSAID. Watch out for the allergies. Ibuprofen is an NSAID. I'll see you next time. Hey everyone, and welcome back to the EMS Med section. We're talking about Tylenol acetaminophen. Now I want to start off, I'm going to break the drug card down, but I want to start by saying mainly why this drug is in EMS. The reason why we have this drug in EMS is, as you know, there's been an opiate crisis over time in America, okay? So as you can see, what's been happening over the last few years, Toradol, acetaminophen, other drugs have been put into EMS's hands, so we now have more options instead of just morphine or fentanyl versus give no pain meds, comfort measures, basically ice packs, okay? So let's talk about Tylenol acetaminophen and break it down. As you know, every drug card here has the main sections, mechanism of action, indication, contraindication, adverse effects, dosing, and special considerations. Now the first thing I want to talk about here with this medication, just put this in your head. You can write it down in your test too. It's a COX-2 blocker or a COX-2 inhibitor, okay? Now it's an anti-fever, which means antipyretic, and also it is a pain reliever as well. So it's going to relieve the patient's pain, okay? Here's our first part here. So COX-2 inhibitor, antipyretic, and here's the thing. It's a non-opiate analgesic. Remember here, the brand name is always here. That's your Tylenol. Generic name, acetaminophen, okay? Now our indication, again, is for mild to moderate pain. So for example, a severe pain, that's when you bring out your NARC kit, okay? Those are opiates. Mild to moderate pain, maybe let's say someone has a 5, 6 out of 10 pain. Here it is. You're treating their pain now. Good on you, okay? Now contraindications. Hypersensitivity to the drug. Then also we have liver failure as well, okay? So if your patient says, I'm in liver failure, which you're wondering, if you're new, you may be wondering, what do you mean? There's patients that have liver failure ongoing. They're prone to it, or they're being treated for it. It's a contraindication. Just write it down, okay? So remember, Tylenol, it has a big impact on your liver. So if you take it every day, your liver has some bad effects. That's the main thing to remember here. Adverse effects, going with that liver, nausea, abdominal pain, okay? But really, the adverse effects are very minimal. Now here's the dosing. I'm going to just go through here with dosing. We have pain dose and a fever dose. So here is the PO doses. Here's the IV-IO dose. Remember, IV, intravenous, IO, intraosseous, bone, okay? So we have a PO dose of 1 gram for pain, 500 to 1 gram for fever, so anti-fever, okay? IV, we have 1 gram infusion over 15 minutes, and then we have 1 gram over 15 minutes Same for the fever dose. Now lastly, with Tylenol is our special considerations. So the big thing here is you want to caution giving Tylenol to a patient under 3 years old or a very small patient, okay? Now, the dosing for a pediatric dose could be different based on protocol, but generally it's going to be 10 to 15 milligrams per kilogram every 4 to 6 hours for the PO dose, okay? So remember, PO is always every 4 to 6 hours, okay? And then you have the IV infusion, that's given over 15 minutes. There it is. Hey everyone, welcome back to the EMS med section, our complete guide here to every single med inside of EMS. Now, we're talking about ketorolac, we're talking about Toradol here, and let's start with the MOA. The MOA for this drug is very simple. It's an NSAID medication, like other drugs that are NSAIDs out there we've covered, okay? Now an NSAID, okay, it's a non-steroidal drug, okay? It's going to help. It's a non-steroid, but it's anti-inflammatory. There it is. Now, what we're going to talk about here also is anti-inflammatory effects, and also it's a non-opiate analgesic. So let's talk about it. It's not a steroid, it's not an opiate, but it has anti-inflammatory effects. That's called an NSAID, okay? Now the indication here is going to be for moderate to severe pain, okay? I would even say mild to moderate, okay, mild to severe. Really with this drug and why it's in our bag, maybe you don't want to give somebody a strong opiate for whatever reason, but you'll want to give them something to help with pain first. You try this first. Toradol, there it is. Great drug. Now, contraindication, allergies, pregnant patients, GI. Adverse effects, GI irritation. Here's our dose. 15 milligrams, okay, here it is. 15 milligrams, IV, IO, IM. PD dose, 0.5 milligrams per kilogram, IV, IO, IM. Okay, so 15 milligrams adult, 0.5 milligrams per kilogram for PD. Special is very simple. Just caution in GI in pregnant patients. And there it is, Toradol. Fentanyl. This is a very, very strong pain medication. It's going to act on the mu mechanism, act on the mu opioid receptor. It's an opiate medication in a synthetic form. This is fentanyl. Fentanyl is the generic, Sublimase is the brand name for this drug. Now, here let's move on. The indication. Pain control could be a trauma. Acute coronary syndrome, sure, we're with that. What about the RSI adjunct? Yes, it can be. This can be used as a post-intubation sedative, RSI adjunct. Contraindications, bradycardia, hypotension, an allergy. Adverse effects, same as morphine, same deal, okay? Dizziness, drowsiness, bradycardia, hypotension. Remember, these drugs are going to bring you down. Remember, watch out for respiratory depression. Special consideration is end-tidal CO2. Yes. Remember the pearl here. Fentanyl is in micrograms, not milligrams. Morphine's milligrams. So morphine has an M. Milligrams, normal. It's an old drug. The new kid in the block. Micrograms is fentanyl. Okay? Now, dose. 1 microgram per kilogram is a dose. Okay? It goes for adult and peds. 1 mic per key. Okay? Now, the adult dose range is right here. So the range that an adult would get, if there was no weight-based dose, a good range in one single dose would be anywhere from 50 to 100 mics. That's like a standard good start. So I'll give you an example. Before we first came out fentanyl, it was like, oh, give 50 to 100, then just no weight-based. Now we're weight-based, but you could give somebody, oh, let's do 50. See how it goes. Okay? Let's try another 50, right? Go off this, but you could also titrate up that way, like we talked about in this series. Very important. This right here is the most common pain control medication in EMS, I would say worldwide. Morphine. Morphine, this drug, is our main narcotic opiate pain medicine. Now, I'll read it out to you. Mechanism of action. It's an opiate medication that acts on the mu-opioid receptor. All opiates act on this mu-opioid receptor. Remember, this mu-opioid receptor is the addictive receptor, okay? But it's the most powerful receptor. With that power comes the addiction. With that power comes the adverse effects that it could be dependence later on if you keep using it, but also comes bradycardia, hypotension, possible respiratory depression. Okay, respiratory depression is a big one. We'll talk about that later. Indications are pain control. So let's say a traumatic thing, they need pain control, or could be an acute coronary syndrome as well, right? So we think about that MONA, right? Morphine, oxygen, nitro, aspirin, okay? So there is that. Contraindication. We have bradycardia, hypotension. I'm going to add one in right down. Respiratory depression and allergy. Now, what are the adverse effects? Well, again, I'll name out to you. Feeling like you're going to faint, like a near syncope, dizziness, drowsiness, but also hypotension, bradycardia, and respiratory depression. The big one is respiratory depression. If you take too much accidentally, respiratory depression. Now, here are the doses. This is the proper dose, 0.1 milligrams per kilogram. But I want to give you a range so you can say, okay, what should the range be? You don't want to go above 10 milligrams in a single dose of morphine, no matter what the situation, okay? Now, the most common dosing would be like 4 to 5 milligrams, to give you an example. Could you give somebody 2 or 3 milligrams of morphine? Yeah, you could. A common dose is around 4 milligrams. If you do this math here, 0.1 milligrams per kilogram in a normal adult patient, the range should be around 4 to 10 milligrams, okay? Again, you can give a lower dose. Like, you could give 2 or 3 milligrams or 4 milligrams to a patient. That's completely fair. Like the benzos that I told you about, start low and work your way up. Once you give, you cannot take back. Start low. This is why it's weight-based. Okay? I think they all should be. But to give you an idea, what I tell you, special consideration, anytime we give a drug to a patient that can cause hypotension or respiratory depression or bradycardia, throw them on end tidal. It's not going to hurt. You have it. Use it. Hey my friends, here it is, Dilaudid hydromorphone, generic hydromorphone, Dilaudid, the brand name, okay? So the MOA, let's go through this entire drug card. Dilaudid is a CNS depressant, central nervous system depressant. Now, the big thing with this drug, it's an opiate. It's an opiate analgesic. The indication is for severe pain. Remember, if you watched the videos earlier, we talked about drugs. We have, Toradol on here. We have Tylenol on here. That's more mild to moderate pain. So a way to think about it could be Tylenol, maybe then Toradol. Then we get into our opiates. This is one of, if not the strongest opiate medication out there, okay? Morphine, fentanyl, Dilaudid, right? Now, contraindication and adverse effects for every opiate, including this one, is if they're hypotensive, if they're bradycardic, or if they're in respiratory depression. Any one of those three, hypotension, bradycardia, respiratory depression, all sedatives, all opiates, that's a contraindication and also an adverse effect. Obviously, don't forget the allergy in contraindication. Dose, pretty simple dose. It's a 0.5 to 1 milligram. It's going to be IV, IO. And remember, now, this is big. I call it my small adult theory here. It's something I call it. Don't write this in your quiz. I'm putting this in so you remember it. If you have an adult, maybe they may be of adult age, but maybe they're smaller in the weight, remember to start off at a lower dose and titrate up. Don't start, I'm going to hit them with 1 milligram when they weigh like 100 pounds. Okay? So remember, every adult weighs different. So you gotta look at that with sedatives, even if it's not a weight-based drug. Like this is not weight-based, just this is the dose. Start with 0.5 and work up. That's what I'm trying to tell you. That's my special consideration. Would be in adult patients that are lower weight, start with a lower dose. My recommendation to you. This video right here, we're going to talk about the drug ketamine. Very interesting drug in EMS because they got so many different uses. I'm going to walk through all of them. Here we go. Now, generic is ketamine. Ketalar is our brand name. The MOA, the biggest in one word, it's a dissociative agent. Okay. Now, what I'm talking about here is very simple. It takes the patient and they're totally dissociated with reality around them when they take this medication, okay? So that's in the class of drugs that it's in, okay? Now, it's also a sedative and hypnotic as well, okay? Now, there's a lot of indications here. I'm going to walk you through them. Pain management. Extreme agitation, okay? Basically a mental health crisis patient. Severe psychosis, okay? They're hurting themselves, hurting others. A sedative, RSI. Other procedures, pre-sedation procedures, okay? Contraindication in emergency medicine is just going to be an allergy to the drug, essentially, okay? Now, the adverse effects, obviously we have if they can be overly sedated, okay? We sedated them too much. Now we're getting out airway equipment, boom. There's special consideration. Have your airway kit ready. And hallucinations. Remember, it's a dissociative agent. So it may be hallucinating, okay? Now the dose. It was more than 3. It's a lot of doses here. So I'm going to go through them one by one so you can see them. Now look here. For pain, 0.3 milligrams per kilogram, IV, IO, or IM, okay? Anything IV can be given IO, okay? 0.3 milligrams per kilogram, IV or IM for pain. Now for RSI, up here, 2 milligrams per kilogram IV-IO, okay? Mental health crisis, severe agitation, extreme agitation, hurting themselves or others. 4 milligrams per kilogram IM. 1 milligram per kilogram IV-IO. It's a lot of dosing here. The big thing with ketamine is you're going to know what it does, the dosing. I want you to drill this video in your head and watch it over and over so you got these doses like the back of your hand. Ketamine. Hey everyone, welcome back to EMS Meds. We got diazepam, the generic. The brand name is Valium. It's a benzodiazepine. When you hear benzo in EMS, I want you to think about 2 things. Sedation, like inhibition sedation, like sedating a mental health patient, and finally, seizure, okay? So benzos, think 2 S's, seizures, sedation. That's a benzo. A benzo, one of them is Valium. Now, the indication we just talked about here, so you look, seizures, sedation, I broke it up, anti-anxiety, mental health, essentially, inhibition. Now, the MOA, essentially, going more into that, for all benzos, okay, Versed, Ativan, it's all the same, we don't know exactly how it works. It acts on the GABA in the CNS in the brain. That's the correct answer. It acts on the GABA in the brain. That's all we know. But it works, okay? Now, contraindications are allergies. And you'll see here I put it kind of together. Think about it. If your patient is hypotensive, bradycardic, or in respiratory depression, you wouldn't give a drug that causes that as an adverse effect. So it's both a contraindication and an adverse effect all in one, you can see here. The dosing, now this is very important. This goes in with the special consideration. The dosing is obviously depending on protocol, on the dosing of the drug. But essentially, a good standard practice is 2 to 10 milligrams, with most things being 5 milligrams. I'm going to explain why in a second. Now, for all benzos, the seizure dose is usually the higher dose. So if I had a seizure patient in front of me, the odds are my protocol is going to say give 10 milligrams. Okay, give a shot, 10 milligrams. Okay. Now, the thing is, if we're talking about Valium in this case, we have to really think and say, okay, well, why are we giving the drug and who are we giving it to? So if we have a small adult patient with any benzo, okay, including Valium, I would lower back in your dose first. Remember, we can give a drug, we can't take it back. So if you're a very small adult with a low weight, start at 2 or 5, work your way up, based on your protocol. But that's my advice to you, and that's my special consideration. It would basically be caution in small weighted adults. Possibly go with a lower dose first, work your way up. That's what I would write down on my quiz. Our next medication here is Ativan. Ativan is a benzodiazepine. Now, there's a lot of benzodiazepines. Xanax is a benzodiazepine. Versed is a benzodiazepine. Valium. This is Ativan. This is the king of the benzos, the strongest of all the benzos. I would say Ativan and Versed are the 2 strongest. Now, when we think of benzos in EMS, we have the Lorazepam, generic, Ativan, the brand. Okay. Mechanism of action. Benzodiazepines are sedative, anti-anxiety, hypnotic drugs. Okay. They act, every benzo acts on the GABA receptors, the GABA in our brain. Okay. Now, the effect, it is a anticonvulsant. It uses a sedative medication. Okay. It can also be used in mental health as well. Indications you can see here, seizures. So, the main use in EMS is for pre-sedation, actual sedation, post-sedation. Okay, we'll talk about scenarios in a second. The other thing is mental health sedation, okay, and then active seizures. So if someone's having an active seizure, you can IM Ativan, okay, there's a dose down here, we'll talk about it. What about a mental health sedation, like a mental health psychosis? Someone hurting themselves or others, they need to be sedated. There it is, okay? There'll be 2 milligrams IM, okay? Big tip I want to give you with benzos to remember if you ever get stuck is the seizure dose is always the largest dose. If you remember that, you'll be good, okay? Now, you can see here we have the contra and adverse. Remember, benzodiazepines, just like opiate medications, they're going to cause hypotension, bradycardia, and low respiratory rate, right? So, if we have a patient who's already hypotensive, bradycardic, low respiratory rate, the adverse effect is it can cause that, but the contraindication would be don't give it to somebody also at the same time, okay? Now, the final piece is if you ever sedate a patient, if you ever give a patient a sedative in general, any sedative, you need to put them on end-tidal CO2 monitoring to monitor their respiratory status. Next, benzodiazepine, midazolam, generic. The brand name is Versed. Now, I want to give you a quick pearl before we start about benzodiazepines and when we use them in the field. In your protocol, this is a field tip. In your protocol, it may say, adult patients, mental health, give 5 milligrams. I just want you to know from experience, you want to think about the weight and the age of your patient. With pain meds and benzos, don't just be a cookbook medic. I'll give you an example. If you were giving Versed to an 18-year-old female that weighs 100 pounds, they are going to act differently when that IM injection hits them versus a 300-pound 36-year-old man does, right? So I'm giving you here a little sliding scale, okay? Seizure activity, here's the dose, okay? But I want you to keep that in mind. Okay, seizures, we kind of have to go after a little bit more. Sedation, yeah, we needed to make the move, but we can work our way up. Seizure, we got to stop that. Okay? My advice. Now here we go. MOA. Benzodiazepines are going to act on the GABA receptors in the brain. Okay, that's all we know about them. Okay, that's what they do. Acts on the GABA, you got it right. That's what it is. Okay, it is an anticonvulsant. It is a sedative hypnotic. Okay, and this medication is classed as a benzodiazepine. Okay, midazolam Versed. Now this one, we talked about, like Xanax and like Klonopin and Ativan. Those can be in many forms. Like could be pills that patients take, right, for anxiety at home. Versed is not in pill form. It's only in, we'll call it medical form in our land. Okay, Versed. It's powerful. Okay, like Ativan. Indications: seizures, sedation. So that could be pre-sedation for cardioversion. That we could use this with RSI as an adjunct. We can use this as post-intubation, right? We can use this in mental health for sedation. Okay. Now the contra and adverse, the same as Ativan was. You can see here hypotension, bradycardia, and low respiratory rate. Okay, that's going to be the contraindication, because if you have an adverse reaction to it, this is what you get: hypotension, bradycardia, respiratory rate, because sedatives bring you down, just like narcotic pain meds. Now I'll give you my 2 doses. Okay, now here are the main general doses of Versed. Okay, 10 milligrams IM active seizure. Okay, for adult patients. 5 milligrams IVIO in active seizure patients. Now, in reality, in the field, sometimes a seizure, you're getting an IV, getting an IO, that doesn't sound appropriate. You're going to do IM, 10 milligrams. Okay. Now, I give you my sliding scale here. Okay, this is my own twist. Your protocols might say 5 milligrams IM, mental health. I'm giving you a sliding scale based on a variety of doses. I'm giving you the thing to think about, 2.5 to 5. It's my recommendation. You could start here, get the effect you want, put on end tidal, maybe go here, give me another 2.5. Okay? My advice to you on that, think about the weight of the patient, the age of the patient. Special consideration, anybody who you sedate, anyone who gets pain meds, anyone who gets sedatives, give me that end tidal. There it is. This right here is the main psychiatric mental health drug that we in EMS carry. Okay, it's a paramedic level drug, and it's our major tranquilizer, our major sedative. Halperidol, generic, Haldol, the brand name. What it does is it blocks what we call the D2 receptor, which is one of the most common receptors that are blocked in antipsychotic medications. Okay, so what it is, in patients with mental health crisis, there can be too much dopamine being released, which can cause a psychotic event. Okay, so what these drugs do is they block down the D2 receptor, blocks dopamine, lowers the levels. Now the event is, confirmed. The event is not crisis anymore. Okay, so what we have here, indications, mental health events. What does that mean? A mental health event means the patient is harming themselves, is harming other people. It could be excited delirium. It could also be a bad reaction to another drug, right? And they're in a psychotic event. The patient think too much dopamine levels, got to bring down, get back to par. Now for contraindications, we have an allergy to the drug. Pretty simple, okay? Adverse. Now here's the adverse, real important. Something called EPS, okay? Now what that is you can have a reaction where you have a stiffness of the body, dizziness as well, and this is called an EPS reaction to the drug. It's actually pretty frequent with Haldol. The patient might get stiff, they might get dizzy, right? That is an EPS reaction. The dose is 10 milligrams IM. how would you reverse the reaction? You would give Benadryl, okay? The dose, 10 milligrams IM. Now, I have with benzos, what's that mean? Well, you could put Haldol and you could put a benzo, like the ones we talked about here, in one syringe, give it to your patient. You could also give 1 and 1, 2, but I'm just letting you know about that. It's 10 or alone, 10 milligrams IM of Haldol, just try Haldol, that's fine too. Special consideration, anytime we sedate somebody, we gotta do the following things. You wanna make sure you do the end-tidal CO2. And by the way, cover your butt and check up with the glucose. The drug here, olanzapine, generic, brand name Zyprexa. Now, with this drug, depending on your area and local area protocol, it can differ. But let's dive into what it is. The mechanism of action of this drug is actually unknown. It acts on a variety of different neurotransmitters, dopamine, serotonin, alpha, all kinds really. If you look it up, you'll see. But what I would write down for the MOA is the exact MOA is unknown. It acts on serotonin, dopamine, alpha receptors to get this response of being a atypical, here's the big one, the class, atypical antipsychotic, antisedative. I'd give you 100% if you told me that. So I would say acts on numerous neurotransmitters, okay? Indication, mental health crisis like severe agitation, for example. Excited delirium is another one as well, okay? So remember, what I mean by mental health crisis is someone is so extremely agitated and aggressive, they're hurting themselves and others. And it's due to mental health, severe psychosis. They're not aware of what's going on. Excited delirium as well. Contraindication is just simple allergy. Very common sedative effects, dizziness, drowsiness, stuff like that. You can over-sedate them, obviously. Dose is very simple. It's 5 to 10 milligrams IM, okay? And then special consideration, we can give this med in combination with the benzodiazepine, okay? Versed, Ativan, Valium, to sedate your patient with these things. There it is. Our next drug here is propofol. You've probably seen this drug in movies. You've probably heard about it before. Yes, it's actually what's a drug that caused Michael Jackson's death. Okay, now here it is. Diprovan, brand name. Propofol is a generic name. Is this one of the strongest drugs out there as far as a sedative? You'd be correct. Is it the strongest? You could say so. Mechanism of action. Propofol is an anesthetic that has a quick onset of about 40 seconds. The medication enters the body and inhibits GABA activity in the brain. Shuts off all GABA activity in the brain. Thus, it's sedative, hypnotic effects. Okay? This is a sedative. Now, obviously, RSI. So, rapid sequence induction, rapid sequence inhibition, whatever you want to call it, to sedate and maintain sedation. So, to start, we can also use it to maintain. Now, here's the deal with this. Propofol, remember, is an anesthetic. So it's not just used in RSI. We're talking about EMS, but it's used as a sedative in all kinds of procedures. Okay. Contraindication, when we use propofol, we're using it as an anesthetic. So when we're using it as an anesthetic, the only contraindication is hypersensitivity and an allergy to the drug. Now, if somebody's in respiratory depression, they're apneic or hypotensive, will we use propofol? Probably not. Okay, but you just got to be aware of it. Okay, and especially in these tricky situations, you got to do what you got to do. Now, the adverse effects would be respiratory depression, apnea, hypotension. I'm going to roll over to my special. The whole thing here, like I talked about from early on, is propofol is the strongest sedative out there. So we got to watch out for respiratory arrest and respiratory depression with our patients, and make sure that all our resus, our cardiac arrest, materials, respiratory arrest materials are with us. You should have your airway kit, everything else that you need ready, and everything already structured and set up. All of your cardiac emergency meds, everything should be ready to go. when you are giving this drug. Everything should be set up and then give the drug, just so you're aware, okay? Now, dose, 25 to 75 mics per kilogram is adult. 1 milligram per kilogram is pediatrics. Okay, remember, doses are always going to be a little different, but this is a good standard dose to work off of. Okay, headache, bradycardia, if I didn't mention, for adverse. So there's our drug. There's propofol. Again, EMS-wise, RSI could be used to sedate and maintain sedation. Strong, strong drug. My friends, this video is really impactful. We're talking about RSI, rapid sequence inhibition. Some may call it rapid sequence induction. Whatever you want to call it, it's called RSI. Let's dive into it. So we're talking about paralytic here today. Now we have here rocuronium, the rock, vecuronium, and we have succinylcholine, also known as Sux. It's funny how everyone nicknames it and they call it Vec, Sux, the rock. I don't know. I don't make it up. But I thought I'd tell you a little joke because there's a lot of stuff here, so get ready. Now, I want to point to everything here. I'm going to be looking at this because there's a lot of words here. It's kind of condensed, so I want to make sure that everything's clear when you're watching this video. So here we go. First, we have rocuronium is generic name. Okay, you have here Zemaron is the brand name. It is a non-depolarizing agent, paralytic. It blocks acetylcholine from working, which causes skeletal muscle paralysis. That's your MOA right here. I'll say it again. Non-depolarizing, blocks acetylcholine, skeletal muscle paralysis. Indication, RSI. Contraindication, allergy. Adverse effects, hypotension and bradycardia. Dose, 1 milligram per kilogram IVIO. Special consideration, have your airway kit ready, have a backup airway available, and make sure you and your team are ready to go. Now remember, with any RSI, do we paralyze first or do we sedate first? We're going to sedate first, then we're going to paralyze. Could you imagine paralyzing someone who's awake? Scary stuff, okay? Sedate first, then paralyze, okay? Now, vecuronium. Vec. Here is our brand name here, okay? We have a non-depolarizing paralytic skeletal muscles. Same deal here, okay? Indications RSI, allergy. Notice, same deal with Vec and Rock. Bradycardia, hypotension, same deal. Dose is different. We go up. Here's the way I want you to remember this. R in the alphabet comes first. So your rocuronium dose is 1 milligram per kilogram, IVIO. V comes later. So we're going to just give it a little 0.5. Dose is 1.5 milligrams per kilogram, IVIO. Same deal. Have your airway ready, have your team ready, and make sure everything is set. We sedate, then we paralyze, okay? We don't paralyze people who are wide awake and say, hello, how you doing? Okay, we don't do that, okay? Succinylcholine is a depolarizing paralytic agent, okay? So it's depolarizing. Notice the difference. Non-depolarizing, non-depolarizing. Rocuronium, non-depolarizing. Vecuronium, non-depolarizing. Succinylcholine, depolarizing. It paralyzes skeletal muscle, okay? Remember, when we paralyze somebody, we're paralyzing the skeletal muscles, which includes their respiratory muscles. We are making it so they're basically, essentially stopping to breathe, so we can put an ET tube in and intubate for them. Okay, breathe for them. Okay, but essentially, yeah, we're creating an airway for them, so that would still be correct. Contraindication is allergy, same deal. In all these drugs, hypotension, bradycardia is the adverse. Dose, different dose, 0.1 milligrams per kilogram. Same to have a backup airway. So really what it comes down to is two things with all the RSI drugs. You got to know the name, duh. But it's all the same MOA except, here it is. These are the two key concepts. The MOA and the dose. Now here it is. You got to just know that the R and the V, the rocuronium, the rock, vecuronium, you got to know that these two drugs right here are going to be non-depolarizing. Remember the dosing rule. 1, R comes first, we give it 1, 1.5, V comes later. How can we add that in and remember sucks? It's depolarizing, it's different. So if we remember this dose being 1, we go, sucks is different. Sucks is only 0.1. That's how you're going to remember it. Hope you guys enjoyed this video. I wanted to have a little fun here because it's kind of a dry topic. Hope you enjoyed me. I'll see you next time, guys. Hey everyone, and welcome back to the EMS Med section. Today we're talking about RSI drugs, and we're talking about etomidate, amidate, generic, brand name. Here's our mechanism of action here, or MOA. Remember, if we know what a drug does, most of the drug card fills right in. Now, the MOA on this drug is that it's a sedative, okay, it has hypnotic effects, and it's also short-acting. So it's not a long-acting, it's short-acting. We'll talk about that at the end of the video. Stay tuned. Indication is really only in EMS for RSI. If you're not doing RSI, probably not going to have etomidate. If you are doing it, you're going to have it. Contraindication is simply just an allergy to the medication. That's the main thing. Now, adverse effects, like all sedatives, hypotension, bradycardia, apnea, respiratory depression. Dose, 0.3 milligrams per kilogram IVIO with a max dose of 40 milligrams. Special consideration, what do we have? This is a short-acting sedative. When you intubate at your RSI, you're doing your intubation at your RSI event, you're good to your end tidal. Be very, very careful. If you have a little bit of a longer transport, you might need to give more etomidate to your patients, or more of, maybe have a cocktail of medications, whatever you're doing. But just know that this is not a long, forever acting sedative. So keep an eye on your end tidal, make sure they're not bucking the tube. That's my special consideration. I write down, check end tidal CO2 for keeping the patient sedated. There it is. Hey my friends, welcome back to the EMS Med section, one of the most complete EMS Med section on the face of the internet. Now let's talk here about Ancef. Okay, so what this drug is, essentially, is an antibiotic. Okay, we're using this prophylactically for a patient with a really bad trauma out in the field. This may not be a drug that you see everywhere, but I want to cover it because it's starting to come into EMS. We're doing more. Let's talk about it. So first is the MOA. It's a first-generation cephalosporin medication. That's what you got to know. Okay, essentially it's an antibiotic. Okay. Now it acts on the penicillin binding proteins. Put that planted in your head. Why do I bring that up? Here's why. We're going to talk about it in a second. If your patient is allergic to a cephalosporin type medication like this, or allergic to a penicillin, they should not get this. So if they're allergic to penicillins or this type of drug, they don't get it. Here's the indications. So giving this out in the field, your indication is prophylactically. So let's say there's a really bad amputation or a visible bone sticking out like an open fracture. We want to give that prophylactically as soon as possible to help with the infection. Does this mean that you give this drug on a short transport time? No, it's a special consideration. When you need to be addressing life threats, I got to get my Ancef in. No. I think this is best used when you're out of trauma, everything is stabilized, and now it's time to, okay, let's give it before we hit the doors. That's how you do it, okay? Now, known penicillin or, again, cefalozin allergy, that's going to be your contraindication. Adverse reaction, usual stuff, guys. Nothing crazy here. Nausea, abdominal pain, like any sort of antibiotic medication. Now, the dose here, as you can see, I've split up in two. This is very important. 2 grams IVIO, and it's split to 50 milligrams per kilogram IVIO over 1 to 2 minutes. I put both doses down for this reason. What I recommend you do with this drug, for everybody, is give 50 milligrams per kilogram and do not exceed the adult dose. this is my personal opinion, okay? This is not a rule. But my opinion is, if a manufacturer of a drug or a protocol gives me a weight to go off of, like a sedative or something like this, for example, this is not a sedative, but you get where I'm going with this. I'll always, because we have an adult patient, what if they're small, right? So I'll do it anyway. And let's say you do the 50 milligrams per kilogram and it goes over 2 grams. You just give the 2 grams. That's a dose. You see where I'm going with that? But what if you get less than 2 grams? You made the right choice. You see? That's what I recommend you do. So I would just do the math on this and get your number. Here's a big thing. Special consideration, don't be worried about giving Ancef at a major trauma because you haven't addressed life threats yet. You stabilize your patient, you package your patient, you get them set up, then you give this drug. This drug should be done as an afterthought to taking care of the life threats in EMS. But it's in our bag, so I gotta cover it. Our next medication is Deltazone. You probably know it as prednisone. So the brand name is Deltazone, the generic is prednisone. A quick tip, remember that the patients usually understand the generic over the brand, usually. Like in this case, everyone knows prednisone, okay? Now the MOA, it's a corticosteroid. We talked about these different types in the A and P section. Make sure you'll watch it if you haven't yet. Now, what you gotta know is steroids, it's an anti-inflammatory, right? So there's inflammation, it's gonna attack it. Let's stop that, okay? Now here's the indications. Intercerebral swelling, okay? So the brain, okay? Asthma and COPD. If you have a flare-up of your MS or adrenal insufficiency, okay? Contraindications. Always, to any drug, if they're allergic, hypersensitivity, okay? Then we have some interesting ones I'm gonna talk to you about. Diabetes, fungal infections, and then coagulation disorders. Whoa. Now, notice how these pair up. Okay, watch me here. Diabetes, adverse effect, hyperglycemia. So, this drug can, as you can see, it can raise up your blood glucose level. So, we want to be very careful with patients that have diabetes. They might spike up. Makes sense, right? Now, what's the deal with the infection, the bruising, the coagulation, all that? Let's move down to the special consideration, okay? Now, we talk here, never stop therapy abruptly, and then purple thinning skin. What's this all about? Here's the big pearl with prednisone patients. If you're on prednisone, your skin gets very weak and you bruise very easily when you're on prednisone. It's an adverse effect of the drug. When you're bruising like that all the time, your skin is not in good condition, it's easier for you to get infections in the body, okay? So this is the big pearl with prednisone, and you'll see this in your patients. One of the most common patients taking long-term prednisone is COPD because they have chronic, lasts a long time, bronchitis, inflammation of the bronchioles, so they're on prednisone all the time. So this is a big pearl here. You want to watch out. Prednisone dosing is always titrated. Kind of like if someone's coming off antidepressants, right? We titrate down, or sedative, or pain meds. We titrate down. We don't just pull it away, okay? So same deal here. Here's a good standard dose for you. Adults, 80 milligrams PO, PD, 0.05 to 2 milligrams per kilogram, pediatrics. Good standard dose. Also, if I didn't say it, some nausea, vomiting could be adverse as well. So, prednisone's a drug. It's one of the main steroids in medicine. You're going to see it a lot. Hey my friends, welcome back to our next video here. It's going to be on Decadron, dexamethasone. Now, this drug here is a steroid, so MOA. It's a steroid medication. You can see, remember generic, our brand name. So it's a steroid medication. It's also an anti-inflammatory medication as well. Now, the big thing with this drug we're going to talk about at the end, so make sure you watch the entire video, okay? Now, the indication for this is basically our, you know, our AAC mnemonic, right? Basically, it's our AAC. It's our asthma, it's our COPD, it's our anaphylaxis, and even used for croup sometimes. Now, how you use it is going to be based on your protocol. If I was to give you one thing to remember, it would be asthma. That's the most common use in EMS, okay? Now, as far as contraindications for this drug, in the emergency setting, there's really none besides an allergy to the drug. An adverse effect of this medication, Decadron, is prolonged wound healing. So if you're taking steroids for a while, wounds are going to take longer to heal. And also, if you look at the MOA, this also suppresses your immune response. So keep that in mind as well, okay? Now down below here we have our dose is 10 milligrams IVIO. And here's the big thing. We're talking about steroids. We're going to talk about Ciamedrol, right? We're going to talk about that, methylprednisone later. Same with this, with our Decadron here, okay? We got to treat life threats first and do our main core meds with these patients. Let's say you have an asthma patient. We got to get our IV established. We have to make sure, hey, watch out, do an EKG, get our nebs on board, treat their oxygen levels, maybe give epi. We got to do all that first before we start messing around with these drugs. This will be the last thing you do before you go inside a hospital. This is my recommendation to you. Hey everyone, Paramedic Coach here, back at you with another video talking about EMS meds you need to know. Hydrocortisone, also known as Salucortif. Now what we're going to talk about here is the MOA. So first, the MOA of this drug, it's a steroid. Steroids are going to suppress your immune response, and they're also anti-inflammatory. Now, the indication of this drug is based on your protocol, but here are a few of them, okay? Anaphylaxis could be one, okay? Number two we're going to talk about here, the big one for EMS, is adrenal insufficiency. Big word, what it means? Your body's not producing enough corticosteroids, like aldosterone, for example, okay? So what we're going to do is use this drug to help that out. Watch the video that I have in the course on Addison's disease. Addison's disease, we talk about it here a lot. This is what you want to look at. And now I'll just tell you here briefly, if you haven't watched the video. Addison's disease, what it is, what it's about, is you're too low, your adrenal gland isn't as strong as it should be. So you have low levels of corticosteroids, okay, like aldosterone, for example. So that is adrenal insufficiency. Now, symptoms of that would be weakness, nausea, abdominal pain, fatigue, and they might know they're having a flare-up, and that would be a good one there. Contraindications are going to be allergy to the drug, and we look at the dose. It's one of the easiest doses, 100 milligrams, IV, IO, IM. Special consideration is, remember, when we give steroids in EMS, we treat life threats first, or ABCs. Then once we stabilize, we set up the patient, when we have an IV and we're transporting, then we'll worry about giving steroids. We're not rushing on scene, I gotta give a steroid. Take care of ABCs, later in transport, then you go ahead with your steroids. Like everything else, like Ciamedrol, like all the other ones we talked about, okay? GI issues could be adverse. Remember, any steroid, it could have prolonged wounds. Big key one there. My friends, there it is. Very popular EMS drug right here, Ciamedrol, also known as methylprednisone. Generic, brand. Here we go. MOA, steroid, anti-inflammatory medication, and like all steroids we talk about here, it's going to suppress your immune response. Indication, well, there's a lot, and how and why you use Ciamedrol will be determined by your medical direction. But here are some uses for it. And basically, what it comes down to, really, guys, is AAC, asthma, anaphylaxis, COPD. Then we add in our friend, adrenal insufficiency. What's that again? Oh yeah, Addison's disease. Okay. Contraindication is going to be allergy to the drug. There's really none in the emergency setting. So now let's talk adverse effects, like the other drugs that are steroids. Prolonged wound healing and GI irritation or bleeds. Dose, 125 milligrams given IV, given IO, given IM. And finally, here are our special considerations. Remember, with all these steroids that we're giving, we want to stabilize our patient's ABCs first, get them packaged, get transporting. En route to the hospital, we'll give our steroid then. But treat your ABCs first, get the other drugs in first. So we're talking about these reactive airway like AAC, asthma, anaphylaxis, COPD, We want to make sure we have our nebs on board first, maybe epi on board first, get our IVs established first, do an EKG, then we'll slip in that steroid en route. Our next drug here is mannitol. The brand name, osmotrol. Mannitol is what everyone usually calls it by, the generic mannitol. So here is the deal with mannitol. I'll just explain to you here. When somebody has an increase in intracranial pressure, you see the ICP? That's what we're talking about. So when somebody has an increase in intracranial pressure due to a head injury, mannitol is your drug. That's the indication. Now what does it do? Here it is. Mannitol is an osmotic diuretic. So mannitol is a diuretic. You got it? Okay. It inhibits the reabsorption in the body of sodium and water, acting as a diuretic. So we get rid of that at the cell level. And it acts to reduce intracranial pressure by doing just that. Right? Some indications: acute cerebral edema, increased intracranial pressure, head injury, and also transfusion reactions. Okay? Contraindications: hypersensitivity to drug always, dehydration. Well, think about it. If we're giving a diuretic and you're dehydrated, well, that's not good. That could kill you, literally. Okay? Hypotension. Anytime we are taking more fluid out of the body, our blood pressure will go down a little bit. Okay? Pulmonary edema would be a contraindication. Okay? Now, adverse effects. Here it is. Hypotension. And I'm going to explain the pulmonary edema in a moment. I didn't write it down, but I'm going to explain it to you. Adverse effect: hypotension, low sodium level, hyponatremia, dizziness, nausea, vomiting. I didn't put it on here, but another adverse effect is pulmonary congestion with this drug. So if you already have someone who's having pulmonary edema, it can cause more congestion. It's an adverse effect with this drug. So you could put under adverse effect here, pulmonary congestion, which is why the contraindication is pulmonary edema. There's something to watch out for with this drug, okay? So now you understand that. Dose. Adult NP is the same. It's 1.5 to 2 grams per kilogram, slow IV, okay? Now, this drug is usually dripped in with an inline filter set. What does that mean? Let me explain. So any drug with an inline filter set, what that means is it needs to be dripped in slow. So if we have to mix the drug, what can happen is it can precipitate. So when you use the inline filter set, it won't do that, and it will be dripped in nice, and it won't be any bad reactions or embolisms or anything like that. That's why we do it with this drug, right? A lot of drugs we drip in slow or they go in slow. You use an inline filter set, and as usual, if I didn't tell you this in any of the videos, I'll tell you in this one if you're watching. Vitals and EKG prior and after administration is always a good special consideration. If you ever get caught and I test, what do I write? Vitals and EKG prior and after administration is a special consideration for any drug. So it's there as well. All right? That's mannitol. Big key here, it helps treat head injuries, increase intracranial pressure. What do we watch out for? Remember the pulmonary stuff? Okay? Remember the dehydration, hypotension? We're getting fluid off. Osmotic diuretic. It's mannitol. Oxytocin is generic. The brand name is Pitocin. Pitocin brand, generic, oxytocin. Oxytocin is more common. Let's roll through it all and then discuss. MOA. Pitocin is a hormone, pituitary hormone, that stimulates uretin, the uterus, smooth muscle contraction, okay, which reduces blood loss in the patient. Indication: postpartum vaginal bleeding. Now, let's talk about this. So let's say you have a mother. Mother delivers the baby and the placenta. but there's a lot of blood loss going on in the mother. It's causing bad effects. You would then use oxytocin here to contract the urine smooth muscle, thus you get less blood loss in the patient, right? Postpartum means after birth, okay? Contraindication is 2 reminders. If we have not delivered the baby yet, or a baby yet, we don't give oxytocin. And of course, if the baby's in distress, we don't give it. So feel distress or presence of another baby coming out, okay, which means the placentas are in there, contraindication. Adverse, hypertension, tachycardia, anxiety, nausea, vomiting, and convulsions. Dose 10 to 20 units put into a 500 cc bag of D5, so dextrose 5, IV drip. 3 to 10 units can be given IM, okay? Special consideration, remember the mother must deliver both the baby and the placenta before you can give it. That's the big key here on specials. Oxytocin, sound familiar from A&P? I'll see you there. Oxygen is our most basic medicine in the ambulance that we have. It's a medical gas, but it is very effective. So let's talk about oxygen. So oxygen class, the medical gas to gas. Well, what is the mechanism of action? Well, it's going to correct hypoxia. Remember, hypoxia means low oxygen levels in the body, in the blood, in the lungs, right? We're going to oxygenate our blood. We're going to send more oxygen available to the alveoli level, and thus, we're now going to, because we have a greater oxygen level, reduce the workload on our heart. The indication is low oxygen levels, and also obviously if we're maintaining someone's airway, like using a BVM or someone's intubated or an airway device, we're going to attach it to oxygen. So that's an indication too, right? So again, what's a low oxygen level? Anything under 94% is going to be a low SpO2. Our goal to get our patient between 94 and 99 is our goal. The contraindication to someone giving oxygen is, in this setting of having low oxygen, none. There's really none. We don't give oxygen to patients that don't need it. So that's the big key here. So if someone says, I'm having a hard time breathing, but their oxygen levels are okay, we have to do a full assessment on the patient. They really need oxygen. Their oxygen levels are okay. There's something else that they may need. So we just want to think about that. The big key is we're not overloading patients with oxygen. The goal is not to get the patient to 100% oxygen. If you check your own SpO2, it's probably 97, 98, 99, most likely somewhere in there. Smokers and COPD patients could be a little lower at baseline. We'll talk about that in a moment. But the key is, the only people you're going to see at 100% SpO2 is like pediatrics. And that's like young kids, and even then they're probably 99. So just a key there to look at based on my own experience, what I've seen dealing with all kinds of patients. Adverse effects. Oxygen can dry your mucous membranes a little bit. Now our dose on oxygen, depending on what we're using, like a nasal cannula is like 1 to 6 liters. Now, like I say, an hour breather is going to be like 10 to 15 liters per minute. Depending on the device we're using and or our airway setup, anywhere from 1 to 15 liters per minute, depending on what we're using. We'll talk more about that in this course, obviously. Now, special consideration to remember, our goal is to get our patient above 94. 94 and 99 is our range. Don't overload them. But what about COPD? COPD patients, we want to get them back to their normal. So you want to try to ask the patient and or anyone around the patient, like family, caregiver, what's their normal oxygen saturation? You'll be surprised they'll actually know it because they have a severe respiratory disease and they're on oxygen at home. So whatever that normal is, that's our North Star goal. We want to get them back to that. Oral glucose is used by basic life support providers to give glucose, aka sugar, to the patient. So the patient's blood sugar is low, but they're still alert, they're still able to obey commands, and they're able to protect their own airway. And they're able to speak, of course, because they're conscious and they're alert. So this is 2 we can give them of basically it's carbohydrate gel. And it's going to raise their blood glucose back to normal. So the class would be, it's a carbohydrate, basically a carbohydrate gel. It's what it is. Mechanism of action, it will raise patient's blood glucose level. Indications for hypoglycemia, contraindication, meaning they can't take it as contraindication. So they can't maintain consciousness, they can't maintain their airway, and or they can't obey commands. In this setting of someone having hypoglycemia, there's not too much adverse effects that are going to occur. I mean, it's taking the glucose gel, some people, I don't want to say enjoy it, but the taste, some people may not like the taste of it, but it's not really an adverse effect. But you might say, oh, this tastes good or tastes bad. And you'll see how that goes. Dosing. So usually, it's take the entire tube, which is 15 grams. Could you do half a tube, see what it comes back as? Sure. But most commonly, it's give the entire tube, and then we see where we're at. But as a consideration, a patient must be alert and able to obey commands, must be able to speak, maintain their own airway, so on and so forth. You don't give oral glucose. You do not give oral glucose someone who's unresponsive or who is altered mental status, who's confused. 10% dextrose is probably one of my most favorite drugs we use in EMS because it works so well and is very easy to use. Now, some may call it D10 or 10% dextrose. What this is an IV fluid bag that holds, as you can see here, 10% dextrose. What this does is it allows us to get IV access in our patient with hypoglycemia, which is obviously low blood sugar, low blood glucose, and raise it up and we have a better way to titrate the effect we're looking for versus if we have to use D50, which is an IV bolus of dextrose. One, it can be hard to push. It's very caustic to the vein. And then the third part about D50 is it can be hard to literally just push it in smaller IV, so difficult sticks. So this is why I like D10 so much, the ease of use, and it's also, with the roller clamp in the IV, we have a better titration of how much we're giving. Instead of just slamming somebody here, have a half an amp or a full amp of D50, we can then give a little to get them back over into normalcy without slamming them all the way up to be hyperglycemic as they were just hypoglycemic. Well, I'm going to be normal, right? So the class, hypertonic dextrose-containing solution, an MOA. So it will increase the patient's blood glucose level up and the ease of use. First D50, we talked about that. It's also my special consideration. This is much easier to administer than D50. I love D10. It's a great drug. Indication is hypoglycemia. Contraindications, we want to watch out giving dextrose solutions with head trauma or head injury patients. And if we're concerned about that, then we gotta caution this. Also, obviously, contraindicated in hyperglycemia. Adverse effects. So adverse effect would be basically rare or none. Obviously, we talked about IV fluids are going to cause urination, right? If we're putting fluid in someone's body, it's going to urinate. Titrate to effect is going to be our goal. So if someone's blood glucose is, let's say they're unresponsive and they're at 32, our goal is to get them back to normalcy. If there's family and bystanders on scene, we want to ask, what's their normal blood glucose? Now, let's say they're alone. We won't know. We just want to get them back, say at least over 80, but we want to get them, most cases, back over 100 is going to be kind of our goal. Get them back in 3 digits, get them away from the low zone. If by chance we have, family or bystander on scene, if the patient's not responsive, they say, hey, let's say their normal for them is 130. We want to get them back to their normalcy, and then you'll use that as a benchmarker. So there it is. Activated charcoal is going to be our generic. Actidose is going to be our brand name. The class is an adsorbent and antidote. I love the class because it shows you exactly what it does. So what activated charcoal is going to do, it's MOA. Activated charcoal is going to enter your GI system. So think about it like this. Let's say we overdosed 30 minutes ago on a bunch of pills. And let's just say it was a medication. We're then able to give activated charcoal. It's only been 30 minutes. It's under an hour. Okay. We give activated charcoal. It then goes in and binds with these medications, takes it along the GI route, and then with those medicines, now bind it to the activated charcoal. It gets excreted from the feces. So what does activated charcoal do? It goes in and binds those meds, basically deactivating them. So we cause no further harm. So that is what activated charcoal does. The issue with it, which I'll start with special consideration, is we only have 1 hour from the time they took the actual meds for it to really work effectively. So that's what we're looking at. So the MOA enters the stomach and binds to the drug, and it activates the drug and will eliminate the drug from the body. It must be given within 1 hour of an overdose. The indications, well, there's numerous oral poisons and too many to list here, and many overdoses where we could use it. It's really when can we not use it? Well, we can always try it. When can we not try it? We can't try in a corrosive overdose, a caustic overdose, if someone's unable to obey commands or unable to protect their airway. Nausea, vomiting, unfortunately, is the adverse effect. The dosing, a normal adult dose would be like 30 to 100 grams. So activated charcoal, it comes in it's usually typically a white bottle and it will have the information on it and some information on the side of it. It's kind of pretty helpful. And then inside is the activated charcoal. Activated charcoal is a black, fine powder substance, and basically it's then made into this slurry, if you will, so it's very thick, but the patient's actually able to drink that activated charcoal, actually take it down orally. That's why it's PO. Now, in some circumstances, that could occur at the paramedic level if this is in your protocol. You could give activated charcoal through a NG tube. That's completely possible to do, okay? Now, adult dose 30 to 100 PO, and then a 1 gram per kilogram is pediatric, so that's going to be our dosing there. And we've covered everything here, activated charcoal. Now, you may have heard of an antidote that will counteract Tylenol, aka acetaminophen overdose. It's called a drug called Mucomyst. So Mucomyst is your trade name, brand name. Here's our generic name. Now the class, I'm talking about this simply as the antidote for Tylenol when I'm talking about this in this drug card. That's what we use it for EMS, right? Not for other purposes. So the class in this case is the antidote. The MOA, the big part of the MOA is, remember, if we overdose on Tylenol, that's going to very severely affect our liver and called a toxic liver, which can lead to bad outcome. So this helps delay, and aka I like to think of it as spread out any hepatotoxicity. It delays it, right? The indication is the treatment of Tylenol overdose. The contraindication in this setting of you're going to have a bad outcome due to Tylenol overdose, the only way we wouldn't give Mucomyst is if you're allergic. The adverse effect would be nausea, vomiting, tachycardia, flushed skin. Now here's our dose. A lot of information, so I'm going to start with special consideration. Per your protocol, this may be a case where if there's multiple drugs to contact poison control. Also, you may have a local protocol on whether you can use Mucomyst or not, or if you can carry it. So now let's talk about the dosing, because this is a sneaky one. Now here it is. There's a PO dose and an IV dose. So let's just start with the PO dose. Our PO dose per oral dose, 140 milligrams per kilogram of body weight. Now, that is our goal, right? Now, this is our loading dose, 140 milligrams per kilogram. Now, after that loading dose, we're then going to move to 70 milligrams per kilogram every 4 hours after that. And that can go on every 4 hours at 70 milligrams per kilogram up to 72 hours. Right. Now, are we going to be with a patient that long? No. Well, we could be with a patient for 4 hours. So it's good to know about the second dose. Now, what about IV? IV, we have a first starting dose of 150 milligrams per kilogram. We're going to place that in a 200 cc IV bag of 5% dextrose, and we're going to give that over the first hour. Next, over 4 hours, it's going to be 50 milligrams per kilogram in a 500 cc bag over 4 hours. Next, in a 16-hour period, we're going to give 100 milligrams per kilogram in a 1,000 cc bag over 16 hours. Notice how much drug we end up giving. If we total this up, 150 and 50 is 200, 200 and 100 is 300. So we are giving 300 milligrams per kilogram of drug over a 21-hour period IV. There it is. Lactated ringers. You may have heard about lactated ringers being the IV fluid bag that has the most electrolytes. You're correct in that. So lactated ringers IV solution. Commonly, this is going to come in a few different ways. Usually, most commonly, it's going to be a 1 liter and 1,000 ml bag, 1,000 cc bag. Could it come in other concentrations like 500 or 250? Sure. But most commonly, it's in 1,000. Now, what are all our indications, contraindications, MOA? Class. It's an isotonic crystalloid solution. Okay. What's the MOA? Well, what it's going to do is an IV solution. So we start an IV on the patient. We're going to drip this in. And what it does is replace the lost water and electrolytes. Now, what are the main 4 electrolytes that lactated ringers has? This is key to know. So it contains sodium, potassium, calcium, and chloride. These are all your electrolytes. Now, the indications. We prefer lactated ringers in burns. Why? Because when we have a burn injury, it's almost similar to like a severe dehydration when we're losing a lot of fluid and electrolytes. So there's more electrolytes in lactated ringers. Why we prefer it in burns. Now, if you have a burn patient, could you use normal saline? You could. But if available, I would like to have lactated ringers. If I don't, I can use saline. It's okay. In all these situations, dehydration, hypovolemia, burns, I put 3 indications for you. Indications for you here. Lactated ringers would be preferred unless the patient is a CHF patient, for example, diabetic patient, or has a renal history. The reason why is because the extra electrolytes, like we see potassium here, can skew with diabetic patients, can skew with renal patients. Now with CHF, the contraindication, we don't give IV fluids to people that already have an overload of fluid in their body. So if someone's an active CHF, you're not going to give them IV fluids on top of that. That wouldn't make any sense, right? So burns, dehydration, hypovolemia, we got, if they're fluid overloaded, obviously we don't overload them even more. And then we talked about the special circumstances there. Now, adverse effect. It's rare. I have to mention it. Your patient may have to go to the bathroom, may have to urinate because you're giving them so much IV fluid. That's normal. Now, your special consideration with lactated ringers is do not fluid overload your patient. Remember, as humans, we have blood throughout our body. Now, if someone's dehydrated, they're having a burn event, right? They're hypovolemic, of course, some IV fluid will help. But we do not just overload the patient with 3-4 liters of IV fluids. That's why we have blood products, right? So this IV solution, when we're talking about patients who are hypovolemic, that don't have enough volume, this is just a temporary measure until we can actually get blood into the patient if they're bleeding out that severely, right? So that's the key here. This is lactated ringers. There it is. In this video, I'm going to be going over our 3 medications for paralyzing agents for RSI. These are our paralytics. So here we go. Rocuronium. Rocuronium is going to be our generic name. That's the main name it goes by. The brand name is Zemron. Class, it's a paralytic, okay? But it's a non-depolarizing agent. So it's non-depolarizing. It's paralytic. MOA, to block acetylcholine and to cause skeletal muscle paralysis. The big key is skeletal muscle paralysis. It's non-depolarizing. That's the big key for class MOA. Indication, RSI. Contraindications. In the setting of RSI, there really aren't that many contraindications, right? We have to use a paralytic. If it's the one we have available, the one we're going to use, right? So I put contraindications in this setting, really just an allergy to the drug, all right? Adverse effects we want to look for, hypotension, bradycardia. Dosing, 1 milligram per kilogram IVIO. That's our dose. Now, what's the special consideration about all these paralytics, and you're going to see on every single one of them, make sure you have a backup airway. So that's the big key here. Make sure we have, whether it's a King LT or a Combi tube or an LMA or a iGel, your surgical airway, make sure that's out. If you need it, make sure that is ready to go. You just paralyze somebody. There's the first one. Now let's go on. We have 2 more. So our next paralytic we have available is vecuronium. So here's vecuronium, and here's our brand name here. Class is going to be of paralytic, non-depolarizing. What's our mechanism of action? Same thing. It's going to be a paralytic to the skeletal muscle. It's going to paralyze skeletal muscles. That's the mechanism of action. Indications RSI. Contraindication, again, in this setting, if we're doing RSI out in the field, the only thing is really going to be allergy in this setting. The adverse effects we're looking for: hypotension, bradycardia. Dose, 0.1 milligrams per kilogram IVIO. And remember, have your backup airways available. Now let's move on to succinylcholine. Now our final drug here is succinylcholine. Now, succinylcholine, we have here a Nectine, a brand. Class, this is the big key, why I have it here. Succinylcholine is a depolarizing paralytic, where rocuronium, vecuronium are non-depolarizing paralytics. That's the split difference. Now, they're both going to paralyze skeletal muscles, but they do it in a different way. So remember, succinylcholine is the one that is, yes, the depolarizing agent. Indications RSI. Again, in this setting, we're doing RSI out in the field. Allergy to the drugs is the only thing that's going to make us not use it if it's the only one we have available, right? Adverse effects: hypotension, bradycardia. Dosing, 1.5 milligrams per kilogram IVIO. Special consideration: backup airway available. Now, for more about RSI, difficult airways, situations like that, make sure to go to the ALS Accelerator, and you're going to see a video labeled RSI. It's about a 28-minute video. Make sure to go watch it. I'll see you there. Sodium chloride, also known as normal saline, probably the most popular IV fluid solution that we have in EMS besides lactated ringers. Usually you'll have normal saline and lactated ringers on your ambulance, and we're also going to talk about one more IV solution as well. Now with class, we have isotonic crystalloid solution, okay? Pretty simple to remember. Now, here we go, MOA. It's going to replace water and electrolytes. Sodium and chloride are our electrolytes for normal saline. Sodium chloride. Right? Pretty cool. Indications. Remember, we talked about lactated ringers. We want to caution diabetics. So we know that as a paramedic or advanced EMT, we would give IV fluid to somebody in DKA. So that's diabetic patient. Well, indicated would be normal saline, right? Hypovolemia, again, dehydration, heat illness, heat exhaustion, heat stroke, right? Dehydration, that's indications. Contraindications, remember, fluid overloaded patients, we don't need to give them more fluid, right? Like CHF. The adverse effect is rare, but no, your patient may use the bathroom, urinate. The dose, again, titrate to the effect you're looking for, fix their problem. Our special consideration is, remember, our patients pump blood, not IV fluids. So our goal, if the patient is hypovolemic or is dehydrated, get them back to their normal state, get their blood pressure maintained and stabilized, not to pump them full of 3, 4, 5 liters of IV fluid, right? That's not the case. They need blood ultimately, and like in trauma, they need blood. So remember, when we're talking about hypovolemia or someone bleeding out, it's a temporary measure until we have blood. You know we have a big topic if I don't have a chair. So here we go. We're talking about antihypertensive medications. Now, what does that mean? Well, for hypertension, that means hyper means too much, too high of blood pressure, okay? So these 5 classes of medications will go after that high blood pressure and bring it down to normal. And there's 5 main ways of doing that. Later in the video, I'm going to give you the exact meds, the generic, the brand name, show you all that. But first, we got to understand how it does it, what are the classes. So here's number 1, beta blockers. Beta blockers, what they do, right in the name, it's going to block down the beta receptor. If you haven't watched my receptor lesson yet, make sure to look for it in this course and watch that lesson so you understand the alpha and beta receptors. And just so you're aware, if I turn on a beta receptor, I increase my heart rate and my blood pressure, the strength of the heart. So if I block the beta receptor the other way, guess what happens? I lower my blood pressure. Same with the calcium channels. If I block down the calcium channels, I'm going to relax my blood vessels and lower my blood pressure. So these are pretty simple, okay? Now, whoa, what is a diuretic? Well, what a diuretic does, in a general sense, we have another video on the 3 types of diuretics, but let's talk about just diuretics in general for a moment. Diuretics, what they do is they help remove excess fluid, in this case, water, salt, urine, okay, from the body, right? There's different types we'll talk about in another video, but in this case, this is the #1 diuretic out there to not only do that, but help you lower your blood pressure, okay? They're called thiazide diuretics, okay? The 4th piece. Now, if you haven't watched the video yet, all you gotta do is go to the anatomy and physiology section, and there'll be a video where it has a title in it, Angiotensin II. Watch that video, okay? Very insightful for you to understand this, but let me tell you now. In the body, when angiotensin II is released, right? If there's too much angiotensin II circulating in the body, you could have high blood pressure. Angiotensin II is released in the body normally when we have too low of blood volume, too low of blood pressure, right? Now in this case, this patient has high blood pressure. So if we lower the amount of angiotensin II and we block the receptors, that's great. We know that can't be the culprit, and we see, is the blood pressure improving? Okay, that sounds pretty fair, right? Now this right here is called an ACE inhibitor. So this is properly called an ACE inhibitor. You can see here I have in the brackets what ACE stands for. It stands for angiotensin converting enzyme, okay? Now, whoa, along the course of the journey, when we go from renin to angiotensin 1 to angiotensin 2, inside of that, there's an enzyme that brings us from angiotensin 1 to angiotensin 2, and that is the angiotensin converting enzyme. If we can inhibit this enzyme from being produced in the body, we will never get to angiotensin 2, so that's going to help our blood pressure. Exactly. Okay? So these are the 5 main classes. Now we're going to talk about the different medications. Here we go. Now that we understand the classes, now we can go through the actual most common medications. So these right here are the most common medications for high blood pressure, medical term, antihypertensives. Now, you can see I have the generic name, the brand name, and then the class type, okay? These are the most common in my opinion. Now, if I could pick one drug for you to go over prescription meds wise, high blood pressure medications is one of the most common, okay? So this is super important for you to know. Most patients over a certain age are going to be on a high blood pressure medication most of the time, okay? So first, I'm going to walk it through it. Okay, we have amlodipine. Now amlodipine, we have the brand name Norvasc, is a calcium channel blocker. Next, okay, next up here, we have benzapril. Benzapril, Lotenzin, is an ACE inhibitor, okay? Hydrochlorothiazide, also known as HCTZ, is a thiazide diuretic, okay? The way to remember, if I go like this, and I'm going to show you a very, very secret pearl to get better at prescription meds faster at the end of this video. Stay for that, okay? Next, valsartan, Diovan, very popular medication, okay? It's an angiotensin II receptor blocker, okay? Metoprolol, low pressor. Hey, EMS, we carry that medication, okay? Let's continue. It's a beta blocker, okay? Lisinopril, probably one of the most common medications in America. Zestril, ACE inhibitor. Now, what can we determine, and I'm going to show you here on the board, about these meds to pick up on other meds that may be new or other medications that are older or just in the marketplace that aren't on this most common list, because there's so many to know. This is not a rule, but it can be helpful. Watch this. Okay, we see here, see how this ends in pril, and see how this ends in pril? ACE inhibitor, ACE inhibitor. Wow. Okay, here's a pril with beta blockers. If it ends in OLOL, one that's not on here is atenolol. It's a beta blocker too. They both end in OLOL. Pril could mean it's an ACE inhibitor. OLOL could mean it's a beta blocker. Okay? If I see thiazide, the odds are it could be a thiazide diuretic, right? Makes sense? Okay? Now, same thing goes with this peen. Maybe it's a calcium channel blocker. It's not impossible, right? We have the tan here. Maybe it's an angiotensin II blocker. It's not a rule, but it's something. If you look at a med, look at the ending. Does it match something that you know? Think about it. Here's the most common. Let's move on. These medications right here treat high cholesterol. Now we know one of the cardiac risk factors is high cholesterol. Let me break it down for you. Before a patient even gets on any of these medications, the doctor tries to get them to do a diet and exercise routine. Now what does that mean? Longer walks, some cardiovascular activity, start working out, okay? If they can, possibly, lifting. We know it's all good for you, okay? Diet, right? More vegetables, right? More fruits, more lean cuts of meat. They try it first. But that does not work. Then what they do is they're going to move into these medications, unfortunately, because they have to do the following. They want to lower the triglyceride levels, okay? High triglyceride levels are a risk factor, okay, of cardiac disease. We want to lower the LDL, we want to higher the HDL. Because this is the issue they're having, they have a cardiac risk factor, we got to solve it. So here they are, okay? We have Lipitor, we have Zocor, we have Crestor, we have Zetia, okay, which is actually, in this case, like over here, these are brand names, generics. Notice, statin, statin, statin. Zetia is, I didn't put the generic because Zetia is, I've only seen it called that. Then this is an interesting one, I just want to share it with you. Caduet, what it does, it actually puts together amlodipine, a calcium channel blocker, with Lipitor, which is a statin medication that treats, we just talked about, high cholesterol. So imagine that, combining the two, because we know that a lot of patients that have cardiac risk factors, they may have high blood pressure and high cholesterol. So they actually made a med with both in it. So we treat the blood pressure and the high cholesterol. Pretty interesting. I thought I'd share it with you. If you see it out in the field, let me know. My friend, I'll see you next time. If I could tell you about diuretics in one sentence, diuretics remove salt and water from the body. Diuretics remove excess fluid from the body. That's what diuretics do. Now, why would we want to do this? Well, if our blood pressure is too high, there's a reason. If we have an overload of fluid in the body, like, for example, we think about heart failure patients, right? Fluid overload, then we might want to do that too, right? We don't want them to have a flare-up, go to the hospital. Okay, so here we have. Now, this is talking about loop-acting diuretics. The way that the first type, there's three types. A loop-acting diuretic, I like to consider the traditional, the standard, the normal diuretic, the most common diuretic. It's a loop diuretic. It simply acts to do this. Go to the loop of Henle and say, hey, can you just increase the amount of urine and take, remember, water and salt go together, and can you get more water and salt out of the body, please? Thank you. That's what a loop-acting diuretic does. On the next slide here, I'm going to show you the different types of medications. Okay. Number two, potassium sparing, like it sounds. What if we say, okay, this patient, we got to get some fluid off, but we need to keep some potassium for whatever reason. This is what it does. So it reduces water, but the thing is, there's no BP support in this type here. So someone that takes a potassium-sparing diuretic, they're not getting BP support. They're just getting fluid loss, okay? Because they're overloaded. All these patients are overloaded. Here is the king of blood pressure support, the thiazide diuretics. They're going to actually widen the blood vessels, and they're also going to reduce water and salt, and they're going to lower the BP. So these are our three types of diuretics that a patient may have. Now let's talk. I'm going to flip over here, and we're going to talk about the medications. Here we go. We've gone through the classes. Now here are the most common diuretics. We have Bumex and Lasix. Those are our two loop diuretics. We have Aldactone. We have Mirdamor, which are going to be our two potassium-sparing diuretics. We have hydrochlorothiazide and chlorthalidone. Now, you'll see here as an NA for the brand name. I've never seen this medication with any brand names. There are brand names for it, but you never see it, so I put NA. I want to confuse you. It is also a thiazide diuretic, okay? So here are your most common generics, brands for diuretics you need to know. Let's move on to the next section. This class of medications is called anticoagulants. If we coagulate, we bring together, right? Well, that can be good in some cases. If we're bleeding out and want to coagulate, I'm okay. But we don't want to do that inside our blood vessels. We don't want to have a lung attack, pulmonary embolism. We don't want to have a stroke, a brain attack. We don't want to have a heart attack, a myocardial infarction. That's bad, right? So we don't want blood clumping together in our veins. So patients that are at risk, let's say they have stroke risk, let's say they have cardiac disease risk, let's say they have atrial fibrillation risk, where the top of the heart is quivering, it's easier to get clots, right? They may be put on these medications, okay? If they've had an event, for example, okay? Now here, let's go through them, and then we'll talk about some pearls, okay? So these top 5, I'm going to give you a mnemonic to remember these. So the first one is Coumadin, warfarin. Everybody knows that. Everyone knows Coumadin, warfarin, warfarin, Coumadin. Everyone knows that. You ask someone in your family, they know it, okay? Now, give me 2 P's, Pradaxa and Plavix. Evan, could you give me 2 more examples? Sure. Example, EX, Eliquis, Xarelto. That's how I remember the top 5 blood thinners. But then, someone always says, Evan, you forgot some. Okay, fine. I draw the line here because these 2 medications are used in different circumstances usually than these medications. Like if someone's on bed rest, they can be on Lovenox, right? For example. Heparin, for example, same thing, okay, if they're on bed rest. So these are 2 that can be used for bed rest. Yes, other things too, but I put them together so you remember, okay? And they're sub-Q shots, okay? Now, heparin is heparin. There's no brand, no generic. Heparin's heparin. Now, Lovenox right here, Lovenox, you may see this in someone in take-home care, okay? Meaning they're in the home and they're being cared for by a nursing staff. Lovenox, they're on bed rest. Lovenox is very common, okay? So these are your top 5 blood thinners. Just so you can, because you can kind of see them here, okay? Now, if I was to pinpoint the most popular, I would say Plavix, Eliquis, Xarelto. The least common of this would be probably Pradaxa, and these are very common also in hospital patients, long-term care patients. And then also, remember, heparin is our drug of choice with pulmonary embolism in the hospital. You gotta know these. See you in the next one. Probably in our top 3 or top 5 most common calls is for diabetes. We got to understand diabetes medications. If you want to be a real pro, understand their medications just as well as they do. That's what we do here. Now here we go. We're starting with insulins. Okay, we're going to work our way from insulins to type 2 medications, the oral pills. Then I'm going to give you a bonus that everyone messes up on. Hang with me. So we have rapid insulins, short-acting or regular insulins, intermediate-acting insulins, and long-acting insulins. So just like the name sounds, if I give you a rapid insulin, it's going to take effect right now. What most diabetics will do, to give you an example, right, is maybe like 30 minutes before they have a meal, they'll take a regular insulin, right? And then for other reasons, and we're not going to get into in this video, they may take intermediate and long-acting insulins for whatever is going on between them and their doctor, okay, in primary care medicine. Now, here's the pearl. Let's start with rapid, okay? Novolog, Humalog, Apidra. So how do you remember that these are the rapid ones? What if you go to a diabetic emergency? Oh, well, what insulin, you're telling me there's a problem with them. What insulin did they just take? We can know. Oh, did they take a long acting? Oh, it's like a rapid acting. See? Now, here. Rapid, look. A log. Then the weird one, Apidra. Sorry, I can't help you with that, okay? But we could, if you think about it, O-log, oh, the A, Apidra. It could work, okay? But the log is the rapid. Now, short and regular and intermediate, notice something. You got to look closely here. Humulin and Novolin is short and regular. Intermediate, all you do, if you see Humulin with a capital N, so Humulin N, Novolin N, it just means it's intermediate acting. See the N? If you see an N, intermediate acting. How do we remember the long insulins? LL. It's an L there, an L there, an L there. Long acting, you mean Lantus and Levemir? They're the insulins. I'm going to erase the board. Let's go to type 2. We've gone through the insulins. Now I want to go through the oral medications for diabetes. Now, here's the pro I want to give you. Most type 2 diabetics are taking oral medications. Show me 10 type 2 diabetic patients. 9 out of 10 are going to be on oral medications alone. Okay? 1 out of 10 is going to be on insulin too. That's a severe case. Okay? Most are on oral meds. Could be one or more of these. Okay, to give you an example. Now there's so many that I've even left off the board that are common. Like there's even more, but these are the most common. There's a lot of them. Now the thing about these diabetes medications like the former insulins, they usually only go by one name. These meds, every med has a generic and a brand name. I've chosen the most common name that you're actually going to hear. For example, if you tell a patient, oh, did you take your glucophage? They're going to be like, what are you talking about? That's a brand name. See, no one calls it that. So let's go through. Metformin, glipizide, Actos, glyburide, Januvia, Tradjenta, Trulicity, the old Victoza pen, Farxiga, Jardiance. Now, if you watch TV for even 5 minutes, you would hear about Jardiance, Farxiga, Tradjenta, Trulicity. That's how, when I first started in EMS, I used to learn about medications. I was from watching TV, even for like 30 minutes, and you learn medication. Great job. You made it to the bonus. Here it is. Gabapentin. Gabapentin is not for diabetics. It treats diabetic neuropathy. So it does not treat diabetes. It treats diabetic-related neuropathy. It also treats fibromyalgia. It also treats epilepsy. Okay? It also treats plain old nerve pain neuropathy. Okay? Now, you gotta know this. Gabapentin does not mean somebody has diabetes. They could have neuropathy. They could have nerve pain, fibromyalgia. They could have epilepsy. There it is. The medications on this whiteboard treat anxiety and depression. Now, the top part, we have 2 benzodiazepines. They're sedatives, okay? Very, very common. Now, in EMS Medications Mastery, that section, you're going to see lorazepam, Ativan. It's an even stronger benzo than these, okay? Now, these, remember, are all the pills oral form that the patient may be taking. Okay, we have anxiety up here, we have depression and anxiety down here. Okay, so these do just anxiety, these can do both. Okay, here we go. Alprazolam, Xanax, anxiety. Clonazepam, Klonopin, anxiety. Remember, I didn't write it down, but it's the EMS meds. Lorazepam, Ativan can also be taken orally as well as an anxiety treatment. Sertraline, Zoloft. Okay, we have Celexa, we have Lexapro, and Abilify. Okay, these are the most common meds to treat anxiety and depression. Now, there are three main types. Okay, I'm going to go over bipolar disorder, schizophrenia, and dementia. Yes, that is a mental health crisis. Now, hear me out here. Okay, bipolar disorder means you have high highs and low lows. Okay, when people have a bipolar event or episode, they could do things because they're in that psychosis state of high or low they wouldn't normally do. Okay, bipolar, the most common medication is lithium to manage bipolar disorder. Now, in the middle here on this whiteboard, schizophrenia medications. Without exception, schizophrenia is a disease that will last a lifetime. Now, if a patient stops taking their medication for schizophrenia, they will become in a psychotic state, also known as psychosis. Okay, they will not know the world around them. Okay, here are the main meds. Okay, and here are, again, if I give you a medication without both, it means that you're not going to see the other one. Okay, this is what you're going to see most commonly when talking to nurses and patients. Here it is. Clozapine, very popular. Abilify, we talked about earlier, but Abilify also can treat this too. So, let's go from the top. Clozapine, Abilify, Geodon, also known as Ziprasidone. I will give you that one, okay? Risperidol, also known as Risperidone, give you that one too, okay? Seroquel, Invega. Zyprexa, also known as Olanzapine, I'll give you that one too. Latuda, Haldol, Halperidol. Now, one not on here, it's an old school med, Thorazine. Something to think about, but it's old school, but you never know, you might see it. Dementia. There are a few meds with dementia. These are the two main ones. Notice the ending in teen, okay? So watch that for dementia meds. Here are the two main ones. Aricept, you also have Namenda. Those are your two for dementia. They also obviously treat Alzheimer's disease as well. My friends, there it is, mental health. I will see you in the next section. I wanted to put together a list for you here, kind of like I did with the most common type 2 diabetes medications. These right here are the most common phrases the patient will know with anticonvulsants, also known as anti-seizure medications. So to name a few, we have Keppra, we have Depakote, we have Dilantin, also known as fentanyl. That is popular too. Fentanyl with a P. Dilantin, Lamictal, Topamax, Tegretol. Now, you're probably wondering, well, what about for EMS? What do we do for, someone who's having an active seizure? That's covered in EMS Medications Mastery. But I will briefly tell you that benzodiazepines, for example, I'm going to name them here, Valium and Versed, two V's, they're very common to be given in EMS for seizure activity. Those are covered, you'll see them, inside of the EMS Medications Mastery. These right here are the pill form the patient will be taking themselves that you will see if they have epilepsy, seizure-like disorders. These are the main ones here. If I had to pick the most popular, probably Keppra and Dilantin, followed up by Tegretol. Probably what I've seen as most common. What I call this right here is the medication pathway or the medication ladder of chronic pain. So, if someone's having chronic pain, maybe they start them off. And by the way, I want you to know that all of these medications, all of them have a downside risk. We hope that we can solve a patient's pain, right? This is we're talking, remember, prescription medications, okay? EMS meds or EMS meds, this is on their med list. I want you to know about them. But we start off with a patient maybe using ibuprofen, Advils or NSAIDs, Tylenol, for example, for their chronic pain, right? You've seen the commercials on that. Now, antidepressants, anticonvulsants, how does that treat chronic pain? Well, the most common chronic pain patient would be like fibromyalgia, right? Would be a nerve pain, neuropathy. These can come in and treat that, okay? Because it has to do with signals in the brain. The final piece is narcotics. When we think of chronic pain, we think about narcotics. So I'm going to flip this board around, and I'm going to show you the most common narcotics, okay? And yes, a lot of them are opiates. I wanted to put together a list for you. We've gone over the ladder. Some of the meds you may see. I don't want you to get caught off guard. Here's why EMS-wise. What if they overdose on one of these opiate medications, these narcotic medications, right? It's going to be your call. Obviously, we're going to use naloxone, Narcan to reverse the effects, block down that mu-opioid receptor, get them back, but you got to know this on a med list. All right, here it is. Quick pearl, I'm going to give you two. Codeine, morphine, oxycodone, OxyContin, methadone, we'll talk about it, fentanyl, hydrocodone, hydromorphone. Again, the pain meds we give in EMS, to name a few, morphine, fentanyl, Dilaudid. Okay? Now, you can look those up EMS-wise in EMS Medications Mastery. The patient in a pill form would be taking these. What's the stars in the underline about methadone? Methadone is used to wean people off of opiates. Okay? Very, very important. Okay? These are your chronic pain signals. I'll see you in the next video. Right here is a condition called insomnia. Insomnia means you have a hard time sleeping. We all know that sleep is essential to your well-being, to your health. You gotta drink water, you gotta eat healthy, and you gotta sleep. The three pillars of health right there. Now, big pearl about insomnia. There's a few different options with insomnia with patients. Some patients, they might have no problem going to sleep, but they wake up too often in the night. So they wake up in the middle of the night too much, so they can't stay asleep. Other patients, literally like the most common scenario, they can't fall asleep. So here's a tip for you and also some advice. Melatonin is over the counter if you have a hard time going to sleep. Melatonin, if you watch Anatomy and Physiology section, you would see that melatonin is released around nighttime when we go to sleep. Okay? Now, these three here, Ambien, Lunesta, Sonata. These three right here are the most popular, Sonata being the newest. Ambien, Lunesta have been around for several decent time now. Okay, you've probably seen the commercials on them. They are prescribed medications. The issue with these medications, especially Ambien, is that they're very, very addictive. So you want to think about it as, okay, this patient, if they have insomnia and they're taking this medication, you want to say, hey, how long have you been taking the medication, right? And you want to think about, could their insomnia be causing something else going on with the patient? Just a quick thought. These medications right here treat erectile dysfunction. These are also called ED meds. The reason we need to know these inside of EMS is because if we have a patient and we want to give nitroglycerin, we can find that medication in the EMS Medications Mastery section. If we try to give nitroglycerin for chest pain, but someone has taken one of these medications in the last 48 hours, 2 days, their blood pressure can get way too low. As a rule of thumb, if somebody is prescribed these ED meds, I personally would not, out in the field, give them nitroglycerin unless they adamantly said no, they have not, and also you already have an IV in place. Okay? If not, if they're on these meds, I probably would wait to the ER. They're going to understand that. Okay? Do your other protocol. So ED meds, we have sildenafil, Viagra, tadalafil, Cialis. We have vardenafil, Levitra, and then avenafil, which is Sendara. Now, if you look here, a fill. If it ends in a fill, it's probably an ED med. There it is. This right here is a very common misconception with medications, and it's a very common med you'll see. Trazodone versus tramadol, tramadol versus trazodone. Tramadol treats chronic pain. It's actually an opiate, okay? Trazodone treats insomnia. It's a sedative for anxiety and depression. So trazodone, anxiety, depression, it's a sedative, insomnia. Very common for insomnia too. Tramadol, chronic pain, opiate. Pain versus sedative. Tramadol, it's going to dull the pain. Trazodone, time to go to sleep. There it is. HIV medications. Now, HIV medications, the biggest pearl I can give you is this. If a medication ends in VIR, that means it's an antiviral medication, okay? If a patient is taking multiple antiviral medications every day on their med list, they may have HIV. Here are the most common HIV medications, right here. Truvada, Incentris, Epivir, and Norvir. Remember the pearl. If it ends in VIR, it is an antiviral. Now, there are other reasons for taking antivirals. For example, someone can have herpes and take an antiviral, okay? But these are your main players. These main four are for HIV. There are a tremendous amount of new HIV meds and also a tremendous amount of VIR meds. It's not uncommon to see an HIV patient taking a lot of meds, like multiple HIV meds to combat it. The whole goal, I just want to give you a pearl, with HIV is to bring their viral load down to what we call undetectable status. Okay, now what that is that when they would actually do a check, it would look like they don't even have HIV because the viral load is so small. If the patient, if they ask you, you can tell them this, the patient stops taking their HIV meds, even for a few days, their viral load spikes up, okay? So the whole goal is once they figure out they have HIV, is, the early detection, is to keep the viral load undetectable status forever. That will prolong their life. Super important. This video right here may be the most important video I make about anatomy and physiology. Why? The levels of organization that I'm going to share with you right here take you through the entire A&P course, the entire A&P everything. So with the levels of organization, what it is, the most simplest way I can tell you is it's the levels of the body. So if you're playing a video game, there's level 1, level 2, level 3, 4, and eventually it's the end. Okay? So in anatomy and physiology, this is your beginning and end of that game. The levels of organization starts down here and goes up here. So I'm going to just break them down for you and have some pearls here for you to remember. Okay, so here we go. You're going to see throughout the course of this video series here on anatomy and physiology, we're going to start with the atom, the smallest part, cells, tissues, organs, organ systems, the organism. Hey, that's us. So that's what we do. So the chemical level is the base level of the levels of organization. Okay, so chemical or Some may call it the molecular level. Okay, that's atoms. Okay, we then move up from there to the cellular level. Well, it's in the name. That's cells. Okay, from there we go to the tissue level. Now, what's a pro I can give you to remember tissues? Well, it's right above cells, right? So for tissues, think it's a bunch of cells working together for a common goal, to complete a common function. That's tissues. They come together. Cells come together. Okay? They're not separate. They come together and make tissue. Okay? Then we have organs. So now it gets pretty easy here. Okay? We know this kind of stuff. Organs, think of the heart. An organ system, think of how the body can maintain someone's blood pressure. What is that? Part of the cardiovascular system. Right? Pretty cool, right? So we have blood vessels in that system. We have the heart. So the heart would be the organ, but the blood vessels, that entire system at play, is the cardiovascular system. Okay? Now the final piece here we have is the organism. That's us, the human. There it is. This is the levels of organization. I'll see you in the next video. What exactly is homeostasis? Maybe you heard the word before, but you're maybe unsure what it means. There's some key terms here we got to know about when it comes to anatomy and physiology, when it comes to homeostasis. And it's one of the core things you have to know about. So here's homeostasis. Quite simply, it is the stable internal environment in the body. Now, that's the definition of it, okay? So if you see it on a test, that's what it is, okay? Now let's talk about how this all works. So throughout the body, you'll see the terms here. Let's just do the terms first. Homeostatic regulation, okay, is the umbrella term that involves all this down here. Receptor, control center, effector, negative feedback. We're going to talk about that. So let's start with the first one, okay? Homeostatic regulation. What that involves is the body's way of keeping itself in homeostasis, using these principles down here, okay? Now here's the first principle, the receptor. So there are receptors in the body, all throughout the body, and they're placed, and we're going to talk about later on in this course. There are receptors placed throughout the body that react to a change in the body or a stimulus in the body acted on that receptor. It picks up on it and then passes that information to that receptor's control center. Okay? That control center then processes the information and then passes that on to the effector. Okay? Which is going to basically take action on what's going on. Now, where every student gets messed up with these terms is negative feedback. All it means is the body's automatic response to any changes with homeostasis. That's negative feedback. To take action when things go awry automatically through this system right here that we talked about. Okay? Watch this video over again until you have it down cold, and we're going to move on to the next video. Hey everyone, welcome back. We're going to talk about organ systems. We have to understand these, so when I say an organ system, you understand at a basic level where I'm going with it, okay? This is our intro phase. Let's talk about it. So I want to introduce to you the organ systems in the body. The first system is the integumentary system. So what we're going to talk about with that is our first barrier of defense against anything that might infiltrate our body, okay? That's our skin system, all right? Now, you're probably wondering, Evan, you have everything grouped up here in these weird groups. This is the mnemonic, the way I want you to remember it. So when they say, hey, can you label all the systems? You know a system in your head to get it down on paper, okay? Now, here's the next thing. We have skeletal and we have the muscular system. So skeletal is like the support system. We don't have any bones, we're just going to fall on the floor. So the skeletal system is our support system. It keeps us where we are. Now, to get us into locomotion, to get us to be able to move and be active, we need the muscular system. Okay? So, when you think about a human body, what do you think about? What's the first thing you think about? We need skin, we need bones, we need muscle. These three systems go together. I call them the big three as far as organ systems. If we're going to be a human, we got to start with those three. Okay? Now I want to move over into what I call the three highway systems. Because if you see what they look like highways or pathways throughout the body. But they all do different things. So let's talk about it. So first is the nervous system. The nervous system is the first action, if you will, to any sort of stimulus in the body. Anything happens, good or bad, the nervous system is going to take action on it. It's the response center for the body, okay? It regulates things. That's the nervous system, okay? We have obviously the central nervous system, right? Then we have other nervous systems we're going to talk about. That's for later chapters, but I just want to plant it in your head, okay? Now, here is the cardiovascular system. That is basically the highway system in your body. It includes arteries. It includes veins, okay? It includes the heart, obviously. We're going to talk a lot about this system. It's very important inside of EMS. Now, the lymphatic system, ooh, you might have, what does that even do? Okay, maybe you're thinking that right now. What the lymphatic system does has to do with preventing disease and stopping infection. So, I told you earlier, our skin is our first barrier, but what if something happens to us? That's our immune. That's inside of the lymphatic system, okay? We're going to talk about that. Now, remember, these three here are together because they're highways throughout the entire body. The nervous system, the brain, the spinal cord, the cardiovascular system, all the arteries and veins throughout our body. The lymphatic system is in a lot of different places in our body we're going to talk about in later chapters. Something to think about there. These are the highway systems. These are the big three. We don't have these, we're not a human. Right. Now let's talk about these. Respiratory and endocrine. Why are they together? Well, it's a drug called epinephrine. And when I think of epinephrine, well, epinephrine basically originates, its home is in the endocrine system. Okay, we think about the adrenals. Okay. Now, with respiratory, the first thing I think about is epinephrine. Because I think about an asthma attack patient or an anaphylaxis patient, they can't breathe. I think respiratory. I think beta-2 receptors. Oh, what's all that stuff? We're going to talk about it later on in chapters. But these two are together because it reminds me of the drug epinephrine. The respiratory system, we exchange air, oxygen, carbon dioxide. We're going to talk about that, and it involves in our body and our bloodstream. But think about respiratory as the air system, okay? We need oxygen, carbon dioxide going on. The endocrine system, that is a long-term regulation of hormones in your body. When people have messed up hormones, it's got to do with the endocrine system. There's a lot of different hormones. We have thyroid. We talk about the adrenals, pituitary, pineal. We're going to talk about them in the different chapters. But when we talk about glands, we talk about different hormones. It's probably the endocrine we're talking about. We'll talk about that later on. Okay? The digestive system. Now, with the digestive system, I've paired it up with the urinary system. Why? Digestive, we think of eating. Urinary, we think of drinking, right? And then we have to get rid of that stuff eventually, right? Take the nutrients and put the stuff to waste. They are friends, okay? So, digestive, that's going to be the entire process of us bringing nutrients through the GI tract. Okay, the urinary system is about excreting waste, okay? Getting it out of our body. Now, the final piece is, well, what are we talking about here? Well, we're talking about the human. Well, we're talking about humans. There's male and female reproductive systems in every single human, right? That's the final piece, is the reproductive systems. So if you're male on one side, female on the other side, two separate systems, of course, and that's what we have here, my friends. Pretty cool? Welcome. Hope you enjoyed the organ systems. I'll see you in the next video. Good work. As we're moving on here, we're now getting into talking about the atom. The first thing we need to understand is the atomic structure. Now, I've put some pearls, some notes here on the board that you absolutely, when you do A&P, you're going to be tested on in class, guaranteed. So these notes are on the board here. We're going to start with the basics, okay? Let's start with these three things. Inside the atom, which we know, okay, remember our organization video, is the smallest form, is our atom, right? At the molecular level, the chemical level, okay, is the atom. First, the charges. So protons are inside of the atom, inside the nucleus, and they are positive. So the P in protons, remember, you're positive. Now, electrons are the opposite of protons. So protons are positive, electrons got to be negative. But you got to remember, there's one more thing inside that nucleus with the protons, and that is the neutrons, which are neutral, okay, a neutral charge, and represented by this little 0 over here, okay? So, protons positive, neutrons neutral, okay? Electrons negative. Remember, these two are at odds with each other. That's how you remember it, okay? Start with protons, say, which one's the negative? Oh yeah, electrons, they're the ones that are against. And then throw in your neutrons as neutral, like a neutral army in the middle, okay? So here we go. Now here, over here, I've drawn an element for you, helium. You can see what it looks like. So here we go, inside the nucleus here, we have PP and N, and then the electrons are out here. We're going to talk about this shell, the electron cloud or shell over here, okay? Kind of like rings on a planet, okay? But we're talking about an atom here, okay? Now, here are the pearls that you got to know. And we're going to talk about the shells at the end, okay? Now, first pearl I got here is the number of protons. It's the first pearl. If you get asked, what does the number of protons represent? That's the atomic weight, okay? Number of protons, atomic weight, okay? Hey, well, what's the other thing I got to remember? It's something else right here. What's the number represented by protons and neutrons? The mass number. So atomic weight, protons by itself. Atomic weight, protons by itself. Hey, what's a mass number? Well, a mass is like getting everything together. Well, we're getting everything inside the nucleus together, protons and neutrons. There it is, okay? So center of the atom is called the nucleus. We have that down. Now there's another pearl I have for you here. You're going to get asked, what holds the electrons? The electron shell. Out here, I think about it like Saturn, like the planet Saturn. You have like the middle, the planet, and then the rings. That's the way I think. This is how I remember it, okay? Whoa, another pearl. Isotopes. What is an isotope? An isotope, okay, let's say, here we go. Let's say I have, for example, let's say I have carbon over here, okay? And then I have carbon over here, right? Or helium here and helium here, right? But there's something different. This is an isotope. What's different about this isotope? The number of neutrons, which makes the mass number different. That's it, okay? So that's how we get into all this. And here's the final piece. What's the deal with this electron shell? They're probably going to get asked the following questions. Let's say you have an element, right? Now, I'll tell you one here, for example, right? Let's say you have an element, neon, for example, right? So neon has 10 electrons, okay? If we're going to place them, the first ring in the electron shell can hold 2 electrons. The second ring can hold up to 8. So if I was going to draw a neon, I would put 2 in the first ring, like helium has 2 in the first ring. And in the next ring, I'll put the other 8. Now I have my 10. And there it is. These are the pearls you got to know when we're talking about the structure of the atom. See you in the next video. The first thing you have to know about chemical bonds is atoms that have the electron shell totally formed. Those are very, very stable. Now, if there are still spots remaining, meaning there's still electrons that can be moved around or placed in, that's unstable, but they make great pairs. So think about it. You're an atom out there and you're going around and you don't have your electronic shell fully formed with electrons. You're looking to partner up with somebody else. These are bonds. We're going to cover ionic and covalent bonds, okay? So let's start with first, what are the different ions? First is a cation. It's positive. Anion is negative. So you talk about ions, remember that. So positive and negative, the attraction links together. So here's the formation of an ionic bond. First, you have the formation. Hey, we're gonna link up, okay? Then from there we have the attraction. Okay, the formation starts with, for example, with sodium chloride, the sodium says, hey, here's an electron. Now you're good. Okay? So now they're attracted with positive and negative forces. And then we have sodium chloride. Okay? So there's an example for you. Another one here is magnesium sulfate. Okay? So when ionic bonds, it's going to be a switching of electrons to make it whole. Okay? Now with covalent bonds, it's different. So ionic, we're giving up. Covalent, we're together. We're bonded together. That's a covalent bond. So there's very simple. There's two types. If the two atoms are going to share an electron, right? They're going to share a pair. The single pair, it's a single covalent bond. They're sharing pairs, sharing one pair of electrons. If it's a double share, meaning we're going to go back and forth and we're going to share two electrons, that's a double covalent bond. That's all it is. Single pair, single, double pair, double. There it is, okay? So the big key here is covalent shares, ionic gives it up. There it is. I want to talk about inorganic versus organic compounds. This is very important when we're going through this section of A&P. Now, how do you tell the difference between organic compounds versus inorganic compounds? Compounds coming together. How do we tell the difference? We tell the difference very simply by this. Organic compounds, right here, they're always going to include both carbon and hydrogen. Okay, they're going to include both no matter what. Whereas an inorganic compound will not always have carbon and hydrogen. It will not have both of them. Okay, so important. So all you got to remember is organic compounds always have both carbon and hydrogen. Where inorganic, that's not true. It's not true. They're going to talk about acids. They're going to talk about bases. They're going to talk about pH, all that stuff. So what acids do is acids isolate and break down, release the hydrogen to stay positive and to be inside of that acid that gets formed. Okay? What a base does is it basically eliminates the hydrogen from being positive. It eliminates it from the outcome of the base. So if you look here, I'll explain to you. So here's the acid, right? So here we have HCl, okay, hydrochloric acid. When it breaks, here it is, okay, H positive, and there it is, the chloride. You can see it here, okay? Now here's the base, right here. Here we are, here's the base. And we can see it here. And look what happens over here. See, it becomes negative, the H. So that's the biggest way that I remember it, okay? The base says, I don't really care about the hydrogen. Now you're going to turn negative. Okay, you're not even going to be in the equation. Where in an acid, it says, yeah, you're going to stand alone on your own. You're going to be a part of this one. That's your assets. Okay, pretty cool. Now down here, real simply, my friends, is your pH. So the pH goes from 0 to 14. Always remember that water is 7 on your pH scale. You know, hydrochloric acid, for example, is 1. Okay, it's a really, really bad acid. A lot of the household cleaners end up being bases, for example. Another thing to keep in mind, my friends. So we went over inorganic. Now what about organic compounds, right? Organic, yeah, I know 4 things. How many? 4 things. There's lipids, there's carbohydrates, there's proteins, and nucleic acids. That is how you remember what's an organic compound. Those are the main 4 you gotta know. A quick pearl I want to give you about organic while we're here is many of them are soluble in water. That could also be a test question. See you in the next video. Inside this video right here, we're going to start talking about the cell membrane. Very important topic, and you will get quizzed on it inside of A&P class. So let's prepare for that, okay? Now, there's 2 types of fluid. You have the extracellular fluid and the intracellular fluid. Okay, so it's very simple. There's fluid outside the cell, also known as the interstitial, okay? So also, then they have the fluid, we're going to talk about what it is, inside the cell, intra. Now, here's what I want you to remember, okay? I've written a few things out. Let's go through them. So first, what is the cell membrane? The cell membrane is the barrier, like the gate, around the cell, if you will, okay, that keeps the extracellular fluid out of the cell and the intracellular fluid in the cell. Now, here's a key point. The cytoplasm, okay? The cytoplasm is the contents inside the cell, okay? I'll say it again. The cytoplasm is the contents inside the cell. But what exactly is inside of the cell? Let's talk about that, because it's divided into 2 different things, okay? So here it is. The cytosol, okay, the cytosol is the liquid inside the cell, okay? Now over here, you have the organelles. So the organelles is the intracellular structures, okay? Now these structures right over here can be non-membranous or membranous, okay? Meaning membrane, no membrane, okay? Now we're going to talk about these structures in a second, okay, in the next video, but this is so key. You got to understand this first. I'll see you in the next one. Membranous organelles. Now remember, these organelles, like the non-membrane ones, they're all inside the cell, inside of that cytoplasm, okay? So let's talk about, I'll go over all the notes here, we're going to break all these down, okay? So let's start from the first one here, okay? Now this right here is the endoplasmic reticulum, ER. Now there's rough ER and smooth ER. You're going to see a video here at some point talking about labeling. You're going to have to label a cell, the entire membrane and everything inside of the cell and all that stuff, okay? Now, the easiest way to remember the rough or smooth ER is that the rough ER has ribosomes. The smooth ER doesn't. And it looks much different. It looks like little black dots on the diagram. So that's how the easiest way to remember that. Now, what does the endoplasmic reticulum actually do? Well, we talk about it here, okay? You see my little note about the rough and smooth. Now, it provides intracellular storage and transport. And also synthesizes proteins, lipids, and carbs. That's your ER, okay? So now I'm going to move down to the Golgi apparatus. Now, there's one thing to know about the Golgi apparatus. It forms lysosomes. So that's what you got to know about the Golgi apparatus, okay? You'll see that also on the video. We talk about labeling. You're going to have to do the labeling, so I'll get you ready for that too. Now, here are the lysosomes. Now, what do? The lysosome's job, put this in your brain. You're going to have to listen to this video over and over to remember it. Lysosomes, what they do is they get rid of damaged organelles. Lysosomes get rid of damaged organelles. Okay, mitochondria. Everyone knows, everyone in your family knows. It's the powerhouse of the cell. Everyone talks about that. It's that. Why? Because it has to do with ATP. It produces 95% of the ATP, the energy for the cell. Okay. Now down here, I need to show you this here. Nucleus and the nucleosis. Now, the bottom here, I'll start with the nucleosis. This is the one that synthesizes RNA. The nucleus has all the genetic material, okay, and is basically the control center. It controls the metabolism of the cell. Okay, so now we're going to talk about non-membranous organelles. Remember, organelles are inside the cell. The structure is inside the cell. Let's break them down. These are the non-membrane ones. Okay, and here they are. So first is the cytoskeleton. Okay, the cytoskeleton, I want you to think strength. I want you to think support, like the skeleton in our body. The cell inside has a skeleton too. Okay, so what it does, it enables movement of structures to move around inside the cell. Okay, now here's the microvilli. This is going to be very important when you're doing your labeling, and you'll see that video here when I talk about it. When you look at it, the cilia is very large, and then just to the side is the microvilli. The microvilli looks like a mini cilia. That's what it looks like. It's a little bit different stuff going on with it. We're going to talk about it. But it looks like a mini cilia. That's how I remember it. That's how you're going to remember it, okay? So it's micro, so that's how I remember it, okay? The mini cilia, basically. So what it does, it is going to facilitate the movement of stuff from the extracellular, and that's how we can move in and we can get into the place where it's absorbed inside, okay? The cilia is going to move materials from on the cell surface, okay? What it does. Ribosomes are going to synthesize proteins. You're going to want to replay these videos over and over until you have it down cold, so I'll say it again. Ribosomes, think proteins. You're going to get asked about that. It synthesizes proteins. Now finally, we have the proteasomes. These proteasomes, what they do is they break down any damaged intracellular proteins. That's the job of that last organelle. My friends, see you in the next video. Keep listening. Great work. Diffusion is the movement of molecules from a higher concentration to a lower concentration, depicted right here. Higher concentration to a lower concentration. Okay, now here is some keynotes we're going to go over on this. Now here's the first one. I'm going to read it to you. How does the ionar molecule move into the intracellular? Okay, there's There's two ways that happens. Number one, it moves across the lipid portion of the membrane. The second one is passing through the channel protein in that membrane. So there's two ways it does that right there, okay? Now here's the last piece. So if I was to define osmosis, here it is here. It's the diffusion of water across the membrane, as you can see right there, okay? Now here, let's talk about the three solutions, okay? Now I'm gonna get out of the way, I'm gonna step in here, okay? So let's say we have a red blood cell, okay? And we have that red blood cell, when we put it in an isotonic solution, that means that everything is equal. Isotonic is another word for equal, okay? So the red blood cell stays the same, okay? It doesn't swell, it doesn't shrink. A hypotonic solution means there's more water in that solution. That's what that means, okay? As you can see here, there's a higher water concentration. With a hypertonic solution, there is a higher salt concentration. Higher salt concentration, hypertonic. So you're gonna get on your test. This is why I'm preaching all this. These are the buzzwords, like all these videos are, for your exams that you're gonna have on A&P. Isotonic, everything's equal. Hypertonic is when you're going to see that red blood cell shrink up. Hypotonic, red blood cell is going to swell up. There's what it is there. This is the first part. We have more to talk about. Active transport and passive transport. You're going to hear these buzzwords when you're taking anatomy and physiology in your class. Now, active transport requires ATP. Active has an A in it. ATP has an A in it. That's how you remember it, okay? ATP is the energy inside of the body. So active transport requires ATP, requires energy, okay? When you hear the word passive, what do you think of? There's no energy. It's effortless. It's easy. Passive, no ATP, no energy. Now on the board here, I'll back up here. I've put examples of active transport versus passive transport. This is also going to be on your exam. So you want to replay this video again so you know it cold. Now here it is. On this side, active transport, we have ion pumps, sodium-potassium pump. Also, I want to bring it up, the little star here. Carrier-mediated transport can be passive and it can be active. So that's a weird one. It's in the middle. So remember that. Carrier-mediated transport can be yes ATP and no ATP. So it can be both, okay? Now over in passive land, we have diffusion, osmosis, filtration, and yes, the carrier-mediated transport. Now, a single cell by itself cannot do every single job that needs to be done in the body. So cells have a job to do. So here's what they do. The cells, they all have a specialty, right? Like, like a doctor has a specialty. So with the cells, when they're specialized, they come together to form tissues to get the job done that they need to get done, right? So that's tissue. So every cell is different, and specialized cells come together to form tissues to get their job done. What exactly is the epithelial? You're going to hear that. What is the epithelial? So this is a function of the epithelial in the body, okay? So first, provides protection. 2, controls permeability. 3, provides sensation. And here's the big one, 4. We're talking about specialized secretions. So in the next video, we're going to talk about stuff about exocrine, endocrine, and we're going to talk about that and how the epithelial and what that has to do with other glands, stuff like that. Now here's what I want to tell you in this video right now is when we talk about specialized secretions, we're talking about gland cells. So this is my little intro here to our little section on tissues and the epithelial. Epithelial. So here it is. The epithelial are layers of cells that cover internal and external surfaces. For example, the GI tract, the respiratory tract, for example, okay? It's epithelial. Now, glands are made up of secreting cells, okay? So glands in the body we talk about. Thyroid gland, right? Pituitary gland, right? We're going to talk about that later on in this A&P, okay? Now down here, when you go into class, they're going to talk about exocrine versus endocrine. What it has to do with is it has to do with secretions being released onto the epithelial itself. While down here, endocrine, that is when the secretions are released into the tissue fluid or blood. That's when we have hormones released from pancreas, pituitary, thyroid, to name a few. That's the major difference. It's going to come up. So I'll say it again. Exocrine, directly on the epithelial. Endocrine, nope, that's into the blood and the tissue fluid. There it is. Classes of the epithelial. You will get quizzed on this. Now here's the first part. We have simple versus stratified. That's the first level. So we look at the epithelial. Is it simple or is it stratified? That's the first step. So simple is a single layer of cells. It's a very thin layer. So it's really only used in internal surfaces, for example, blood vessels, not on the outside. Now outside epithelium, that's over here. It's stratified. So with stratified epithelium, there's several layers of cells. Think like in the mouth or the skin, So it's more exposed, right? So inside, more exposed. Simple inside, thin layer. Stratified, several layers on the outside or a sensitive area. Of the epithelial, there's 3 subtypes you need to know. The first one here, we can see squamous, is thin and flat, the nucleus in the thickest part, okay? Now, the second piece right here is basically like a cube, but it's hexagon style, and the nucleus is found centered. The final piece is in column form. So the epithelial is shaped taller and more slender. Actually, the epithelial is actually 2x of the actual size of the nucleus. So when you look at a picture of it, you'll see that it's very easy. The column one is very tall and slender. The hexagon one, that's right in the middle. And then the one that's thin, flat, almost like a fried egg, that's right here, squamous. So these are the main parts. These are the subtypes. So there's simple squamous, simple cube, simple column. Then there's stratified squamous, stratified cube, stratified column, depending on where it is in the body. And there it is. These are your classes of the epithelial. Hey everyone, welcome to the integumentary system, also known as the skin system, okay? That's the way that I remember it. Now, what we're going to talk about here is the baseline terms and definitions you need to know about this system. So let's start with that, then we're going to get a little more complex and break things down in future videos. So here we are. So this system, I want you to think of skin, hair, nails, and some glands. So I'll say it again. This system, think about skin, hair, nails, and some glands. What we're going to talk about. Okay. Now we start with the cutaneous membrane. Okay, the cutaneous layer, if you will. Okay, think the skin. If I say what's cutaneous, the skin's cutaneous. What's subcutaneous? Below the skin. So remember, in medicine, epi means above, and sub means below. So check this out. This cutaneous membrane, this layer, is composed of the epidermis, which is composed of superficial epithelium. We talked about that. Remember that last chapter? Okay. Now, here's the next thing we're going to talk about here. The epidermis. Epi means above. That's how you remember it. Okay, the epidermis is our skin, essentially. Okay. The dermis is the underlying connective tissues. So that is the epidermis and the dermis. That is still comprised of the cutaneous membrane. Down here is subcutaneous layer. This subcutaneous layer is attached to the muscle and the bones. Now some people might say, oh, that's not really part of this system. It is, because we have to have a connection point there, so I'm going to include it in this little series, okay? Now down below is, if you get asked, what are the accessory structures of this system? Right here. Hair, nails, and exocrine glands. Not endocrine, different system. Exocrine glands, okay? So these are the baseline things you got to know about. Here they are. Let's get a little more in depth. These are the basics. Now I want to discuss the 5 functions of this system, okay? Now the first is protection, okay? So remember, the skin is our first layer of defense. Well, we have to defend all our glands, all our organs inside our body. That'd be nice. And the second thing is, it's that first line of defense against infection, right? We have intact skin, okay? Now 2 is temperature maintenance. So what that means is the heat exchange between you, yourself, and the environment to keep the body at normal temperature. All right. Now there's a few others on here to talk about. 3 is the synthesis of nutrients and the storage of even some nutrients. So one that comes to mind is vitamin D3. Obviously, people know we get that from the sun, and it's absorbed through our skin. That's a big one, okay? Number 4 here is sensory reception. So if you feel a pain, if you feel a pressure, that's the first thing that you're going to notice in that system. The fifth thing here that we're going to talk about is excretion and secretions. So we're going to talk later on about the glands, but remember, there are glands in this system. We're going to talk about them later, okay? Now look here. Excretion, salt and water. Secretions like glands that secrete breast milk in this system. So let's just break it down one more time. For my audio learners, listen to this. Protection, temperature maintenance, synthesis of nutrients, sensory reception, excretion and secretions. So now I want to discuss the actual layers of the epidermis, okay? We're going to break down in this video each section of the epidermis. Remember, the epidermis is the most superficial part of our skin, but the epidermis has several layers. It's not just one epidermis, it's layered, okay? Like a cake has layers, same with the epidermis. So let's talk about this first. If you hear the word strata, what it means is layers, okay? So when I say strata, whatever I'm going to say, it's the name of a layer, okay? Now, the first thing we got to know is there is a difference between thick skin and thin skin. Thick skin is found on the palms of our hands, at the bottom of our feet. Thin skin is everywhere else in our body, okay? So the skin is, if you even feel it yourself, your skin feels more thick in your hands and the bottoms of your feet. Sounds like a pretty good thing to have considering this touches everything and your feet touch the ground. So good design there, right? Now, if you look at the bottom here, this is the most bottom layer and this is the top layer, okay? So I have deepest, there's something called the intermediate layers, and there's 3 of them only in thick skin, I'm going to explain, and then superficial. So thick skin has 5 layers, okay? Thin skin has 4 layers. You can see here, this one right here, the stratum lucid, it actually is only found in thin skin, which means if I put my arm here, and I don't know if it's going to work, you're going to kind of block a little bit, but this one right here would be removed, right here, the stratum lucid, for thin skin. So there's only 4 layers in thin skin, and there's 5 layers in thick skin. So I'm showing you all 5 here like it was in the thick skin. Make sense? If it doesn't make sense, repeat this video over again 2 or 3 times till you have it. Okay? The thing is, I like to give things nicknames so you don't get so caught up in trying to pronounce the word or get so caught up in trying to understand the word, where instead you can remember what you need to remember to understand it. So, give it a nickname. If I think about the base level, I then think, well, I have to have a spine level. This looks like spine. Then you got to remember here, the gland is right in the middle, okay? This is where all the keratin production is, okay? Now, what is keratin? Keratin helps things grow, like your hair and nails. That's very important, okay? Now, the stratum lucid. Well, you're lucid because it's not there if we're talking about thin skin. It's only there in thick skin. That's how you remember it, okay? And the stratum corn here, this top one, you just got to know that that is the final piece. Now, most of the times they'll give you a word bank on this. That's the way that I remember it. So hopefully that you can use those little tips and do your own mnemonic as well. But I hope that that was a good way for you to remember these new words. Pretty cool? See you in the next video. It's going to be on the dermis layers. This video here is going to break down the dermis layer. This is very simple. With the dermis, there's 2 layers. But I don't want you to forget this. Is the dermis part of the cutaneous or the subcutaneous? No, it is the cutaneous, okay? So remember, the epidermis, we talked about in the previous video, the dermis are part of the cutaneous. So we're not in the subcutaneous layer yet. Students get this tripped up, so don't forget. Dermis is still cutaneous. Now, there's 2 layers of the actual dermis, Okay, now here it is. We have first the papillary layer. This consists of capillaries, nerves, and supports the epidermis because it's the closest to it. Now, the more deeper layer, remember, it basically supports the epidermis. This is going to connect the dermis, the reticular layer, is basically fibers that connect to the subcutaneous. How do we get from the cutaneous to the subcutaneous? This right here, this layer right here, okay? So those are your layers of the dermis. Let's talk about some more stuff in the subcutaneous in the next video. So now we're at the subcutaneous layer. The most important piece of the subcutaneous layer is that this layer connects essentially our skin system to our bones and muscle. If you just remember that, you're in a great spot. But let's talk about some extras, okay? Now I'm going to read all this off for you, okay? Now, the nickname is the hypodermis. Hypo, below, so hypodermis, okay? Connects skin to bones, muscles, vessels are inside. Some large vessels that can go through the subcutaneous, something to know about, okay? Now, there's a lot here about fat cells and subcu fat and all that. Let's talk about that, okay? So, subcutaneous fats, okay, could also be called adipose, okay? That might be another word you might hear, okay? When you are a baby, when you're a very young baby, okay, you know they say baby fat and the kids, like, they look so fat. It basically protects them from kind of the rough activities they might encounter when they're young. Once you hit puberty, you start to lose that baby fat. So men will get it in a different area than women will, okay? If you think of the areas of fat, a man versus a woman, that's how it gets spread out, essentially, throughout puberty, right? So men might be here on the neck, for example, right? Where a female might be on the hips, right, for an example, okay? Where that subcu fat goes to, okay, where it lives, okay? Now the last piece here, just to remember, is when we think about the subcu, do think about fat cells, because that's part of it, but also remember that those fat cells are an energy reserve. There is one final piece I want to remind you about the subcu, is you could have a subcutaneous injection. So there may be medications that you could give subcu. Now in EMS, they're not very common. They were years ago, like let's just say 15 years ago. They may have had subcu 15, 20 years ago. But now everything is basically into the muscle, IV, IO, different stuff like that. But just know that in medicine, there are subcutaneous injections. It's subcu. I'll see you in the next video. Remember at the beginning of this series, we talked about glands, and I said it's exocrine glands. Remember, we're not talking about endocrine, totally different. Exocrine, totally different. So in this system, there's two types of glands. There's oil glands and sweat glands, okay? Now these oil glands secrete something called sebum, which lubricates the hair and the skin to help inhibit bacteria from growing, okay? So that's the big thing about the oil glands, okay? Now here's the thing though. These glands right here, this also can be where acne is formed if somebody has a larger than normal gland, okay? So this is where acne is formed right here, okay, the oil glands. Now down here is, we talk about sweat glands. So sweat glands, there's two types. The type right here, which are on the armpits, the groin, and also near the nipples. Then secondly, the merocrine is more widespread throughout the body. So not much to talk about here, but pretty simple, is the one with the A, remember armpits, that'll make you remember, okay, so we have the armpits, nipples, groin. Essentially, these sweat glands, if someone has body odor, this is what it comes from. Okay, these sweat glands produces that odor. Okay, so that's another way to remember sweat glands, body odor. There it is. Welcome to our skeletal section. What we're going to be talking about in this video is the 5 main functions of our skeletal system. Now, this is the cornerstone of understanding this topic. Now, here it is. So first we have support, okay? What I mean by support is the skeletal system is the framework of our entire body, okay? So it connects soft tissues. It's very, very important, okay? And organs as well. Now, 2 is storage. Now, what do I mean by storage? Well, 1, as a mineral reserve. We're talking about calcium. We're talking about phosphate ions inside of body fluids. What's the second piece? Well, there's something called yellow marrow. A yellow marrow acts as an energy reserve of lipids, okay, the body can use. Yellow marrow, energy. Now, number 3, you can see right here on the board, we talk about red blood cell production. That's red marrow. So blood, think red, that's red marrow. Yellow marrow, that's lipids. Ooh, that's like fats. That's yellow, right? Yeah, there it is. Okay, so the red marrow, that section when we talk about bones doing red blood cell production, they can also produce white blood cells too. Okay, now why is that important? We obviously know red blood cells has to do with oxygen. Okay, now here's, I think, the most important piece. Okay, these are all important, but let's talk about protection. So the ribs protect the heart. The skull protects the brain. The vertebrae, which is another word for bones, that protect your spinal cord. Your pelvis protects your digestive system. And, okay, especially for the female patient as well, we talk about reproductive. Exactly. Now the 5th piece is very simple. Every time I move, where I'm using leverage, movements, positions, it could be a powerful movement or a slight movement, it's your skeletal system. So these are your 5 right here. Now I'll go through them again for my audio listeners. Support, storage, blood cell production, red blood cells, white blood cells, protection, leverage. There it is. The structure of the bone. But at first, before we do that, I needed to find something so you understand these new medical terms. So the word bone is another word for osseous tissue, okay? So later on we're going to talk about intraosseous. In medical terms, that means into the bone, okay? Intraosseous. So you can see here, bone equals osseous tissue. So if I say, that man broke his osseous tissue, that man broke his bone, okay? Now over here, if I was to walk up to you and say, what is bone made of? Well, about 2/3 of bone is made of calcium. The other 1/3 is made of something called collagen and other types, but the majority is collagen fibers, okay? So, if on a test question, what is bone made of? Calcium and a little bit of collagen, mostly calcium. Now, I got some buzzwords over here. I want to talk about, there's 4 types. How many types? There's 4 types. We're talking about types of bones in the body. First type is a long bone. So a long bone would be like a femur, would be like the humerus, okay? Hey, where's that at? Well, femur, okay? Humerus is in your arm. Femur, okay, cool. All right, now, longer than wide is a long bone, okay? We said the humerus, femur. Short bones are equal in length and width. There's no difference. So that would be like the carpal bones and the tarsal bones, okay? So think about like your ankle, that section, okay? Very cool. Next here we have flat. So flat bones are thin. For example, we're talking about the parietal bone up in your skull. That's a thin bone. What about ribs? Another thin bone. Now the last piece here we're going to talk about is irregular. So these are complex bones that don't have any other place out there. If you tell me a complex bone, that's a vertebrae. So there it is. Okay? The vertebrae in your spine is a complex bone, which makes it an irregular type. Doesn't fit anywhere else. It's a vertebrae. Okay? Here are some buzzwords I want to go over. So if I say, what's bone marrow? Okay, we talked earlier on, yellow marrow, red marrow. Bone marrow, what that simply is loose connective tissue inside the bone. That's it. Okay? Now, if we look here, okay, we're talking about other different types, okay, of bone. Is it compact or is it spongy? Well, compact is solid, okay? Spongy has different spaces in between. That's it. So if you hear that buzzword, now you know what it is. So here it is here. These are your structures of the bones. I'll see you in the next video. Now, one thing that I want to discuss is when we hear the term intraosseous, maybe you've heard of the word bone drill. Maybe you heard of an IO needle or the IO drill. You're probably wondering, what? How does this work? How do we put fluids, how do we put medications into someone's bone and give them medications? This is very important. So the intraosseous, remember, in the last video we talked about osseous tissue is another word for bone. So intraosseous, into the osseous, into the bone, that's the IO pathway. And IO is used only in emergency situations. So let's say you have a patient, they really need a medication badly, but you cannot get an IV, or there's no time to mess around and get an IV. Cardiac arrest is a great example, okay? There are other situations, but that's the most common, cardiac arrest. Now, you can see here that large bones are very vascular. Now, there's 3 large bones we're going to talk about. How many? 3. Okay, number 1 is going to be the humerus, okay, up here. Okay, number 2 is the tibia, so down here, okay. And then number 3 is the sternum. Now, that's more military, but in an emergency situation, you could use a sternum. It's not usually recommended in EMS. Usually in EMS, it's going to be humerus, it's going to be tibia, okay, as your routes. Those are the large bones that can accept fluid. Now, here's how it works. I'm going to show you, so check this out. I'll try and zoom in here. Here's the IO needle that enters the bone, okay? Now, there's something called a medullary cavity, which is right here, okay? So think of these little capillary networks in here, okay, that are collecting the fluids. You can see here the medullary sinusoids. What they're going to do is they're going to collect that fluid, that medication, and bring it across the other veins and bring it right here to the central venous channel, which is going to bring it into central circulation, like an IV. Pretty cool? That's how the IO works. We're putting that needle right into that bone marrow, which ends up being right here into the medullary sinusoids. Right in there. That's how you do it. Right into central circulation. See you in the next video. Cool video coming up. Now we're going to talk about the actual skeletal injuries. So first we have sprains. So as you can see here, a sprain, what it is an overstretching, or if it gets really bad, a tear of a ligament. Could be one or more ligaments that cause an injury, okay? Second piece here we're going to talk about, you can see on the screen here, is a partial dislocation. That is called sublimation, okay? Now, so what that is simply a partial dislocation. An actual dislocation is a complete dislocation of the bone from its joint capsule. Most people think about a shoulder dislocation, okay? Now, we talk about spinal trauma. That's where this partial dislocation comes in, a lot, okay? Now, a fracture is a breakdown of the bone structure, the integrity of the bone. Now, there's two pathways of fractures. One is you have a healthy bone, trauma comes in, okay? That could be a fracture. Now, the second piece, what if the bone is just weak by default? Could be cancer, could be osteoporosis, right? There's patients that we're just walking around, there's no trauma, the bone breaks because the bone structure was just, it wasn't integral, it wasn't strong. So those are your two types of fractures. Now, we're going to talk in the next video about the actual types and grades and everything like that. We're going to bring up sprains. We're going to bring up fractures. Stay tuned. There are 3 grades of sprains. A grade 1 sprain is a minor overstretching or a very minor tear. Okay, that's going to be your grade 1. Now you can see here, there is swelling, there is pain and tenderness, but the joint is stable. Key. When you cross over to grade 2, the joint becomes to be unstable. Still intact, but unstable. Now, this is considered a moderate injury, so a moderate tear, significant tear, but the joint is unstable but intact. In grade 3, it's not intact anymore. The joint is not intact anymore. There's severe pain and severe spasm in grade 3. It's complete failure of the ligament that we're talking about. There it is. Open or in a closed fracture. I didn't put it on the board, I'm just going to tell you about it now. An open fracture is a fracture of skin. A closed fracture is, wow, there's some deformity maybe on the inside, okay? That's what we're going to see. All this stuff is on x-ray, but it's going to be in your A&P class, so we're going to talk about it, okay? So fractures, how do they know this in the hospital? On an x-ray. So the green stick fracture, I'm just going to go along with you guys here as we're going along, okay, for my audio people too. Green stick fracture is children, okay? There's 2, how many? 2. The green stick and the torus fracture, those are going to be in children. So green stick children, one side is broke while the other side is bent. Now, Evan, why are there fractures only in children? This torus and this green stick fracture? Why is that? Because of the large cartilage that children have versus adults, okay? So the torus fracture isn't even a real fracture. It's a swelling of the bone with very little displacement of bone. It's not real like a broken bone. It's just like it's swollen. It's a high level of cartilage. Remember we talked about earlier on, what is bone made of? We talked about that. We talked about the collagen fibers and the calcium. So that's the cartilage, okay? Transverse fracture goes along this way, okay, left to right, okay? Now we have here the oblique. It can't really be vertical. It's close as it can get, like a side piece like this. You can see it coming across. That's the oblique. The spiral fracture is kind of like that. It's a twisting of the bone. So it's a spiral fracture, how it got twisted. Now I want to talk about 2 types of fractures that have multiple segments. One has free bone, one does not. So let's start with the one that does not have any free bone. It's the comminuted fracture. So this has multiple bone fragments of the fracture, but there's no free bone. Now in this one, you can see down here, the segmental, that is the one that has the free bone, okay, segments. Now finally, you can see here, the last one is impacted. If you watch a lot of my videos, you know I talk about axial loading. Axial loading is when basically it's like a vertical force. Let's say you were a diver and you were diving into a pool and then your head went straight and down. That vertical force is axial loading. So what axial loading can cause is this kind of fracture right here. It's an impacted fracture. It's an axial loading event. There it is, folks. So what we're going to talk about now is the 2 major divisions in the skeletal system. You have the axial skeleton and the appendicular side as well. That is very important. Now here it is. The axial skeleton is made up of the skull, thoracic cage, and also that vertebrae, that column, which is basically our spinal column, okay? Remember, bone equals vertebrae. Remember that, okay? Now, skull has 22 bones in it. The hyoid bone is outside of that, a few other accessory bones, okay? You'll see that coming up, okay? There it is. The thoracic cage. Now, what does that entail? That's going to be your ribs. Sternum, okay, as well. Now, what's the vertebral column? It's going to be the bones of the spine, okay? Now, down here, the appendicular skeleton. What that is everything else, obviously. So your upper limbs, your lower limbs, your pelvis. And there it is, folks. Okay, so this is, right here, you can see it. These are our two main divisions you got to know about. The next video you're going to see here on the skeletal system is going to be a series of different worksheets to help you start to label this stuff. Now, hear me out here. You go into A&P class, you watch this entire course. Okay, you watch it back twice, take notes on it before you go into A&P. Okay, whether it's EMT or paramedic. Wow, are you going to be way ahead, especially with these worksheets, because you're going to have these little worksheets on quizzes, stuff like that. So you do it now, you're going to be way ahead. And if you're in class right now, speed up. I'll see you in the next video. Okay, so I want to welcome you to the next section here. We're talking about the muscular system. Now, there's three types of muscle in the body. There's skeletal muscle. We're starting with skeletal first. Later in other videos, we're going to talk about cardiac muscle and smooth muscle. There's three types of muscle in our body. We're starting with skeletal muscle. So here it is. Now, skeletal muscle, I have a few things we're going to talk about. So first, let's talk about, well, how many skeletal muscles are there in the body actually? There's 700, remember this number for your buzzword for your test, 700 skeletal muscles throughout your body. Okay, now, next piece we're going to talk about. What does a skeletal muscle do? Well, it provides us with protection, okay? So it's supporting us to maintain our posture, right? It's guarding our organs, right? It's part of the skeletal muscle is the muscle is attached to our bones, connective tissues, all that stuff, right? So this is all skeletal muscle, right? And my arms here, just to give you an idea, okay? So we talk about here how we move, maintain posture, temperature, guard and support our body, okay? Now, here's the big pearl, and I'm going to show you on here. I'm going to try to zoom in here for you, okay? There's 3 layers to the skeletal muscle. How many? 3 layers. Okay, 3 layers to the skeletal muscle. The first one here, okay, is the epimysium, okay? The epimysium here is on the outside, okay? So this is the outer layer, okay, the epimysium, okay? Now the perimysium, you can see here, the perimysium, the way it's broken up, okay, we have the outside of the muscle. This is your muscle right here. Pretend this is a screenshot of my arm muscle right here. If I cut it open, and I go like this and I cut it open, you'd see this, right? So the inner layer, right, the next layer in, this whole entire piece right here is the perimysium, right here, okay? Now, this is very important, okay? And this is where people get confused. I don't want you to get confused, so hang on here. Inside the perimysium, which is the next layer underneath the epimysium, so epimysium outside, the perimysium is the next layer down. Inside that realm, which is right there, I want you to think about individual bundles of cells, okay? So inside the perimysium, there are individual bundles, like bundles of hay, okay? Like little bundles of muscle, and it's muscle fascioles, okay? Those muscle fascioles are the little bundles. If I gave you a muscle fasciole and took it out, inside each little circle here is the muscle fasciole. These little dots that you see on the screen here, that is the endomysium. Okay? Now, new topic, might sound crazy. Replay this so you have it down cold. These are 3 layers. Epimysium, perimysium, endomysium. Remember, these are all wrapped up like hay with the muscle fascioles inside of the perimysium. There it is. Now I want to talk about cardiac muscle tissue. I'm going to start with a buzzword here. It's relatively small, and also it has a single centrally located nucleus. You hear that in a test, cardiac muscle tissue. Now, right here, it's found only in the heart. That goes by the name. You probably knew that already, but check this out. Now, the actual contraction of the cardiac muscle. And the actual contraction of the cardiac muscle is through a process called automaticity. Now, that is controlled by pacemaker cells, and that is unique and what differs cardiac muscle from skeletal muscle that does not have that. This does with these specialized pacemaker cells. Now, it's an aerobic metabolism. There's a question for you right there. There's an answer for you right there. Now, what does it mean for a muscle to get into tetany? Tetanitis is a pure contraction of the muscle, okay? And it stays like that. We don't want that, okay? Now, the heart muscle, thankfully, it cannot get into a tetany where it would just contract because then your heart wouldn't be able to pump any blood, okay? So that is good. Now the last piece here, another possible question you might get, I put some notes together here for you on cardiac muscle is this. It is 10 times longer, the contraction of the cardiac muscle tissue, than skeletal muscle. Skeletal muscle is faster. Some quick tips here, now you know it. So now we're going to talk about some quick tips with smooth muscle tissue. Now, like the cardiac muscle tissue, it also has a single nucleus centrally located, something to pick up on a question. But what else? Well, here's a big thing. Smooth muscle lines the majority of our organs. So we talk about digestive, blood vessels, lungs, smooth muscle. So you can see here, those are the big ones. Now, two pearls I want to talk about. So the first pearl we're going to talk about is this right here, smooth muscle, actually contracts the longest. Okay, has the longest time of contraction. Okay, it has to move things along. Speaking of moving things along, you're going to see probably on a test or just in general, something called a sphincter. Now what that is basically a gather, if you will, of smooth muscle that moves things along and regulates the flow. So for example, there are sphincters inside the digestive system that will stop flow, that will move flow. Something to keep in mind, this is smooth muscle. Okay, so let's talk about skeletal muscle fibers. First is fast versus slow. So fast muscle fibers, they deteriorate faster. They get tired and fatigued faster, okay? Now, the pearl here, the majority of fibers are indeed fast, okay? And the fast fibers, they use a lot of ATP very fast, which is why they fatigue so fast. Think about the muscle fiber just swung it up whole, right? Now, slow fibers are less fast to fatigue. And I'll give you some more pearls here. Slow fibers have more O2 supply and a large capillary network, and they have more mitochondria. This, put it all together, think about a sprinter versus a marathoner, right? Fast versus slow, and what they're using when they're actually doing that activity. Now, I have a story for you, but I want to talk about white versus red first. White muscles is where the fast fibers live, okay? They're kind of pale in color. Red muscles is where the slow fibers live, okay? Now, you're probably wondering, well, how do I make sense of all this? So let me explain, okay? Now, a chicken flaps its wings when it has to fly, okay? So it's using anaerobic activity. Okay, it's a fast twitch. Okay. Now, when the chicken just walks around, it's using slow twitch. Okay, it can walk for a long time, but when it's got to get in the air quick, it's got to go move fast. So that's why we have white meat in the chicken versus dark meat in the chicken. You with me? Now, what about humans? Well, our muscles are basically all pink because it's not one or the other, it's a mixture. So with humans, I put up top here, how is your muscle composition determined? It's first by genetics. You have fast, slow. You could have less of more of more, whatever it is. Okay. Hope you enjoyed that little one. And athletics is where you can actually do the best of your potential to improve on your fast and your slow fibers. There it is. All right, so now I want to talk about anaerobic versus aerobic endurance. This is a key part of your muscular system. Now, what we're talking about here with anaerobic is, very simply, and I'll read it out to you, the length of time muscle contractions, are supported by energy reserves such as ATP. Now, what does that mean? Again, that is like someone who is sprinting. That is like someone who is doing a fast movement like weightlifting. That's anaerobic. So what happens is it requires a lot of ATP and then it burns out. Okay? So that's anaerobic. Length of time contraction supported by energy reserves such as ATP. So you have this level of endurance till your ATP runs out. Okay? Over here, with the aerobic endurance, is a length of time a muscle can continue, and I circled it here for you, contracting while being supported by the breakdown of carbs, lipids, amino acids. Okay? Totally different system. So ATP, carbs, lipids, amino acids, think mitochondria. There it is. So now I want to talk about a few clinical cases you may see that involve the skeletal muscle. Okay? So here they are. Now let's go through each one step by step. You may have heard these words before, but you might not know what it is. You can't not know what it is, especially if your patient presents like this. So let's talk about signs, symptoms, and all that stuff. So here it is. So here's rigor mortis. Rigor mortis, usually, it's not a rule, depending on the temperature in the room where the body is. But if someone passed away, they go into cardiac arrest, they die. Okay? Usually about 6 hours later, they develop rigor mortis. This is why. If you go to a patient, rigor mortis is a sign of they're dead on arrival. Okay, a DOA. Okay? So around 6 hours after death, you can see the reason what happens is the muscle, let's say here's my skeletal muscles here, okay? All the glucose, ATP energy gets completely depleted. So what happens is the muscle just goes ahead and tenses up and is in full contraction. Okay, it's sustained contraction for about 12 to 24 hours. And then eventually it will relax. By that point, the body is, clearly a dead on arrival, if that makes sense. Okay? Now, next we have here is the muscular dystrophy. You've probably heard that word before. What is it? Well, here it is. Okay, it's an abnormality of that patient's gene that messes with the proteins inside of the muscle. Okay? Now, it's very progressive and it will lead to later and later and later in life, continuing on to getting more progressive with the disease and muscle weakness. Now, what's an autoimmune disease in this category of skeletal muscle? Well, this is right here, okay? Myasthenia gravis, okay? Also known as MG, some people too, okay? Now, here it is. It's an autoimmune disease. It causes weakness and fatigue, okay? What they commonly do will have a patient not in the labs, but in the doctor's office, when they go to the doctor, they'll do a chew test to see how strong their muscles are. So the final piece is rhabdomyolysis, also known as rhabdo. Now, what is that? That can be an unconscious patient or a conscious patient who is basically, they're immobilized. They're unable to move. Maybe they're pinned, for example, under a car or a fall, and they're underneath them. There's some force being applied to the skeletal muscle, which is causing it to break down and really be destroyed, breaking everything down. Now, if you look here, it has to do with prolonged time of that immobility, okay? If you're on the floor and you can't move for a long time, that could be it. If you're pinned under a car, it's the same thing because you can't move, same thing, okay? So you don't have to be pinned, but you are immobile. You cannot move for whatever reason. Now, the key here is electrolytes get released. That can cause a lot of problems. Mimetics, EKG, you'll see that. Dark red urine and kidney failure is the big thing with rhabdo. So these are our 4 things that has to do with what we're going to be learning about the skeletal muscle. Now, these are the 4 things that we need to understand with skeletal muscle. See you in the next video. Now, there are many ways to help you understand this material, but if we can understand how the nervous system actually works while we're defining what these are, we're going to remember it. So let's start from the start. Okay? There is a central nervous system and a peripheral nervous system. So I want you to think of the central nervous system as the brain and the spinal cord, which it is, and the main place that processes information. I want you to think of the peripheral nervous system as 2 parts. Part 1, the peripheral nervous system gets information from receptors and then passes that off to the central nervous system to take action on it. Hang with me, okay? Then, once the information is processed in the central nervous system, it then passes commands back to the peripheral nervous system to take action. Let me explain. Now, here it is. So we start here. Now, we're going to go through this whole journey, okay? This piece right here is the peripheral nervous system. This is the central nervous system. This left piece right here are the receptors in the body. Over here is what we call effectors. What gets affected by the commands that the peripheral nervous system is taking action on. Okay? Now hang with me. Here it is. We start with receptors. There's 2 types of receptors, 2 categories of receptors we're going to talk about. How many? 2. So here we have the somatic receptors. The somatic receptors, what this has to do with is your position in the world with your body and what impacts you from the outside. Okay? The visceral receptors is what's going on inside your organs, inside your body. So think the somatic receptors are regulating what's going on in the world around you, while the visceral receptors are inside your body, what's going on internally. Now, whether the somatic gets a hit, gets a piece of information, or the visceral receptors have an important piece of information, they pass it on to the peripheral nervous system, which is going to do what? It's going to take that sensory information and it gathers it, but it doesn't process it. It's got to pass it off. Now, there's 2 divisions, 2 parts of the peripheral nervous system, right? You could think about it as this is the part, the afferent division, gets the sensory info from the receptors, but it needs to pass it off to the smart people, the central nervous system. They process the information, okay? So that's the afferent division over here, okay? Now, when it passes it through to the central nervous system, that's the brain spinal cord. That's the smart people, okay, in the body, all right? So the CNS processes the info, but it can't take action. It uses the efferent division of the peripheral nervous system to take action. And then there are pieces, there are subdivisions of the peripheral nervous system on the efferent division side, okay? This is one division, there's another division. Just to make it clear for you, I'm going to go like this, okay? We're going like this, okay? The receptor gets a hit, pass it to the afferent division of the PNS. That's sensory info. That sensory info is passed to the CNS, where the smart people go ahead and process the info. And it's passed off to the efferent division, which has to do with motor commands. The CNS, do this. But the CNS isn't going to do it. The PNS is. Now, there are two types of subdivisions in the peripheral nervous system. You're going to see the somatic nervous system and the autonomic nervous system. Okay, the somatic nervous system, there it is. That's it. No more divisions, no more dividing. But the autonomic, in its little subdivision, breaks off again into the sympathetic and the parasympathetic divisions. Okay, sympathetic, fight or flight. Parasympathetic, rest and digest. Okay, now hang on here. If this command is going to the somatic nervous system, it's going to affect our skeletal muscle. Okay? If the command from the CNS that gets passed off to the efferent division of the PNS is on the autonomic side, well, the question is it a sympathetic action or a parasympathetic action? It can only be one of the, which one is it? And what does that affect? It affects your smooth muscle. Could be a cardiac muscle, could be a gland, it could be adipose tissue, okay? And this is the breakdown. Now, there's a lot of information here, okay? This is the best way to memorize it, not just by terms, by understanding how it works. So I'm just going to do it for you one more time, just so you have an idea. We have outside receptors, we have inside receptors. We have somatic, outside, visceral, inside. When the receptors get a piece of information, when they get a hit, they pass it off to the PNS. This afferent division gathers sensory info from the receptors. But we need someone smarter than the peripheral nervous system, so we pass it off to the CNS. That's the brain spinal cord. They process the information. Once the info is processed, the CNS says, okay, who am I giving the command to? Am I giving the command to somatic or am I giving the command to autonomic? Okay, this is the efferent division of the peripheral nervous system. Okay, this is about motor commands, commanding you to do this. Skeletal muscle goes with somatic, smooth muscle, cardiac muscle, glands, adipose goes with autonomic. Is it fight or flight response? Is it rest or digest response? There it is. So now that we understand the actual system in the first video, now I want to talk about the most basic unit of this system, which is the neuron. Okay, so I'll say it again. The neurons are the basic unit of the nervous system. That is going to be a test question, no doubt. Okay, now I've talked about this. What does a neuron look like? Later on, we're going to talk about different shapes of the neuron. Okay, these are all going to be test questions, guaranteed. Now, here's an important one. Now, I'm going to read these out. Okay, so this is what a neuron looks like. Okay, now I'm going to show you here what we got going on. Okay, so here are the components of a neuron in the nervous system. First, we have the cell body, which is right here, the cell body. This entire piece is the cell body, okay? This piece going off over here is called the axon, okay? So what the axon is going to do is the start of any outgoing activity for this neuron, okay? Now, the first piece, the dendrites, are these little pieces right here sticking out of the cell body, okay? You can see them coming out here? So the dendrites are going to take in information while the axon is the start of the out information. Okay? Now, very important. The synaptic terminals, all the way down here, okay, all the way at the end here, is the final stop for that outgoing of information outside the neuron. So, if I'm a neuron, I would have these little pieces coming out of me called dendrites. And dendrites, what they do is that's incoming information coming into my cell body. Okay. Then when I gotta go out now, right? I'm gonna move it down the axon and then move it into the synaptic terminals. There it is. Okay. Now there are a few other things in here that are not labeled, but this is the main piece. For example, you have mitochondria in here. You have the nucleosis right there inside of our nucleus. You have all that. But I just want to give you the main points here. You got to know this to understand how the neuron flows. There it is. Okay, so now we're going to talk about classifying neurons. So there's 3 types of neurons in the way they're shaped, the way they look. Okay, so the first type is the multipolar neuron. So we can see here, here's the cell body. You can see everything here. The axon going across. You can see that. You can see the dendrites here. And the movement, kind of like our classic neuron we saw in the last video. That's how it is. These are most common in the CNS and also skeletal motor neurons as well. Okay. Now the most popular one in the PNS, the peripheral nervous system, okay, is unipolar neurons, where we go straight through the axon to the terminals. And what actually happens is it goes straight through. The cell body is kind of lumped up to the side, and the impulse goes straight through the dendrites, shoop, all the way through to the terminals. Okay. Now the bipolar neuron is a little different. You can see it goes straight through. So you have your dendrites over here, through the cell body, and then we have our terminal on that side. So these are sight, smell. These are specialized neurons that you'll see. You're not going to see many of them in the body. It's the bipolar neuron. So what is the key to remember here? Multipolar, CNS, skeletal muscle, kind of like a classic neuron. In the peripheral nervous system, unipolar, goes straight across, most common. Bipolar, a little specialized. That's going to be sight, smell, stuff like that. There it is. All right, so talking more about neurons, here's what we have next. We're going to talk about the different types here. Now, I've broken this up between the peripheral nervous system and central nervous system. We're going to start with the peripheral nervous system. So on one side, we have our sensory. Remember, the sensory is the afferent division. The motor side is the afferent division. Okay? So you can see here, we have somatic sensory receptors right here that are broken up into 2 types. There's external receptors that has to do with touch, temperature, for example. Then proprioceptors has to do with our physical position in the world and our joints and our skeletal muscle. Okay? Now, visceral receptors, that's the second piece here, visceral receptors, has to do with the internal, like the digestive system, cardiovascular, reproductive, urinary, respiratory systems. Okay? The somatic, it's the outside. Remember, somatic's the outside, but it's broken up into 2 types. External, touch, temperature. Proprioceptors, position of our skeletal muscle or joints. Visceral receptors are inside all of our organ systems. Okay? Now, the motor side, we have somatic motor neurons that take the action. That's somatic S, skeletal S. They go together. Visceral motor neurons, remember, that has to do with the autonomic nervous system. Is it sympathetic? Is it parasympathetic? We'll have a video on that coming up. And then you can see down here, cardiac muscle, smooth muscle, adipose tissue, glands. That's what it affects. Now, you may be asking yourself, what's an interneuron? Well, an interneuron is only found inside of the central nervous system. Different system. Central nervous system has to do with the brain spinal cord. So interneurons are used. They're associated neurons that bring neurons together to solve big tasks, like high functions like memory. Okay, there it is. Okay, here's our final video of the nervous system chapter. It is sympathetic versus parasympathetic, talking about that autonomic nervous system that is part of the peripheral nervous system's efferent division. You got it all? Here it is. Now, sympathetic. Now, I'm going to go through these. We're going to point them out. But I first want to talk to you first. So the way that I think about the sympathetic nervous system is the sympathetic nervous system is like a man on cocaine. And the parasympathetic nervous system is like a man on opiates. You're going to see a very similar reaction when you see someone on cocaine and when you see somebody on opiates. It's kind of like how the body acts when the sympathetics turned on and the parasympathetics turned on. So just some general rules here. The sympathetic nervous system is a fight or flight response that we have when we need to get moving. We need to get going. If you're being chased by a tiger, you're going to need to have your lungs open. You're going to need to have your pupils open. Your heart rate and blood pressure need to open up. You need to be able to move blood faster, right? And we need to shut off our digestive and urinary systems. Where on the other side, parasympathetic, a lot of people talk about it like a after sex response. Oh, I'm so relaxed right now. Okay? That is the parasympathetic, right? Talk about opiates. Oh, I'm so relaxed right now. There it is. Now let's talk about it in depth. The eye. Sympathetic, dilated pupils, so I can see better. Parasympathetic, constricted, because we're just hanging out. What are we worried about? Cardiovascular. We have vasoconstriction, which causes that blood pressure to increase. Okay? The heart rate goes up, and the contractility, aka the force of contractions, goes up as well. Heart rate and BP simply go down in parasympathetic. That's it. Okay. Respirations. Why do we give meds that innervate and turn on the beta receptors, like the beta 2? We get a sympathetic response. It opens up the lungs. That's a bronchodilator. Well, when the sympathetic nervous system is turned on, our lungs dilate because we got to move. Makes sense. There's a decreasing of the diameter of the lungs. They're not wide open when we have parasympathetic. They're more relaxed. Not closing like you're having an asthma attack, just not wide open like I'm going for a run. Okay. Digestive and urinary is pretty straightforward, but we'll talk about it. So think about it. If you are being chased by a tiger, do you need to be producing urine? Nope. Do you need to be moving your bowels? Nope. You got bigger things to worry about, like taking care of all this stuff. Okay? So that's what happens here. And a point I have here too about the bladder is the bladder relaxes. When the bladder gets contracted or tenses, that's when we actually go, use the bathroom. So urine production is increased on parasympathetic. The bladder is tensed, and we increase our movement of our bowels. There it is, folks. This is sympathetic and parasympathetic. Watch this video a few times, and believe me, you will remember this for the rest of your life, not just for the test. There it is. Okay, right now, we're going to talk about the major brain sections. We're going to start with the cerebrum. Now, the cerebrum is the largest division of the brain. It deals with intellectual thoughts. Okay, so thought, intellectual, and right here we have, it deals with that sensory somatic info. So sensory info from the outside world coming into the brain. That's a cerebrum. Now the diencephalon, that deals with conscious, unconscious, sensory, motor commands. So remember we talked about how we know the brain is part of the CNS. The CNS has a processing information, but then it says, command, do this. There it is. Here's the motor commands section, okay? Now the midbrain here is going to process our visual and auditory sensations, okay? Straightforward. Visual and audio is our sound. The pons. Now the pons, part of it deals with our involuntary breathing. So, we know how that process works. We all breathe. Now over here, a big point about the pons. The pons actually connects the cerebellum, okay? It's very important with everything else. So remember that, okay? Very important. Now the medulla oblongata. The medulla oblongata connects the brain and the spinal cord and acts the track of information between, that's where the track lies, from the brain and spinal cord to talk to each other, and those tracks go through the medulla oblongata. Also, you can see here, it deals with sensory and motor function with the cranial nerves. Cranial nerve right here, you can see 8 through 12 on the cranial nerves, and we'll have a worksheet on that later on, okay? Now right here, we have the cerebellum. The cerebellum is your autonomic center and deals with balance and fine movement, okay? Now, what is ataxia? You probably heard another buzzword. Oh, I've heard of ataxia, but what is it? Well, here it is. Ataxia, what it is a state where you are basically out of balance. The most common way to be ataxic is by taking drugs and alcohol that gets you off balance, and that disturbs your cerebellum, so you're off balance. There it is. So now we're going to talk about the meninges. Now everyone hears this word, the meninges, but no one really knows what it is. No more. In this video, I'm going to break down the layers of the brain and spinal cord. Now here it is. I'm going to step in real quick, just to say one thing, and we're going to go into the layers. The brain and spinal cord need to be protected from, shock, from trauma, okay? So this is why there's so many layers that protect it, okay? We've heard other buzzwords about epidural bleeds and subdural bleeds and subarachnoid hemorrhage, all that. We're going to talk about it, and you're going to understand it, okay? Now here it is, okay? So on this side, I have the brain layers. This side, I have the spinal cord, okay? So we're going to start from the start, okay? Now the cranium, remember, the skeletal system, one of its functions is to protect. So the cranium, the skull, protects the brain. But inside of that, there's other layers to protect the brain because it's so important. Now, the cranium, the first layer is the dura mater. There's 3 layers, if you will, of the dura mater. There's an outer layer, there's the main dural, and the dura mater. So outer, the main dural, then the dura mater inner. Okay, so 1, 2, 3. Okay, now, what is the epidural space? Well, the epidural space is a space between the outer dura mater and the cranium. So there's bleeding on the outside of that dura mater, and the cranium is bleeding in there. That's an epidural bleed right here, okay? So that blood's touching the skull, okay? Now we got to roll down here. Underneath the dura mater inner is the subdural space, okay? So that's where the subdural bleed is. Sub means below, like a submarine under the water, okay? So subdural space, okay? This have the bleed underneath this dura mater. That's the subdural space, okay? Now here's the arachnoids here. We have the subarachnoid space right here, okay, as we go on, all right? That's where a subarachnoid hemorrhage is, right there. This is pretty deep in the layers here. The pia mater is right here. And then right on the side of that pia mater is the cerebral cortex, aka the brain, okay? So those are the layers. So look at all this, the way it's designed. Someone would have to get through all these layers to shock the brain or to touch the brain. If we have bleeding in here, this is really bad, obviously, because it can pull up a lot of blood, and it wouldn't be a good outcome, okay? Now, we talked about earlier, when I say vertebrae, I mean bone. Well, if cranium's bone, we know that vertebra is bone, the bone that protects the spinal cord. So we have the vertebra, then we have the epidural space, we have the dura mater, the arachnoid. It's a little more simple on the spinal cord side. The subarachnoid, pia mater, spinal cord, okay? This is a good function to remember when you have a patient with an epidural bleed, a subdural bleed, a subarachnoid hemorrhage. Now you actually understand it, not just saying, oh, they're bleeding in their brain. There it is. So now we're going to talk about nervous system infections. Now the first one we're going to talk about here is meningitis. Now, I just want you to know something. You may have heard about acute versus chronic infections. And depending on what it is, they can be acute infections or chronic. Chronic means it lasts longer than 3 months. Acute means it just happened now, okay? Just want to give you that quick tip. Now, here's meningitis. Now remember, anything that ends in that itis, okay, what does that mean? Well, it means that it's an inflammation or infection of what we're talking about. We just learned in the last video about the meninges. Those are the layers that are right in front of the brain, right in front of the spinal cord, that protect it. When they get inflamed, infected, you have meningitis. When you have meningitis, you present with fever, with headache, with photophobia. What's photophobia? Well, photophobia, it's a handful to say, is you cannot look into light. It's so bothersome for you to look into the light. Think about somebody with a bad migraine. They have photophobia too. So we talk about fever, headache, photophobia. Altered mental status is another one. Now here's two big things I want to talk about down here with the signs, okay? One more that I probably should add, the most common one, you probably knew it already. Meningitis, stiff neck. They have a very stiff neck. So there's two signs that I want to discuss. Now, these signs are present, you'll see them in about 50% of the patients with meningitis, okay? Now here it is. We have Brudzinski's sign, which is a passive flexion of the neck of the patient will cause the patient to have flexed hips and knees. So if we passively flex the neck of the patient, okay, then what's going to happen? We get a flexion of the hips and knees. Okay, that's a sign number one. Number two, down here, our second sign is the patient cannot extend their legs when their knees are flexed, okay? So these two signs, you'll get to see them on a test, okay? Whether EMT or a medic, it's right here. Those happen in about 50% of the meningitis patients. There it is. Okay, so now we're going to learn about another common buzzword that you may have heard about. What is encephalitis? What is it? Encephalitis is inflammation of your brain. That's it, okay? So the brain's inflamed. Well, that's not good. Well, how does it happen? What happens is your patient could be altered. They're going to have a headache, okay? This is a big part of the patient's history. So have they traveled somewhere, right? So we talk about mosquitoes. So mosquitoes can transmit this to humans. Now, there's other things here. Do they have rabies actively? Do they have mono actively? Are they an AIDS patient actively? These are the big pearls with knowing about this disease, this infection. Now you know about it. There it is. Our next nervous system infection, it's a pretty simple one, are brain abscesses. Again, you've heard it. Now let's understand what it is. So a brain abscess is simply an accumulation of pus inside the tissues of the brain and spinal cord. That's all it is. Now, how does this even happen? Well, here's the thing. If you have a nasal infection or an ear infection that gets out of hand, it can lead to that, okay? The second piece is trauma, okay, which is why this is most common actually in people that are 30 to 40 years old. I guess a lot of trauma happens around then, maybe work accidents, stuff like that. And the other thing that we have too here is we have surgery. So if you have a surgery being done, obviously that can cause it as well. Now, the last piece is HIV patients. There's a particular form of bacteria that can cause this for HIV patients. Just something to know about. You might see it out in the field. Could be a transfer. Now you know about it. This is brain abscess. Okay, now there are 3 types of headache that we need to know about. Now, the first one, this is the one with the aura. The aura is a migraine, okay? So a migraine, you can see here, it usually starts in the early teens. And there's usually, and it changes from patient to patient. When they have this aura, it could be a smell, it could be a taste, it could be a visual stimulus. So for example, it could be like they see lights flashing in their eyes. It also could be blurry vision. Is the aura is the sensation they feel before the event starts, the migraine starts. Now, what causes the migraine? Some sort of external factor. Something going on in the world around them. This can be so many different things, can cause a migraine. So every patient has their own external factor, and they'll know, and they'll tell you, oh, well, this happened, it's probably this, a migraine. Now, there's positive nausea, vomiting, and photophobia. Now, I want to give you a pearl when we're talking about EMS. If you have somebody in the ambulance, and they have photophobia, nausea, vomiting, because they're not opening their eyes, and they have a really bad headache, we start thinking about brain bleeds, right? We don't just say, it's a migraine, no big deal, just a migraine here, right? The patient may tell you they have a history of migraine. That's great, but we always want to treat worst case. We want to ask them, was there any trauma, any new medications, right? Did you fall? Did you get attacked? So never forget that. But you just want to understand this. It is part of your A&P to understand this, okay? Now, a cluster headache, because I'll give you one more pearl too. You may have a nurse or doctor that tells you, oh yeah, they're having a cluster headache, and you're like, you don't even know what that is. Well, now you know. That's why you're here. So a cluster headache, severe pain. It's a one-sided ache, and it lasts between 15 minutes and 3 hours. The patient will be very restless because it's so severe, and it commonly affects men over 20 years old. Now, a tension headache is the most common headache in the entire population. It's a classic headache, a tension headache. And there's no nausea, vomiting, and no photophobia. Where a migraine has nausea, vomiting, and photophobia, okay? So headache, no nausea, vomiting, no photophobia, but it affects both sides of the head, and it's non-pulsating. You can't feel that pulsating when you have a headache. We've all had a headache before, I bet. So, my friends, there it is. Let's move on to the next video. Now, as we start the endocrine chapter, I first want to do an overview of some of the buzzwords, some of the processes, some of the things you're going to see. So let's start from the start. The endocrine cells, you can see right here, okay? The endocrine cells are the base units of this system. They're actually going to be the ones that secrete into the extracellular fluid, okay? So think about that, okay? Endocrine cells. Hormones. Your hormones are chemical messengers that have a certain origin, where they start, where they're released, and they have a specific target and a certain effect on the body when they're released. And depending on the hormone, it's going to be a much different reaction from one to another, okay? It's a chemical process. Now, there's 3 types of hormones. The first type is an amino acid derivative. This is like epinephrine. This is like thyroid hormone, norepinephrine. This is like, you can see here, melatonin, okay? Now, second type, called a peptide hormone. These are short chain of amino acids, okay, a chain of them. And here's a few examples. ADH, we're going to talk about all these as we go along, okay? Just want to give you a little preview. ADH, oxytocin, growth hormone, prolactin, and finally there's lipid derivatives like steroid hormones and the prostaglandins. So we're going to talk about all these, but you may get asked, which of the following is an amino acid derivative? A peptide hormone, a lipid derivative. What is an endocrine cell? A lot of this is covered right here. You got it. So what I've done is I've put together a chart. This chart is going to break down the anterior pituitary gland hormones. There's 7 of the pituitary gland hormones on the anterior side. There's 2 in another video you'll watch on the posterior side. So here we go. So we have the anterior side. I've broken this up by the names of the hormone. In the middle, you can see here the target origin. You can see here what's going to happen. So let's break them down, okay? TSH, thyroid gland, target origin, the goal, secretion of the thyroid hormone. ACTH, its target is going to be the adrenal cortex. Right here you can see is glucocorticoid secretion. FSH, now we get a split here between female and males. Ovaries, female, testes, male. For females, we get estrogen secretion. For males, we get sperm maturation. Now, luteinizing hormone, LH, we get ovaries on one side, female, testes, male again. Here we go. Now, we get 2 things on ovary side. We're going to get progesterone secretion and ovulation. On the male side, we're going to get testosterone, okay, secretion as well. All right. Now, prolactin, mammary glands, milk production. That think lactate, think like milk. Okay, that might help you remember it. Growth hormone affects all cells, and what that does, what's in the name, growth, but also is protein synthesis. Okay, it's very important. It will synthesize proteins at a higher level. Now, the last one is MSH. So its target is going to be the melanocyte of the skin, and what it's going to do, it's going to increase and synthesize melanin on the epidermis. And there it is. So in a previous video, we talked about the anterior pituitary gland hormones. There were 7 of those. Well, there's also a posterior pituitary gland. There's 2 hormones that are going to be the target secreted for the posterior pituitary gland. Now here it is. There's 2, ADH, oxytocin. So let's roll through them. ADH, anti-diuretic hormone, okay, ADH, targeted origin, target, kidneys, okay, now here it is. It's going to reabsorb water, elevate blood volume, and then in turn, elevate your blood pressure. This is one of the body's life-saving maneuvers at times, okay, when things start to get a little off with blood volume, ADH. Oxytocin, females, uterus, mammary glands, males, sperm duct, prostates. Oxytocin, the goal from the uterus is to provide labor contractions. Mammary glands, ejection of milk. Now, what about men? I talked about sperm duct and the prostate. It's going to contract the sperm duct and the prostate. These are your 2 posterior, that means back, posterior pituitary gland hormones. There's 2 of them. There it is. In this section, we're going to talk about the thyroid and the parathyroid hormones. Here we go. So we have the thyroid here, and we have our 2 types, the follicular epithelium and the C cells. So the follicular epithelium has to do with T4 and T3, affects most cells, and it's going to increase energy, it's going to increase O2 consumption, and increase your growth and development. Now C cells have to do with the CT hormone, bone and kidneys, and over here, it's going to drop your calcium. Now, the opposite side, the parathyroid hormone, is going to also target the bone and kidneys, but it's going to increase your calcium concentration. So let's look at the whole board here. Chief cells are going to ultimately go to parathyroid hormone, which is going to increase calcium concentration. C cells, CT, lower calcium concentrations. That's the big key here. So now we're going to discuss the adrenal hormones. Now, the adrenals, remember, we have our adrenal. It's broken up between a cortex, the adrenal cortex, and the adrenal medulla. if I can give you a one pearl, think about the adrenal medulla as your epinephrine center, and this all will kind of come into play. So let's just talk about it. Adrenal cortex. We have mineral corticoids, glucocorticoids, androgens. We're going to talk about it. Now, mineral corticoids target the kidneys, glucocorticoids, most cells out there, okay? Now, the goal of the mineral corticoids and all this happening is to reabsorb sodium and water. The goal of glucocorticoids, release amino acids and start to get production going of glucose, of glycogen, okay? We want to form it, okay? Now, androgens, we're going to talk about later. We talk about reproductive, but androgens can actually be released here by the adrenal cortex, but no one's really sure why or what effect that does. It's just something I want you to know about. A weird question might come up, okay? Now, the adrenal medulla, that's your that's your epinephrine and norepinephrine center, okay? Now, what is that going to do? It's going to affect most cells out there, and what is it going to do? It's going to increase cardiac activity, increase blood pressure. That's the main thing epinephrine, norepinephrine is going to do in the body. There it is. The pancreas lies in the left upper quadrant. The pancreas, the majority of it is in the left upper quadrant. A little bit may leak over into the right upper quadrant. The majority on your test, it's left lower quadrant is the majority of the pancreas. Now, the pancreas has two hormones. How many? Two hormones. The pancreas, alpha cells, is going to be our glucagon hormone. Beta cells is going to be our insulin hormone. The balance of our blood level, glucose, is in effect from our glucagon and our insulin. Okay? Just like with our calcium concentrations, we talked about earlier, with the CT hormone and the parathyroid hormone, it's going to be up and down of our calcium concentrations. This glucagon and insulin have to do with our effects of blood glucose levels. And there it is. Inside this video, we're going to talk about the pineal gland. Now, the pineal gland is very simple. All it does is affects your day and night cycles. This is the most important piece of information. So, throughout our day and night cycles, we're going to either hold back our melatonin or release the melatonin. Melatonin is going to be highest, obviously, with our night cycle. When it's released, time to go to bed. Okay, so that is your pineal gland. Just remember, it's got to do with our melatonin. Right here is our hormones of the reproductive system. Now, here's what we got to go over, the main part to this. First, I want you to know that the male sex hormone is the androgens. The female sex hormone is the estrogens. Now, here we go. So we've got testes here with two types of cells, okay? The interstitial and the S. Now, the interstitial cells connect with the androgens. Androgens affect most cells, and what do we get? We get sperm support. We get protein synthesis out of that, okay? Now, our S cells over here are going to go after inhibin. Going to target the anterior pituitary, and we're going to inhibit any secretion of FSH. The ovaries with the follicular cells. Estrogen, okay, we have inhibin. Inhibin's going to do the same thing. Inhibin, anterior pituitary, it's going to inhibit FSH. Now, on the female side, well, we support the female. The follicular maturation, okay? All right, the follicle maturation. Now, over here, we have the corpus luteum. This has to do with the progestions, uterus and mammary glands. And what is it going to do? It's going to prepare the uterus for implantation and get the mammary glands ready for any secretions. There it is. Inside this video, I'm going to talk about diabetes, type 1 versus type 2, and I'm also going to discuss as well our diabetic emergencies, too low and too high. So a type 1 diabetic, we talked about in a previous video about beta cells having to do with insulin, how we produce insulin, okay? And how glucagon and insulin are going to be our counterbalance, right, for blood glucose in the body. What if I decide to destroy all your beta cells? Blood sugar is going to go way up because the alpha cells are going to win. There's no beta to balance it out. Well, that is a type 1 diabetic. A type 1 diabetic, their beta cells are destroyed. So they cannot even produce, can't produce insulin. So this is a type 1, also called juvenile diabetes, because when you're young, you figure it out. Type 2 is usually called adult onset diabetes because that's when it starts. So risk factors, which are pretty eerie that these risk factors of becoming a type 2 diabetic are the same risk factors that you would develop cardiac event. So here they are: high cholesterol, high blood pressure, obesity. Unfortunately, some people are stuck with family history. Just something you know, okay? Now, what happens here is we have a decline in insulin production. So, and also one thing I wrote down, I do want to mention it out loud to you, is usually they're over 45 or 50 when this can occur. Now, think about it. The body's getting older. There's a slowing down of insulin production, okay, due to some of these risk factors or the family history, okay? This risk factor group of type 2 diabetes, obesity, high cholesterol, and high blood pressure screams coronary problems. Just want to let you know about that. Now, hypoglycemia, you're going to present, could be unresponsive in a coma. If you're awake and you have low, hypo means low, hypoglycemia, what that means is you're going to be pale, you're going to be cool, and what's going to happen is you're going to either be passed out unresponsive or acting very bizarre and altered mental status. Your blood glucose is going to be usually, not a rule. It's not a rule. This is a practical tip. Hey, practical tip, not exam tip, practical. If someone is, every diabetic is different. You could have a diabetic at 30 and they're wide awake and altered. The same diabetic could be, a different diabetic could be 30 and unresponsive. Some might be 60 and unresponsive. So everyone's different, okay? But under 70, we start to worry. Under 60, we really start to worry. Now, DKA is too high. The biggest pearl I want to give you with DKA is that your patient is actually dehydrated as well. So if someone's dehydrated, what do they look like? Well, they got hot, dry skin. So do they. Now, the difference with this from dehydration is your blood sugar is extremely high. 3, 4, 5, 600, high on the glucometer. You have this deep, rapid breathing called Kussmaul breathing, okay? And the big pearl is the fruity odor from the ketones. Almost every question has it. It might not, though, so I give you a few other things to look at. There it is. Now, these right here are the thyroid disorders. Some are chronic, where the patient is living with it. They're trying to sort it out with their doctor. Other ones are EMS-related ones. You may see this patient out in the field, and you might pick up on it. So let's talk about it. So you can see on one side we have too high. Now, too high is going to be Graves' disease, thyroid storm. Too low is hypothyroidism and mytoxemia. Now, let's talk about these, okay? Now, we can see here, Graves' disease is a more chronic issue. So someone with Graves' disease, they might have an episode or a flare-up of their Graves' disease when their thyroid hormone just gets too high. They're going to appear agitated, altered, kind of irritable, altered mental status, tachycardia, okay? And they're sweating. What's going on with this patient, right? You can see here, Graves' autoimmune, agitation, weight loss, insomnia, tachycardia. Now, a thyroid storm is something completely different. That is when the level of thyroid hormone gets so high, it's all released freely into the blood, And this is very common if someone may be abusing levothyroxine or Synthroid. So here it is. Levothyroxine, which you see over on the low side, is a drug that people can use to increase their thyroid hormone. But that same drug can be used for weight loss if your thyroid levels are too high. If you overdose on levothyroxine, you can get a thyroid storm. It looks like sepsis, right? High fever, irritability, or a coma, hypotension, nausea, vomiting. You might think it's sepsis, which is not going to hurt the patient. I mean, you're going to treat them very similar way, but you got to think here, this could be a thyroid storm. So you want to ask about that. Now, what else? Too low. Too low is going to be hypothyroidism. That's chronic. Acutely is mitoxemia. Okay, now what's that? Let's talk about it. So let's just go over the buzzwords. This is someone with a low metabolism. These patients are usually found, they have pale skin, they are very unemotional, they may have puffy or thick skin. Okay, something to think about with hypothyroidism, the chronic side. They may be taking levothyroxine, Synthroid, the brand name, because they need to raise their levels to get back to normal, okay? Now, right here, we can see we have fatigue, weight gain, that dry, puffy skin, depression, bradycardia. You may have a patient, again, unemotional and depressed. It's not depression, it's their thyroid level. So that's something to think about too, okay? Now, if they're in mitoxemia, what this is, mitoxemia, is a thickening of the connective tissues in the skin and other places in the body. So what happens there is your patient can become very, very hypothermic. Still look like this, but they're very bradycardic and hypothermic, and it's myoxemia. Sneaky, okay? These are not talked about a lot, but I guarantee you'll get a question on it. You got to know this. These are the thyroid disorders. Remember, too high is Graves, too low myoxemia, too high is thyroid storm, too low hypothyroidism. Remember the drug, levothyroxine, is going to raise your levels. And if you abuse it, you might get a thyroid storm because you put in too much in your blood. There it is. So for you, I've created a chart here of the adrenal disorders. Too much circulating adrenal hormone and too low. Too high is Cushing's syndrome. Okay, you may hear words like moon face or the buffalo hump, which is too much fat on someone's back that accumulates, okay? This is Cushing's syndrome. So you're going to see, with that buzzword, weight gain. You're going to see bruising more easily, and you're going to see an increased risk of MI or stroke with someone who has Cushing's syndrome. Think about it. Weight gain because they have too high of circulating adrenal hormones. So they're reabsorbing that sodium and water with we talked about earlier with our hormones. So all those actions are happening all the time. Put them all together in a pot and you're going to be at risk of MI and strokes, right? So this can happen due to, I guess you could say, for lack of a better word here, side effects of steroid use. And long-term or steroid use, and I'm talking about all kinds of steroids, like not steroids like, for building muscle. I'm talking about like prednisone, okay? Long-term steroid use could cause this. Long-term steroid use or using a steroid for a short period of time could be a side effect of, and you get this. It's on both sides of this. I want you to know. Now, this is more, though, on the Cushing side. On this side, about 90% of people that have too low, it's an autoimmune disease called Addison's disease. Addison's disease, what it is an autoimmune disorder where your body starts to attack your adrenal cortex and destroy it. And because it's being attacked and destroyed, it's not going to release as much adrenal hormones like the ones we talked about before. So imagine what happens then. Okay, the opposite of this. So what you get is you get a low production of all three hormones. This is adrenal insufficiency. So think about it. If your body is in a state that it needs to release these hormones, it might not be able to. And this causes a very, very bad effect in the body, especially under times of stress where you could have very easily a cardiac event because you have this. There it is. Hey everyone, welcome to our next section. We're going to be talking about everything to do with blood. So first, I want to break down what exactly is in our blood so we can understand it. There's a lot to discuss here, so here we go. Now, the first piece here is the composition of blood. So what's your blood made of? Now, your blood, as you can see on the board here, is made up of plasma, which is 55%. Well, that leaves 45% of something called, right down here, formed elements. Now, the formed elements is red blood cells, white blood cells, and platelets. Now, when we talk about plasma, plasma is built up of different proteins that each have a very specific function. We're going to talk about that in another video. Okay. Red blood cells, their goal is to carry oxygen and transport oxygen and carbon dioxide. Okay, moving around. White blood cells have to do with the defense systems in the body, aka the immune response. Okay, it's the immune system. And the final piece down here is going to be platelets. So with platelets, what we're talking about is clotting. Okay, so we think platelets, we think clotting responsibilities. Okay, so here's everything here: 55% plasma, 45% all these formed elements. These are the basics. Let's get a little more advanced next video. Here we go. Let's talk about red blood cells. So I'm going to do a second video on hemoglobin, but first we're going to talk about hematocrit. So first, a quick little thing you got to know about red blood cells. So remember what we talked earlier on about formed elements. That makes up 45% of the whole blood, which is plasma, 55%, formed elements, 45%. Right. So we talked about red blood cells and white blood cells being inside, and platelets being inside of the formed elements. Well, here it is, folks. Red blood cells make up 99.9% of that 45% of formed elements. Okay? Now we got that out of the way. You can see red blood cells make up 99.9% of formed elements, leaving that 0.1 to be white blood cells and platelets. Okay? Now, if you were to stop this video right now, and you were to stop watching right now, and I said, hematocrit, 45%, have a good night. That's great. That's not bad. But if you really want to understand this at a deep level so you know it for life, let me tell you why and what it is behind it. So here it is. So hematocrit is the percentage of whole blood volume occupied by elements. So if red blood cells are 99.9% of the formed elements, wouldn't it make sense that a normal person would be about 45%? Yes. Now, of course, it's not a rule. So let me explain something to you. Hang on. In male patients, okay, when we're looking at a hematocrit, which is part of what they call the H&H, which is the hematocrit and the hemoglobin coming in the next video, is the first H, okay? So males, the safe range is around, again, it's not a hard rule, this is a range, but if you're given, this is a practical tip as well, not just A&P, but practically, you could be doing a interfacility transport. Yeah, he's going for a blood transfusion. His hematocrit came back at 17. Well, that's low. Well, maybe before this video, you would have had, I don't know, low, high, what's that? What does hematocrit mean? Now you know. So the males, okay, safe range, 40 to 54. That's safe range. Really, we like 45, 46%. I like that. Females are 37 to 47, safe range. 42% we like that. Now, why is this? Okay, here it is. So, males have a sex. Remember we talked about the endocrine, the sex hormones? Look how it's all coming together, folks. Now, check this out. We're talking about androgens. That's the male sex hormone. Well, that male sex hormone produces red blood cells. Okay? Estrogen does not. Which is why males have a little bump and a little higher number with red blood cells. And there it is, hematocrit. I'll see you on hemoglobin next video. Here we go. Hey my friends, back here with our next video in our blood composition section. Here's what we're talking about now. Simple one here. We already talked about hematocrit. We're talking about the other H of our H&H, which is going to be hemoglobin. Now, what is hemoglobin and what does it do? Well, it's the ability to transport oxygen and carbon dioxide in the body. So what does this mean? Well, here's a normal level, okay? Again, I'm going to give you a quick tip. If you were to watch the video right now and stop watching, and I said hemoglobin 15, and you left the video, good. Remember that. Now let me explain a little more for you. Here's hemoglobin. Now, the goal, male or female, is 12 to 18 grams per deciliter. That's how it's measured. So 15 sounds right about in the middle, okay? That's the safe range, okay? Male or female. Now, if our hemoglobin is too low, what that means is we cannot transport oxygen and carbon dioxide very well, and your patient suffers. That's the big pearl with this. So now we're talking about platelets. Here's the number with platelets. So our goal is 350,000. A range from 150 to 500 is fair. Now, another word for platelets is thrombocytes, okay? So their whole goal is to aid in the clotting process. Now, here it is, okay? It's produced in the bone marrow. Next year, each one lasts about 9 to 12 days, then replaced. And the final piece here, 2 buzzwords for you. We have thrombocytopenia, thrombocytosis. So here's what we have. A volume loss, cytopenia. And then right here, infection, cancer, inflammation causes it to be too high of a platelet level. And there it is. So now I want to talk about plasma proteins. So in the first video, we talked about how plasma is 55% of blood, and then 45% is formed elements. I told you that plasma is broken up into different proteins. But what are those proteins? What do they do? What are their names? Here we go. So first, we have the albumins. The albumins make up 60% of the plasma proteins. Now, being it's at 60%, its goal is to keep the osmotic pressure. That's the goal of it, to maintain, okay? So there it is. Now, number 2 is going to be the globulins. These globulins are at 35% for the plasma. Now, they're broken up. So the subdivision of those globulins is going to be antibodies, which are immunoglobulins. And then we have the transport proteins. So here we go. Antibodies, immunoglobulins. They attack foreign invaders and pathogens. Okay. Transport proteins have a pretty cool job. So what they're going to do is they're going to bind to ions. They're going to bind to hormones. And what they're going to do is, let's say there's something out there that is a very low solubility in water. It's going to transport it. Okay. And the final piece here is the fibrinogen. So this has to do with blood clotting. Okay. So what's the plasma protein that has to do with blood clotting? There it is, fibrinogen. I'll see you in the next video. Now we're going to discuss white blood cells. So white blood cells, I'm going to give you some names here. They're broken up into a few different types of white blood cells. So let's start with that first, okay? So we have white blood cells. Here are the different types. We have neutrophils, we have eosinophils, we have basophils, we have monocytes, we have lymphocytes. Each one of these we're going to break down in separate videos, what they do, okay? So I just want to let you know, those are the main players, the types of white blood cells. Now, what is leukocytes? Okay, a white blood cell, another name for it, so AKA leukocytes. White blood cell, leukocyte, it's the same thing, okay? So that's very important to remember. Now, they defend against invasion and pathogens. They remove toxins and waste in the body. That's what white blood cells do. If you get a test question, which is physically larger, like 1-to-1, a red blood cell or a white blood cell is actually larger. There it is. Now right here, I break down all the types of white blood cells. Now, what they do is pretty similar, but they all do it in a little bit of a different way, okay? So here it is. First, we have neutrophils. Now, neutrophils are going to engulf pathogens and debris. And what they use is they use a cytotoxic attack, okay? Now, eosinophils, they're going to attack antibody-related materials. They also have a cytotoxic enzyme attack, okay? Basophils are going to enter damaged tissues. They're going to release histamine and produce inflammation. Monocytes are going to engulf pathogens and debris. And then finally, the lymphocytes. That has to do with the lymphatic system. They are the main cells of the lymphatic system, and they are the defense against pathogens. There it is. So there's just some buzzwords because you're going to have these on your test. So what does this do? What does that do? These are the main buzzwords, so now you know. So now we're going to talk about the blood levels you absolutely need to know. Let's dive into it. So first we have hematocrit, also known as HCT, hematocrit. That talks about the percentage of formed elements. And we talked about that in a previous video, okay? Whether male or female, we're looking around 37, 54% is our goal between the lowest we'd like on a female and the highest on a male, okay? Now, it's called polycythemia is going to be too high, okay? Anemia is going to be too low, okay? Quick tip, anything with an A in front of it in medicine usually means it's non-existent or not enough, just to tell you, okay? Complete blood count is known as a CBC. So that is the number of red blood cells per milliliter, okay? Now here it is, 42, 63 million, okay? That's our range, okay? Now it's polycythemia is too high, anemia too low, same deal, okay? Now here is, see the HB? H and a lowercase b is your hemoglobin. Hemoglobin is measured 12 to 18 grams per deciliter, okay? You could see here, well, we don't really talk about, there's no word for too high. There is a word for too low, that's anemia, okay? Now what about down here? What are these things? We got MCV, MCHC, whoa. Well, let's just go through them. So here we go. So first, we have the MCV right here. What this measures is the average volume of one red blood cell. You can see it here, okay? 82 to 101, okay? This means you are normocytic, okay? You are macrocytic if it's too much. You are microcytic if it's too low, okay? Now, MCHC is the average amount of hemoglobin in one red blood cell. 27 to 34 on that realm. Here it is. Too much, you're hypochromic. You're hypochromic, too low. Normochromic. So if I say to you, your patient is normochromic, you're going to know that their average amount of hemoglobin on one red blood cell is normal. There it is, folks. This is your blood levels you need to know. Sickle cell disease. Very misunderstood. You're going to know it cold right now. Here it is. So with sickle cell disease, what we have is most people out there in the world have hemoglobin A, which is 2 alpha and then 2 beta. That looks like A2, B2. That is normal hemoglobin A. So if you don't have sickle cell trait or sickle cell disease, you have hemoglobin A. Okay. Now, sickle cell hemoglobin is called hemoglobin S. You got your 2 alphas, A2, but you have 2 S's, S2. That gives your hemoglobin S. So here's what happens with a sickle cell red blood cell. A normal red blood cell, when the sickle cell and the normal red blood cell are oxygenated, everything's fine. But as soon as that patient gets deoxygenated, as soon as that red blood cell gets deoxygenated, it turns into a sickle fashion. And when it's in that sickle fashion, it can obstruct small blood vessels. Okay? Now, sickle cell is actually passed down from parent to child. So you can basically say it's like an autoimmune passed on disease from family member to family member. Now, here's the deal. There's sickle cell trait and sickle cell disease. If your patient says, I have sickle cell trait, well, that means they're this. They're A2BS. Those people usually do fine. They very rarely have any problems, ever. They do not have sickle cell disease, just a trait of it. So they don't have the disease. They don't have sickle cell. If both parents have sickle cell traits, or they both have sickle cell disease, that combines together, and that brings it right here, which is sickle cell hemoglobin S, A2S2 disease. Here's normal, here's a sickle cell. There it is. The biggest thing to remember is remember that hemoglobin has to do with how we transport oxygen and carbon dioxide. So when somebody is in sickle cell disease, that affects their ability to transport oxygen and carbon dioxide when they're in sickle cell crisis. And when they're in crisis, they're going to be deoxygenated and they're going to have small blood clots going on in their body. There it is, folks. All right, we are back with another video. We're talking about the heart layers. So we have think about our heart, which we know is a muscle. Okay, we're going to talk about that. Well, it's surrounded by something called a pericardial sac. There's a little space in there, and there's layers in that pericardium, that lining, and there's also layers of the heart itself. Okay, so here we go. Let's start with the most outer layer, which is the pericardial cavity. It could also be called a pericardial sac. You probably heard in other videos talk about cardiac tamponade. That's fluid pressure in this space. You see? Now, if we have a heart attack down here in the myocardium, that's heart muscle dying. Okay, we're gonna go through, but that's just a little preview for you. Okay, now here we go. Pericardium is made up of the parietal pericardium, the most outer layer, which is basically the lining of the pericardial sac. This right here is basically the most outer layer of the heart. It sits right on the heart. It's the epicardium, which is also called the visceral pericardium. The visceral, it's right on it. Okay. Now here's the heart wall. This same layer is the most outer layer of the heart, the epicardium, that visceral pericardium. Okay, that's the most outer layer. Same as here. Okay, same layer. Now we get down to the inner parts of the heart. So the actual muscle itself of the heart is the myocardium. Myo means muscle. Okay, so there it is. And the inner workings inside the heart is the endocardium. So we go from the parietal pericardium, the epicardium, also known as the visceral pericardium. This is the same thing. Okay, don't get confused. Same thing. Then we go to the myocardium. Then we go to the endocardium. This particular one here is part of the epicardium, is part of the heart wall, and the last layer of the pericardial cavity. There it is. Hey everyone, welcome to our heart section here in Anatomy and Physiology Mastery. We're going to be talking about heart blood flow. Now, I've done other videos on heart blood flow. You'll see it in the course. But this, I want to be very detailed and I want to be slow going through, and I want to make sure that you understand this. So we're going to go very slow and controlled. Now here it is. Heart blood flow. What is so important about the heart? Well, the heart is our pump in our body that pumps blood from our fingertips to our toenails, from our head to our toes, to make sure that every organ gets oxygenated blood. That's what the heart does. The second thing the heart has to do is, once it's pumped blood out and it's given away the oxygen to the system, it is the means of getting more oxygen in the system by connecting with the lungs. We're going to talk about that in a second. But the heart is partners with the lungs. Okay, it's very important to remember. Okay, now I'm going to go through how it all flows so you understand it. Now, the first thing that you need to know, and you'll see it right here. When you think about arteries, I want you to think away. When we talk about veins, think towards. What does that mean? Arteries go away from the heart. Veins go towards the heart. So let's start over here, okay? What is the SVC? What is the IVC? Well, it stands for superior vena cava and inferior vena cava. Vena means it's part of the venous system. What did I say? Veins go towards the heart. Well, this IVC and SVC is going towards the heart. Now, superior in medicine means above. Inferior means below. Okay? Now, here's what it is. All the blood pooling in the venous system from up here dumps into the SVC. Everything from mesentery legs down here dumps into the IVC, and it travels up. Okay? So all this blood pooling from the whole body comes right here to a head, right in the right atrium. Now, how do I tell my students to differentiate the atria from the ventricles? It's a little trick. Now, here's how you remember it. I like to tell my students that the atria is not as strong as the ventricles are. And I want you to give the stronger ventricles a job to do. They have a task and they must achieve it. All the atria is going to do is pass the blood down to its stronger partner. Okay, now here it is. The right atria gets the blood from the SVC and the IVC. This blood does not have any oxygen because it's already been dropped off. The blood is returning back to the heart to get more oxygen, which, remember, is one of the two things that the heart is responsible for. Now, here it is. Right atria goes through a valve. What's the name of that valve? The tricuspid valve. I put the number 3 here so you remember, okay? Tri 3. Goes through the valve into the right ventricle. Now, we got to give the right ventricle a job, okay? So what's the job of the right ventricle going to be? The job is going to be to get oxygen, okay? Because we don't have any oxygen. So the right ventricle's job in this earth is to get oxygen. Where on here do we see oxygen? Oh, here it is. The lungs. I have oxygen. Okay. So how do we get there? Well, what if we made an artery that goes away from the heart towards the lungs? And we call it the pulmonary artery. There it is. We have to go through the pulmonary valve to get there, right? So here we go. I'm going to draw it out for you. So here we go. From the right ventricle, the pulmonary artery. I'm going to put PA. There's a valve in here. I'm just going to put it over here just for ease of use here. It's more down here, but just to give you an idea. Here's your pulmonic valve. Okay. Here's the valve. Okay. Now, We hit the lungs. What do the lungs have in their capillary beds? Oxygen. We take it. Thanks for the oxygen. Now, right now, this heart blood flow, if you will, we're sitting at the lungs. We got oxygen. Veins go towards the heart. We got to make a vein to go back to the heart. Where are we going to go back to? Well, we haven't gone over here yet. There it is. So, pulmonary vein brings us back. Now we're in the left atria. Okay, so it's beautiful. Right ventricle, you did your job. You get a check mark. All done with the right side. Now what are we doing? We're in the left atria. We have oxygen. What's the second job of the heart? The second job of the heart is to pump blood to the rest of the body. That's what we're going to do right now with the right ventricle. Here we go. So there's a valve here. The number 2 you got to remember here. It's the bicuspid, also called the mitral valve. I don't make the names, just telling you. So let's call it bicuspid because we think 3, we think 2 makes sense. Okay, we go through. Okay, now we're in the left ventricle. What's the job of the left ventricle going to be? The job is going to be pump to the body. Okay, pump to the body. Great. How are we going to do that? We need something strong. We need the strongest piece in this whole system. The aorta. There it is. So aorta, we're going to go wrap it around like this. Okay, some are going to go up here. Some are going down here. Okay, there's our aorta. The strongest piece in the whole system, because the aorta has got to finish the job that the left ventricle started. And there it is. There it is. Okay? We gave the right ventricle a job of getting O2. It did it. We gave the left ventricle a job of pumping the body. It has done it, pairing up with the aorta. Now, through the aorta, all the blood's pumped out to your fingertips, to your toenails, to your head, to your toes, and then it gets flipped around again through the venous system because the oxygen gets dropped off, and we go again and again and again and again and again and again. That's how you do it. So that is heart blood flow. There it is. Watch this over and over until you know it as well as I do. I know you can do it. Right here, we're going to talk about the exact heart electrical system and how impulses are gone through the heart. Okay? Now, first, I want to talk about what are pacemakers. So, in a normal heart and also a sinus rhythm, we're going to have the pacemaker be what's called the SA node up here. Okay? Now, I just want to give that little thought to you. We're going to talk about pacemakers later. Okay? Now, here's heart electrical activity. Now, remember, the heart hasn't changed. Even though it's not marked here, if I go like this and I cut it, I have the same players. This is the right atria, right ventricle, left ventricle, same heart, just a different labeling system, okay? We went from blood flow to now the electrical system of the impulses of the heart. That's all we've done. Now, remember, the electrical is actually what makes the heartbeats happen, okay? And the mechanical is the other side of that. So the SA node starts the impulse. It then travels through what we call the internodal pathways through here, okay? It ends up here at the AV node. The AV node goes over to the bundle of His through the right and the left bundle branches. And then we end up here down at the base of the ventricles, what they call the Purkinje fibers. Now, we already went over heart blood flow. This is the electrical flow of the heart. That's it. That's all it is. Now, here's the big where people get messed up. If I have a sinus rhythm, the heart rate is 60 to 100. Right. If the SA node is in charge in the starting pacemaker, then we get 60 to 100. What if the AV node says, you know what, SA node, you're weak, I'm taking over. Well, the heart rate's only going to be 40 to 60. And there's not going to be a P wave. which means you have a junctional rhythm. In ventricular rhythm, if the SA fails, the AV fails, and now we're down here and the ventricular is taking over, you get a heart rate of 20 to 40. If you look up idioventricular rhythm, and you can see it, it's in this course, go to the paramedic section, you'll see a full breakdown in EKGs. There it is. Hey everyone, we're going to talk more about ACS, acute coronary syndrome. There's a lot of words here, a lot of buzzwords. I need you to understand this cold at a deep level. So we're going to talk about it now so you understand these buzzwords with cardiology. Now here it is. Now, we know a STEMI on 12-lead EKG is 2 up and 2 down. At least, remember the elevation's got to be usually at least for protocol, at least 2 millimeters up. Okay? Now, acute coronary syndrome, what that means, ACS, it does not mean it's a heart attack. It means there is an acute process going on inside one of your coronary arteries. We don't know exactly what it is. We don't know if it's a spasm, a half blockage, a full blockage, just a temporary blockage. Will it last 15 minutes? Will it be indefinite, like a heart attack? We don't know. But we know there's something going on. So this is what it is. You go to your patient and they have chest pain and they have difficulty breathing. They have nausea, vomiting. Those are your main symptoms of someone having a heart attack, right? It could also be that back pain. I'm weak. Those are sly symptoms, right? Okay, now, if we don't do an EKG, if we don't do any blood work, and let's say, well, at that point, we would be at the EMT level, right? So we may be able to do an EKG, but we may not be able to read it, okay? We would assume maybe they're having a heart attack. So if we do an EKG and we do blood work, we can figure out what is actually going on. And we can call it something different than an ACS. Now, here we go. So you're a paramedic, you do a 12-lead EKG. You know how to read it. Great. Well, here's the question. Is it a STEMI or is it not a STEMI? Is your ST elevation showing a STEMI, 2 up and 2 down? Or is it not a STEMI? Or it's something else, but it's not a STEMI, okay? So here's where we go. Now, if it's a STEMI, it's a heart attack. It's a full-blown heart attack. Call the code. It's a STEMI. Now, if the ST elevation is not, there's no ST elevation, so it's not, we can't call it a heart attack just yet. That's why we go to the hospital with our patient. They draw blood work. Now, if the troponin level comes back normal and the patient still has symptoms, they have symptomatic chest pain. My chest just started hurting. It's crushing 20 minutes ago. I'm throwing up. I'm unstable. And you've given aspirin. You've given nitro. You gave pain meds. They're still symptomatic. They're still in trouble. But the troponins are normal. That's unstable angina, unstable angina, okay? That's what it is. Unstable. However you want to say it, okay? If the troponins come back elevated, that means heart muscle is actively dying. This is called an NSTEMI. Because remember, what a heart attack is, it's just simple. The myocardium's dying. That's all it is, okay? So the troponins up, but the 12-lead Evan, the 12-lead was fine. Well, it's called a STEMI is when we see it on the EKG. You can have a heart attack and not see it on the EKG. You see it in the blood work. It's an NSTEMI. So that's all the words, the lingo. Now, what is this? What is Prinzmetal angina? Okay. It is not a blockage of the coronary artery with plaque. It is a spasm of the coronary artery where it goes like this and just shuts down. So it's spasming. And then we hope if we give nitro, it will open up. If we treat the patient, it will get better. So that's interesting. Now, how we get noticed in the field? We're not. But you might be transporting a patient in a facility who has Prinzmetal angina and know that it's basically the same as a heart attack as long as you're under spasm. There it is. Now this right here is a very important video for my paramedic students, okay? Now anyone can watch this video. I'm not saying to skip it, but this is not going to be an EMT level National Emergency Prep video. This is going to be a paramedic level video, okay? But you want to learn? Come on in. It's totally cool. Just want to let you know. So here it is. So we know we have our 12-lead EKG, okay? We know we have all the leads. Now, here they are. You know, if this is a printed EKG, it runs like this. Lead 1, 2, 3, AVR, AVL, AVF, V1, V2, V3, V4, V5, V6. Okay, so first, we're going to label. If we have 2 up and we have a STEMI, which is 2 up and 2 down, reciprocal changes, where would we have the MI where the elevation is? So, this is looking at the lateral wall of the heart, 1 in AVL. Looking at the inferior wall of the heart is 2, 3 AVF. V1 and V2 is septal. V3 and V4 is anterior. V5, V6 is lateral. So if I have an inferior wall MI, where's the elevation? 2, 3 AVF. It could be, remember, it's 2 or more friends, 2 or more contiguous leads need to be up, and then we need reciprocal changes. So, let's say that 2 and 3 were ST elevated, okay? At least 2 millimeters, 2 little boxes up. And then I look at, let's say, V1 or V2, or V3 and V4, or V5, V6, or 1 AVL, and I see 2 down, okay? Most commonly, it'd probably be in the V leads. That makes sense, okay? Because they're opposites, okay? We have a STEMI, okay? So if we had, let's say we had the lateral wall up, or these up, or all these up, okay? We look for the opposite. Usually it's the inferior is the opposite of everything. Usually. Not a rule, usually. Okay? Now, what about coronary arteries? You're going to get asked in a test. Well, you have a lateral wall STEMI. Which coronary artery is being blocked? Well, here it is. If the STEMI, which stands for an ST elevation MI, we're going to have to do another video on what is acute coronary syndrome and breaking it down, because there's a STEMI and an NSTEMI. We're going to talk about in another video. Just want to tell you what it is, okay? If we have a ST elevation MI in 1 AVL, the circumflex and the LAD are affected. Circumflex LAD. Notice both laterals, which is here and here, 1 AVL, V5, V6, affect your circumflex and can affect your LAD. Okay? Now, if I attack the inferior wall, that's my right coronary artery. Boom, boom, boom. Okay? Now, what does that lead to everything else? Everything else is straight LAD. Okay? Now, if you think about it, it makes a lot of sense, right? Left anterior descending, and this is all basically anterior. Okay? It makes sense, right? So there's a way to remember it. My friends, I hope this gave you insight so you have this down cold. This is going to be on a lot more tests than one, that's for sure. This is a very common equation you're going to see, so I want to explain it to you now so you know it. So we talk about cardiac output. That is how efficient the heart is at its job. Think of an employee getting graded on their performance. Well, in this case, the heart is our employee, and we're going to grade its performance. So what we have is, we have a few buzzwords: cardiac output, stroke volume, and heart rate. So here's the equation. You have to know this. CO, cardiac output, is equal to the stroke volume, the mLs per heartbeat, times the heart rate, which is the beats per minute, gives you the mLs per minute. So if, let's say, my heart rate is 70, and I'm getting 80 mLs per beat out at a rate of 70, I'm at 5,600 mLs a minute. That's a normal patient, if you will. Because most patients are going to be around 60, 70. Again, we've talked about how, the heart rate could be less. Of course, you're an athlete or a runner. We talked about that, okay, in other videos like 40s, 50s. Other people could be a little higher. Talk about heart transplant patients, they might be higher. But this is a good rule to keep in mind right here. There it is. This is something that may come up, and I don't want you to be fooled by it. So, as you know, heart transplants nowadays are extremely common to get. And if you have a heart that is transplanted, it can last anywhere from 15, 20, even 25 years. Okay, that's not uncommon. Now, something you want to know about a heart transplant patient is this. They have no vagus nerve. So when that donor heart leaves that body to go to the recipient, well, they have to cut the nerves. So they have to cut the vagus nerve. They have to sever the vagus nerve. So there's no nervous system control of the heart. The heart is basically affected by the heart itself and just the circulating hormones. That's it, like epi and norepi. So what happens is, in a normal patient, you have that parasympathetic and sympathetic control of the heart. In transplant patients, there's no vagus nerve. So the sympathetic takes over a slight edge, essentially. And the heart rate's always going to be a little faster. And it's also, if it does get faster due to hormone release, then it takes a longer time to get back down to normal. This is something you should know about heart transplant patients. Just want to let you know about it. This right here is the basic building blocks of this system. So what we're going to talk about now is the blood vessels. We're going to start with the arterial and then the venous side, okay? So earlier on, I talked about heart blood flow in a previous section. But what actually takes place after heart blood flow? Well, here it is. Okay, this is in a broad sense what it is. So, we all know that after the left ventricle, blood is pumped to the aorta. Okay, it must go up, it must go down. Okay, it is pumped to the aorta and then hits the large and then later on medium arteries. Okay, so think about it. If you were to puncture your aorta, tremendous amount of pressure. But if you were to puncture an artery, tremendous amount of pressure. Because it's got to be pumped through. Okay. Now, after that, blood is then sent to smaller arterioles. The arterioles connect this oxygen-rich blood to the capillaries. Okay. Now, we all know, if I say one word about the capillaries, this is where the exchange of oxygen and carbon dioxide takes place, in the capillaries. We all remember that. Okay. Now, here are capillaries. The capillaries are our bridge from the arterial side to the venous side. So here they are. Now we're on the venous side. Now, remember, the arterial side takes blood away from the heart because everyone else needs it, the oxygen-rich blood. The venous side goes, well, we need more now, so it comes back, okay? So here we go. Capillaries then move over to the venules, okay? They move on to the veins, which then go from small veins to medium-sized veins, larger veins, like veins we talk about, until it all comes to a head in the vena cava, which is the superior vena cava and the inferior vena cava, which is right in front. All that blood comes together and then clicks over to the right atrium. And then we start our heart blood flow, which we've gone over. So this is important to know, just at a broad scope, how it works. And these are really some of your key terms. You got to know these. There it is. The blood vessel structure has 3 distinct layers. Now, very important here is it's the same whether it's an artery or a vein. And they both include smooth muscle. There's a buzzword for you. Now, here's what we have, okay? There's a lot on this board. Let's break it down. So, I want you to think that if we take a circular artery like this, okay, or a vein, right? Blood has to flow through that pathway, right? So what I've done here is I've kind of took a cross section up here of the 3 layers. Now the cool thing is, if you read these terms, it kind of makes sense. So here's the blood. This would be the blood in this case. Then we have our layers, okay? So if you look here, the first layer is called, the most inner layer is called the tunica interna, okay? So interna sounds like inside. That makes sense. It's the most inner layer. Great. So we check it off. Okay. Tunica media. Sounds like the middle. There's 3 layers. We just got to know there's 3 layers. There's the middle one. Tunica media. That's the middle one. Okay, great. And the tunica externa. That sounds like the exterior of a building. That's the most outer layer. There it is. So inside, tunica interna, the most inner layer. Okay. The middle layer, tunica media. Outer layer, tunica externa. Pretty cool, right? So now, remember that there are going to be bands of smooth muscle throughout this. Okay, I put it here to remind you that smooth muscle, and we're going to talk about this vasoconstriction versus vasodilation right now, is smooth muscle controls how the arteries are going to work, right? So hear me out here. If we have vasoconstriction, that is going to increase blood pressure. If we have vasodilation, that's going to lower blood pressure, okay? So I'll give you an example. If someone has a very, very high blood pressure, it's really high, right? Let's say someone's sitting in a chair and their blood pressure is 180 over 90. They are in some sort of vasoconstriction. They have to be. If the same person's sitting in that chair and they're resting and they're 80 over 40, they're going to be vasodilation. There it is. The bridge between the arterial side and the venous side is the capillaries. So what we have here is 2 different ways for the blood flow to go through the capillaries and make it to the venous side. The first option is capillary beds, and the second option is anastomoses, and we're going to talk about that. So here's what we have. So as blood comes through these small arteries here, it's going to end up in one of our arterioles, okay? Now, the blood has 2 options. Does it go through these precapillary sphincters that are laid across this capillary bed, okay? Now, normally there's, 1, 2, or 3 of these laid out. I just want to show you the difference between this and the anastomosis down here, okay? Now, as blood goes across these capillaries, it makes it to the venial, up to the vein. Pretty cool, okay? And this will get smaller and then larger as it goes up, okay? Just so you're aware. Now, you look and you go, what's this? What's this section here? So what it is, it's an arterial venous anastomosis. Now, what that is it skips the capillary bed. It's a bridge, it's a connection, direct connection, like a direct flight from the arterial side to the venous side. And this is what it is. You can see it right here. So this is what the capillary bed looks and feels like. Remember all the players here. The arterial heads down. We can go the anastomosis route or the capillary bed route. The sphincters, remember they're involved in opening, closing, and flowing. We're going to decide how that happens. There it is. My goal with this video is for you to understand blood pressure because people are going to be asking about you and what you're doing when you're taking a blood pressure and what their blood pressure ends up being and what's the top number, what's the bottom number, and it's important. You have to really understand this like a true professional, and I want you to understand this just as well as anyone. So here we go. Now, we first have to understand this basic buzzword. Okay, another medical buzzword. Here it is. There's systole and diastole. Systole means it's the contracting heart. Diastole means the relaxing heart. So when I say ventricular systole, it is the maximum contraction pressure. When I say ventricular diastole, it's the minimum relaxation. Because the heart's going to contract, relax, contract, relax. Okay? So now we know that. Let's dive into this. So the arterial pressure is a patient's blood pressure. We're just calling it blood pressure. But it's really, what is the pressure inside? What is the pressure? What's going on inside your arteries? Let's check it out. So we do. Now the systolic is the peak pressure, the highest pressure during ventricular, which is how we contract. Okay, ends in the ventricles. We know that. Heart blood flow, we did that already. It is the peak pressure during ventricular systole when the heart is contracting. So that's our top number, systolic. Diastolic is the minimum, the lowest pressure that we have, the bottom number, when the heart relaxes again. There it is, okay? That's blood pressure 101. This right here are two of the main ways that the body controls blood pressure and how the blood pressure leads to be at a given time. So first, we have baroreceptors. Now, a quick point before we get into this. In the aortic bodies, in the carotid bodies, are where you're going to find these receptors. Now, baroreceptors are really checking the pressures inside of the vessels and for any stretch in the receptors. That's the baroreceptor. It's about pressure. The chemoreceptors is nothing to do with pressure. It has to do with chemicals. So we're talking about pH changes, oxygen changes, carbon dioxide changes, cerebral spinal fluid changes. And that's how they'll respond to the differences. So one's about pressure, one's about chemicals. There it is. So what exactly is arteriosclerosis? Well, here it is. I'm going to lay it out for you, and I'm going to show you the two main pathways on how a patient can get it. So let's just go line by line here, okay? So first off, arteriosclerosis is the cause, the most common cause of strokes and heart attacks in patients. Now, you probably have heard over here in the corner of coronary artery disease, also known as CAD. If you see CAD in a chart, they have arteriosclerosis, okay? So what it is, it's a thickening or toughening of the arteries that supply blood flow. And remember, if it's in an artery to the brain, it's called a stroke, right? Can occur if it gets really bad. We're going to talk about it. If it's coronary artery, then it's the heart. And if it's another area of the body, it's another area of the body, right? So all kinds of arteries we talked about in the other video. Now, here's what it is. There are focal calcifications, or basically due to aging, it's also sadly a big risk factor of this with diabetes, is calcium deposits start making its way into the tunica media and it starts hardening up the vessels. Now, the other common way is the main root of arteriosclerosis is you have a high cholesterol in your bloodstream, And what's happening is you're getting lipid deposits into that tunica media. And it starts off where you can make changes, but then it gets to a point where you can't reverse the damage that's been done. So this is why, you may have, I know this is not EMS care, but we're going to see these patients when they're having the stroke, when they're having the heart attack, when they're having the unstable, angina or the stable angina, when they're having a TIA. You can now understand what's going on in their body, okay? Or if they have a risk factor. And what are the main risk factors? Well, smoking, age greater than 40, diabetes, high blood pressure, high cholesterol, and a family history of someone having a heart attack, I would say younger than 40. You could say younger than 50. You could. I would say younger than 40. That's really young, okay? So that's what we have here. That is what it is. Once the damage is done to a point with this lipids here, it can't be undone. You got to lower that cholesterol. It's so important. This right here may be the most important video that I make in this section. Whether you're an EMT, advanced EMT, or paramedic, you have to watch this video. And I'll try to make a point of it. Now, watch this entire video. So here it is. This is fetal circulation. Every level in EMT, you will need to know this. And this is one of the most common questions when we're talking about the foraminal valley, ductus arteriosus. Let's talk about it. So the first thing we need to know is if you haven't watched my heart blood flow video and you do not understand normal heart blood flow, you need to go watch that video now. I have a heart blood flow video in the accelerator, and I have one also in A&P. It's that important, okay? So go watch it. It's in the A&P section. You can watch it here, okay? It's right in this tab. If you don't know heart blood flow cold yet, then you can't. This is not going to make sense. So you got to watch that first. Then come back here. Did you do that? Okay, you're back? Okay, here we go. So I want you to think of the placenta as the fetal lungs. So when we talk about normal heart blood flow, what normally happens is, well, we have the SVC and the IVC. It's, remember, veins go towards the heart, arteries go away, and we have that blood coming back, right atrium, right ventricle, then it goes into the pulmonary circuit, and the lungs are over here. Remember that video? And the lungs have the oxygen. This is a totally different system with fetal circulation. The lungs are not turned on yet. The child is in the womb and doesn't take a breath. So the lungs don't turn on until the child takes his first breath. This system will change to normal heart blood flow, like we talked about in the other video, as soon as they take their first breath. Okay? Now here it is. So the placenta actually has the oxygen that we need to control our body. So what happens is we have umbilical arteries that actually go towards the placenta. And then we have umbilical veins that go away from the placenta. Okay? It's a little different. I know. Just hang with me, okay? So the umbilical arteries go into the placenta. The umbilical veins go away from the placenta. Okay? So if you think about it, hang with me here. I know this is a little complicated. Just hang with me here, please. And you can watch this video over and over. If we think about the placenta like the lungs, you know how the pulmonary artery would go towards the lungs? Well, the umbilical artery with no O2 is going towards the placenta. It's going to get its oxygen, and then it's going to go to the umbilical veins, like in an adult or a newborn who took his first breath. It's going to go through the umbilical veins like the pulmonary veins back to the heart. See the parallel there? Okay, now, umbilical arteries, they come back. We go here. We have umbilical veins. They're going to go through, essentially, just to be broad here, through the liver, through the abdominal section, until they end up in the inferior vena cava. When that blood is going up the inferior vena cava, we have oxygen. and the lungs are turned off. So now we just got to get the blood out to the whole body. So we go into the right atrium. So here's what happens. Blood's going to be moving in two directions. Some of the blood's going to go through this hole right here called the foramen valley that takes blood from the right atria to the left atria because we don't need to go to the pulmonary artery to go to the lungs. The lungs are off. Very little blood flow. Very little will end up going through that cycle. The majority is going through these holes. Okay? So we go right atria over to left atria. Okay? Now, some of that blood is going to still go down normally to the right ventricle. And it's going to go up to the pulmonary artery, but it's not going to go all the way. The majority of it is going to take a stop through the ductus arteriosus, which is right here. Before we go all the way through that pulmonary circuit, it's going to kick off and go through the ductus arteriosus, which is literally going to take it from that pulmonary artery all the way through to the aorta. There's no going to the lungs. There's no pulmonary vein. There's no left atria. There's no left ventricle. We're going to go straight from the right ventricle to the systemic circuit, which is the aorta. And we know the aorta's job is pumping it right out. So if we think about this, the right side of the heart is pretty important here. Because if our right side of our heart isn't doing very good because we have an issue, this doesn't look very good for the child. You understand that now? Now, I'm going to just go through it one more time. We've already done our job, and blood returns to the placenta, which is the oxygen center, the nutrient center for this child. So the umbilical arteries go towards the placenta. Okay. They get the O2 from the placenta, our nutrient center, goes out the umbilical veins, kind of like in an adult we have the pulmonary and artery veins. Goes through abdominal, some goes off in the liver, we go through IVC, right atrium. Then we have our foramen valley. Could go left atria. The rest of it is going to go down to the right ventricle and then go up a little bit and then go, nope, just kidding. I'm going to the ductus arteriosus and I'm going to end up in the aorta from the right ventricle. There it is. I would implore you to watch this video and take notes at least 2 or 3 times. If you know heart blood flow, cold. If you know fetal circulation, cold. Those 2 videos alone are going to take you from here to all the way up here. There you go. This right here is the first of our 2-part little section here talking about hormonal control of our blood pressure. Now this has a lot to do with our glands and the kidneys. So let's talk about it, okay? Because kidneys have to do with the absorption and reabsorption of fluids, okay? So here it is. Now first, antidiuretic hormone is released by the posterior pituitary gland, okay? When blood volume is low, it's going to cause kidneys to absorb and hang on to more water and also cause vasoconstriction. Now, one of the ways that ADH is released is through the presence of angiotensin II. So what happens is when we have low blood volume, an enzyme called renin will be released into circulation. What happens next, it gets quickly converted into angiotensinogen, which is basically an inactive substance. Doesn't do anything. Then it gets converted over to angiotensin II, which does something. It does vasoconstriction. Now, what happens next is when angiotensin II is released and it's doing its thing, causing vasoconstriction, it's actually going to turn on aldosterone and ADH, which are both going to also do vasoconstriction, but really they're the players that are going to really keep water on board to keep our blood volume at a good level, not get too low. So these two work together. Now I have two more in the next video that I want to talk about as well. We haven't covered yet, so let's dive into those two. Here we go. So here we have our final two players when we're talking about hormonal regulation of our blood pressure. Now, very important. This top one, EPO, still like angiotensin II, okay, like the other hormone we talked about in the last video. EPO has to do with blood pressure that is too low. Down here, ANP has to do with the blood pressure being too high. That's when it gets released. So hang with me. So, in a scenario where your blood pressure is too low, EPO is released by the kidneys. What it does, it stimulates red blood cell production, which gives you greater oxygen capacity and increases blood volume. Pretty cool, right? Now, ANP, I'll say it again, ANP is the one, you're going to get a test question on this. Which one of the hormones regulates your blood pressure when you have too high a blood pressure? ANP. Now here's what it is. I'll read it out to you here. When pressure's too high, reduces blood volume, it blocks ADH, it blocks aldosterone. We know ADH and aldosterone have to do with all that reuptake of the water and sodium. Okay. Promotes water loss, thirst loss. So it blocks this. Look what it does. This is amazing. It's incredible, right? ANP, it's going to say, stop being thirsty, stop taking in water, let's get it out of here. And then it's going to say, hey, arteries, stop being so tense, let's relax them a little bit. And then it says, we're going to really make sure, we're going to block aldosterone, sodium, we're going to block ADH, water. And now we're going to lower our blood pressure. Pretty cool? There it is. So there's a lot of talk about what exactly is an aneurysm. I'm going to define it for you here and make sure you understand it for life. Now here it is. An aneurysm, all it is a bulging of any blood vessel. That's what an aneurysm is. It's a weak wall that is bulging out. That's an aneurysm, okay? A ruptured aneurysm means the wall is completely broken. That means literally all our layers are broken in the blood vessel, right? Now, an aneurysm starts, this will make a lot of sense to you because you understand this now. It starts with a tear in the tunica interna. And as it gets worse, it becomes a real big tear, and that's how we get into our peritoneal spaces, right? And most commonly could be the retroperitoneal space. Okay, now here we go. We talk about bulging of a weak wall. Atherosclerosis, talked about that in another video, is the main culprit because that's what makes the walls weak. Talked about that already. Now here in the bottom, let's talk about this. A thoracic aneurysm is pretty much sudden death. There's a tremendous amount of blood pressure and volume going through that circuit. Those patients, it's usually a catastrophic event. Now, a ruptured abdominal aneurysm, we call it a AAA. But that patient, they're going to present with abdominal pain, back or flank pain, hypotension because they're bleeding out. And interestingly, if they're bleeding into the retroperitoneal, back where they're, hey, what's retroperitoneal? The kidneys. There you go. Remember that? They're going to have an urge to use the bathroom, defecate. Now, this is one of the biggest life threats, a AAA, that you'll ever see. By the time you get to someone who's had a thoracic aneurysm that's ruptured, they're probably going to be in arrest. There it is. These right here are the functions of the lymphatic system. So let's go through them. These are the main things. When you think about this system, you'll say, oh, that's what it does. Here it is. First, it's to fight and overcome disease by using lymphocytes. Now, lymphocytes, like we talked about earlier, are the specialized defender cells of this system that take care of abnormal cells, clean up debris, foreign invaders, overcome disease. Lymphocytes are the special defender cells of this system. Okay? Now, number two, we're going to talk about something called specific versus non-specific defenses in other videos. Okay? But these are basically the modes on how we defend ourselves. Okay? 3, balancing body fluids. So blood volume is balanced between the blood volume, the circulatory system, and the peripheral vasculature versus the lymphatic system. Okay? So there's a balance there. Can I give you a quick pearl? When someone has an overload of fluid and they have a high blood volume and they're in heart failure, they get lymphedema. That's a sign that there's too much fluid going on. Okay? Now 4 is how we actually distribute hormones and nutrients. So this system has a way of taking care of any hormones, nutrients, and even some waste products. It will help get that to the origin site where it needs to go. So here are the main players. We're talking about this system. This right here is the lymphatic organization. Now the first level we have is going to be vessels. Remember, there's 4 parts to the lymphatic system. This is the big key here. How many parts? There's 4. First is the vessels. The vessels is basically, think like blood vessels for the circulatory system. The lymphatic system has the lymphatics, it's called. The lymphatics, that's the vessels of the lymphatic system. And it goes throughout the entire body, okay? It ends at the venous system, is where it ends, okay? Now, secondly is the fluid. So lymph, like the circulatory system has blood, the lymphatic system has lymph. That's what actually goes around in the fluid inside the vessels, okay? Now there's 2 more parts here. We have the lymphocytes, which are specialized defender cells. And the final piece is lymphoid tissues and organs. Now, some organs, we'll name a few here. The thymus, it's right around here. The spleen, right over here, okay? What about lymph nodes, the tonsils? We're going to talk about all this in future videos. But these are the 4 parts of this system you need to know. These are the basics. Now here they are, the lymphocytes. Remember, lymphocytes are the main piece of this entire project, if you will, this entire system, if you will, or lymphocytes. Okay, you're going to hear a lot about these. You will get quizzed on these, which is why I'm making this video. Now, lymphocytes. They're broken up into 3 main types. T cells, which stands for thymus, okay, relating to the thymus, which is a organ we're going to talk about later on, okay. Bone marrow, deriving B cells, and NK, natural killer cells. That sounds like they're going to kill some cells. Okay, all right. So here it is. Now, let's talk about this. The T cells make up 80% of all this, okay? Now, there's 3 different types of T cells. Cytotoxic are the ones, think of like the infantry, they're going to do a direct attack on any foreign invader. The helper T cells are going to stimulate, while the suppressor T cells are going to inhibit. Those are the keys, okay? Now with B cells, they make up about 10 to 15%, okay? And the main one here we're going to look at is plasma cells. So these plasma cells are the ones that actually create antibodies. Okay? They have to do with antibodies. Okay? The NK cells are called the natural killer cells. These cells do something very important, which is called immunological surveillance. They're the ones constantly scanning the body for any changes, cancer cells, foreign invaders, animal-looking cells that are being developed. Okay? So here's what we're looking at here. These are the natural killer cells that will go out and attack as well, and they're always doing, this is the buzzword, immunological surveillance. You'll see that too. What you probably want to know about is, what does it mean when you have a swollen lymph node? So let's start with that first, okay? A swollen lymph node, what that means is it's a possibility. It could be benign or it could be something. You should get it checked out, okay? Now here's what it is. If a patient asks you about this, there could be some sort of bacteria or viral infection. It could be cancer. It also could be an endocrine disorder. Just want you to know that if you ever get a patient that says, I have a bunch of swollen lymph nodes, well, those are the possibilities. We have to get it checked out, okay? Obviously, do your vitals and do what you need to do with your patients. Now, with lymph nodes, there are two main things. The first thing is that lymph nodes are put around the body in certain locations to make sure that the lymph hits these nodes in order to be purified before ending up in the venous system. Okay? So think of the lymph node as purifying centers throughout your body. Okay? If they're swollen, that could mean that there's a bacteria, viral, it could be a cancer, or it could be finally an endocrine disorder going on. Or it could be benign. Okay? But there's the main details you got to know with the lymph nodes. So right here we talked about earlier are the types of defenses, but I want to categorize these that you're going to see when you're in class. So first we have non-specific defenses. Then we have specific defenses. So non-specific defenses will defend against nothing in particular, meaning there's not one infection or one virus or one bacteria, right? What it is, it's a defense against everything, okay? That includes like our hair and our skin would be a physical barrier defense. The skin doesn't just protect against one infection, it will go against all, okay? Now, specific is different. That is gained through exposure to a bacteria or a virus or infection or whatever it may be. And then that immunity, it can be developed. That defense can be developed against that one particular thing. I've seen that before. I'm going to go after that. That's specific defense, okay? Now, here are the types of non-specific. Physical barriers, inflammation and fever, immunological surveillance. Remember, the NK cells are the ones that do the immunological surveillance, always checking all the tissues in the body to see what's going on, okay? Inflammation and fever, we're going to talk about later on, okay? And then this has to do with the lymphocytes, with specific defenses. Seeing, oh, I see that. If I see it again, I'm going to attack it. There it is. These right here are our main players with the lymphatic system. We talked about the specialized cells. Well, now we're going to level up and we're going to talk about the glands and organs, okay? So the first gland I want to talk about is the thymus. The thymus is a pink gland that lies posterior to our sternum. Here's our sternum, posterior, behind, back of our sternum, okay? And the thymus, it reaches its maximum size as we grow into puberty. As we get older, we get smaller and smaller and smaller. Thus, if you think about this, what does the thymus do? Well, the thymus actually produces T cells, okay? Remember, T cells have to do with the thymus. So it produces, it deals with the function, and then releases when they're ready to be put out to circulation in the lymphatic system, right here, the T cells. Now, the thymus gets smaller and smaller as we get older, meaning So this is maybe one of the reasons why, as we get older, our immune system isn't as strong. Food for thought. Now, the second piece is our spleen. Now, our spleen sits, stomachs are right here, right around this section. Should be our left upper quadrant section, okay? The spleen, anytime you have get any trauma to the flank or anything like that, you want to really think about spleen injury. If the spleen ruptures, just a quick tip, if you have any blood expelling into the space, you can actually get a left shoulder pain when they get hit here. This happens about 40% of the time with spleen injuries. A quick tip, I had to throw it in because anytime I talk about spleen, I bring it up. Now, what does it do? It's going to filter the blood. It's going to store iron from recycled red blood cells. And it can actually call on T and B cells circulating in the blood to actually attack anything that needs to be dealt with, right? Any foreign invaders, okay? So here it is. Thymus and spleen are your two main players in this system. Fever is a normal response in our body's immune system, but we have to make sure it stays in check and doesn't go too wild. So let's talk about this. So in the body, there's a certain protein. It's called pyrogens. These pyrogens act on the hypothalamus, which is basically the body's thermostat, the hypothalamus. And those pyrogens raise the body temperature with the goal of increasing metabolism, which will make the cells move faster, which can help repair the body faster. So that's a good thing. If it stays then under 103, all right? If we start to get a fever that's too high, which it would be, I would say would be 103 to 107. This is where we can actually have physical stress on the body and have to damage ourselves. So, this is what we have here. Okay, we've pretty much gone over everything on this board. But this is what fever has to do with. The goal is to speed the body up to get more done, which is why you may get a fever. Okay, it can be a good thing, but it's got to be within a normal limit. This is what fever is all about. And then here are your numbers. Technically, anything greater than 99 is a fever. There are 5 main functions of the respiratory system. This is an overview of what the system has to do with. So the first most important thing is that the respiratory system takes air and it's going to exchange that with gas exchange. That's our oxygen and carbon dioxide. So air exchanging with circulating blood. Oxygen and carbon dioxide. That's number 1. Number 2, well, it's just the movement of air itself throughout the system. And we're going to talk about the anatomy of the system in a little bit. Third is talking about pathogen defense, invader defense. That it's a physical barrier to actually getting into our bloodstream, of course. Okay. Now 2 more. Sound and speech. Well, I'm speaking right now thanks to the voice box, the larynx. Okay. And finally, the 5th piece here we're going to talk about is smell, which everyone forgets, but we have a voice box, we speak, and we have to smell as well. That's number 5. So these are our 5 things that we're going to discuss in this chapter. I want to show you the pathway that inhaled air is going to go through. Now, the big first question, you see here I have nose with a star and mouth with a question mark. What am I going at? Well, the normal process of breathing is going to be breathing in through your nose. That's where air is going to come from. Could you breathe through your mouth? You could, but it's not proper. Okay? So the nose is going to be our primary activity. So we're going to talk about it in that way inside of A&P. Okay? Now, the nose, as air comes in through our external nares and it comes through, it's going to lead back eventually to what we call the nasopharynx. The nasal cavity is in there as well. Okay? Now, this is the upper airway to the lower airway. So here are the main players. We're going to go from the nares, the nose essentially, nasal cavity to our nasal pharynx. Okay? We have here an oral pharynx, and we have a laryngopharynx, okay? So these three pieces make up our pharynx, all right? Going down from the nose, oral cavity, moving down, okay? Moving down to almost to the area of our voice box, which is our larynx, okay? So the larynx includes the glottic opening, okay? Epiglottis, okay? Third, we have our thyroid and cricoid cartilage, our rings, which you can feel on yourself as well. And the vocal cords, our actual true vocal cords, how I'm speaking to you right now. So once we hit the bottom of that larynx section, that's it with our upper airway. So what does this mean? Well, I just want to tell you, if an infection comes down to here, we're now in the lower airway. If it's in here, it's upper airway. We don't want anything to go down here. Okay. Now here it is. The trachea is also known as the windpipe. It's the first piece of our lower airway. We then move on to the bronchi. Now here's the main thing with the bronchi. We have two main stem bronchi, the right main stem and the left main stem. After the main stem, we break into secondary and then tertiary bronchi as it goes down until it ends up in the bronchioles. Okay. So the bronchioles are right here. Now the bronchioles is where we talk about the asthma patient having constricted bronchioles and then albuterol dilating those bronchioles. That's the constrictor dilation part, those bronchioles, okay? The alveoli right here, that's when we talk about the alveolar duct and we talk about surfactant. That's our place we're going to find that, okay? Now, the alveoli is going to lead, not technically in this section, but on the other side, when we talk about a circulatory system, is our capillaries. The big player here is alveoli, is where gas exchange occurs. In the alveoli, through the transfer of those capillaries, that's where all the magic happens, if you will, okay? So, here it is. This is the flow of it. There's going to be another video here where I'm going to give you a worksheet on how to label some of this stuff. I'll see you there. So I've drawn out a normal capnogram. We're talking about end-tidal CO2. Now, I have other videos in the paramedic sections talking about this, but this is still part of A&P, so I do want to bring it up. Okay, now here it is. Now, it's multiple things I've laid out here. You can see A, B, 1, 2, C, D, E. What's that over there? We're going to talk about it. So here we go. So the first thing is, what are we even looking at here? What we're looking at here is someone who's inhaling and exhaling. Okay. Now think about this. What if patients inhale? What do I inhale? What do you inhale? Oxygen. What do we expire? Carbon dioxide. Right. So if I'm talking about this whole thing's talking about carbon dioxide, I'm talking about someone exhaling. This is correct. So here I am at the bottom here. Okay. So I call this section the A-B section. Okay. This is, you can see here the late inspiration. You can see here coming in. This is the start right here of early exhalation. There's no carbon dioxide at all at this. Excuse me. There's no carbon dioxide at this stage right here. Okay, we're at zero basically. Okay, this is all zero. Okay. Now, as we go up here, you can see at the B point, we start early exhalation as we move up. Okay. So now CO2 starts to appear and we go straight up in phase 2. Okay. You can also call it the BC section, whatever you want to call it. Okay. Now, as we get here, this right section here is called the plateau. This is constant CO2. Okay. This is the full exhalation moving. Okay. Now over here is our end-tidal CO2 points right over here. Okay. Now, why is it called end-tidal CO2? It's the end of that volume. Okay. It's the end of the exhalation. Okay. Now here, as soon as we start to go down, we start as it goes down, 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 bracket zero basically again. There's a respiratory pause. Okay. So this right here is your normal capnogram. Inspirations right after are entitled CO2. Now, again, you may need to watch this video once or twice to get it down cold. I have another video in the paramedic section that talks about all the different end-tidal CO2, capnography, stuff like that. I would go check the bottom of that section. We talk about all that stuff there too, but this is a normal capnogram for everybody. There it is. I've put together this video so that you can understand hypoxic drive. Now here we go. Hypoxic drive, what it is only found in advanced, severe respiratory disease like emphysema, chronic bronchitis. It's COPD. Okay, that's what we're talking about. Now, a normal patient works on a respiratory drive. What that means is right here. Okay, now I'll show you. This side is normal. This side is our COPD patient. So respiratory drive is controlled by the PCO2, the amount of carbon dioxide in our blood. When the body sees an increase of the carbon dioxide levels in the blood, what happens? We're going to stimulate respirations. When we see a decrease of carbon dioxide in the blood, we're going to inhibit respirations. That's under a normal patient. But here's what happens with COPD. What happens is the body gets used to the state of chronic hypercapnia, which means that your CO2 levels are chronically high. And as it gets more advanced, the body gets used to it. So the body says this. The body says, you know what? These levels are too high. I can't go off of this. I'm going to be stimulating my respirations all day long. You can't do that. So what it does, the body says, you know what? Let's change it and let's use hypoxic drive. And let's base it off our oxygen levels. Okay? So what this means is right over here. You can see here. Now, a COPD patient runs off chronic hypercapnia. Okay? So their PCO2 is normally very high. It switches now, instead of being regulated off of the PCO2, it's regulated off the PO2, which means if you give your patient supplemental oxygen, that's going to cause their oxygen levels in the blood to rise. And because they're running off a hypoxic drive, they're now going to start to inhibit their respirations because they have too much oxygen. Where they're normally, when their oxygen levels go down, they're supposed to breathe more. You see where I'm going? It's a hypoxic drive. So, what do we do with a COPD patient who can't breathe? What do we do? Do we not give them oxygen because of this? No. This is something, though, you should know about to not overload a COPD patient with oxygen. Our goal with a COPD patient is very simple. The family, a bystander, the patient, if they're unresponsive, you're doing way more things, and there's no one there, you're doing way more things than worrying about this, okay? If they're awake and talking to you, they are going to know if they have COPD what their normal oxygen saturation normally is. We want to get them back to that and not go above it, back to their normal. That's the goal. And this is hypoxic drive. There it is. Carbon monoxide poisoning is a catastrophic emergency because you don't see it coming. It's odorless, so you can't smell it. It's tasteless, so you can't taste it. You don't see it coming. 3 ways it usually happens. Automobile fumes, that's why I always gotta open the garage. Second is improperly ventilated heating systems. And the third piece with CO is an enclosed structure fire, okay? So with this, the big thing about CO, which is carbon monoxide, is that it has a 200 times affinity to hemoglobin, which we learned about how that all works, about buying oxygen in other chapters through this series. it's 200 times the affinity to the hemoglobin. So it literally, think about it like this. Imagine it kicking off oxygen and all the hemoglobin saturated heavily with CO. Oxygen goes down, you become hypoxic, and here's what happens. First, you become altered with rapid breathing, and then later on, you're unresponsive in a coma. This is why, especially in the fire service, this is so dangerous. There it is. This is what is measured when you take an ABG, or arterial blood gas. Now, I'm going to go through each one, but here's the big thing. An arterial blood gas, why are we even talking about it? Why is it even taken? It's taken so we can see these great numbers when we're talking about a severe respiratory distress patient, so we know what's going on deeply inside the body. It's different than what we get from the normal blood work. So we have to actually take a needle and we have to actually go into someone's artery and draw blood out. Okay, and it hurts. It hurts. A vein doesn't really hurt that much. An artery has a lot of sensory around that, and it can hurt. Now, the radial artery, brachial, or the femoral artery is going to be our choice. Now, here it is. First, we have our PO2, which is our partial pressure of oxygen. Secondly, you're going to get your partial pressure of CO2. Next, you're getting the pH of the blood. Next, you're getting the bicarb level, which is HCO3. And finally, the OHG, that's going to be your hemoglobin. Now, this is a great deal of information for that ER staff or EMS staff. Depending on where you are, who knows what people are doing. This is what you want to look at. There it is. Hey everyone, we're back with the respiratory section. I may even put this in the paramedic section as well. Now, if you are somebody who's an EMT or advanced EMT student, this is watching for fun. If you're a paramedic student, you would watch this because this could be a question that comes up. Not often, but this is getting to be a cornerstone of your paramedic care. You're going to go over ventilators at some point, so why not get a little lesson right now? Here we go. So ventilator modes. Now, there's how many things? There's 4 things that each ventilator is going to track, and there's 3 main types of ventilators you need to know about. So I'll say it again. There's how many? 4 things the ventilator is going to look for and 3 types. So here they are. Now, I put a check here because everyone knows respiratory rate. So we check that off. Okay. Now, tidal volume. I'm going to give you a tip, and I'm going to say it with you here. And here's my quick tip. It is not a rule, okay, but a quick tip if you get in trouble. Usually, the tidal volume of the patient should be 10 to 15 mLs per kilogram of body weight. It's not a rule, but it's a quick tip if you get in trouble. Now, the O2 concentration is the FiO2. That's how it's measured. You can see CmH2O is going to be our PEEP, okay? Now, what is PEEP? Well, it's the pressure at the end of expiration, okay? That's what it is. So the pressure at the end of our expiration is our PEEP. Now, there's 3 types of ventilators. Now, here's how I break it down, okay? One, which we're going to talk about, I'm going to go through it, okay? So I'm going to give you a quick tip here. The first type, I always think of as the full control ventilator. The patient is not breathing at all. They're apneic. They're not breathing. So we're going to control everything what to do with the patient. No breathing in the patient, full ventilator. I like to call it the full control ventilator. Now, it's called the CMV setting on the ventilator. Because when you have a ventilator, you can have different setups, okay? Well, what kind of patient do you have? Like any other device. Now, I put a few buzzwords here because you might hear this out in the field. Put them in AC mode. Put them in assist mode. The proper is ACMV, okay? Now, here it is. This section, I like to consider this section. And here's what it actually does as well. It's going to assist with the volume of the breathing of the patient, okay? If the patient tries to take a breath, it's going to assist it through and give it an extra breath, okay? Now, and I'm going to go through these just to make sure we covered you good. Now, the final piece here is the SIMV. And this one is what I like to call the intermittent ventilator. So what that means, we all know what that means. Well, patient breathe, then I'm going to breathe. Patient breathe, then ventilator. The patient breathe, the ventilator. So it's intermittent breathing, okay? So let's just go through this. Now, I'm going to read these out to you just to make sure it hits home. CMV, used usually in apneic patients, set by EMS rate, full control. ACMV, AC mode assist control, you can see here, you set the minimum rates on AC mode, the minimum rates. The patient tries to breathe, an extra breath is delivered. And finally down here at SIMV, there's no breath assistance as far as volumes or extra breathing, okay? But times the breathing in between patient breathing. So patient breathe, now I'm a ventilator. Patient breathe, now I'm a ventilator. There it is. Here we have the 6 functions of the digestive system, okay? Now, here we go. We go from ingestion to mechanical processing to digestion, secretion, absorption, excretion. Now, let's break it down. Ingestion is when food enters the mouth. Simple as that. Mechanical processing is how the tongue, teeth, and later the GI tract manipulates and moves around that food bolus. Now, the third piece is right here, digestion. Okay, now what that means is the chemical breakdown of food into small organic molecules that the body can then absorb into the digestive epithelium. Remember the epithelium chapter? Well, here it is, okay? Secretion talks about water, acids, and enzymes. Absorption talks about electrolytes and vitamins. Excretion is removal of waste. So here is the functions of the system that we're going to talk about. Here we go. So here are the swallowing steps. Now, one thing you're going to talk about a lot is the process of swallowing. So you're going to hear, now, the whole part of the digestive system is to take this food. Let's say you're eating a piece of chicken, for example. This piece of chicken uses teeth to tear and shred that chicken into what we call a bolus of food, okay? Which is basically a digestible portion that is wet enough to get into the esophagus, go down it, as the stomach, be able to then move to the stomach process, which we're going to talk about later on, okay? Now, here are the steps of swallowing. First, there's an oral phase. Your teeth in this oral phase are going to tear and shred whatever it is you're eating. Then, your tongue, the other receptors in your mouth will realize it's time to swallow. What's going to happen next is that food's going to go up against the hard palate and be pushed back into the pharynx. Then we enter the pharyngeal phase. The pharyngeal phase is the involuntary swallowing reflex. This is the subconscious swallowing section here. So this is more conscious in the oral phase. Once we get to here, it just kind of starts to go through on its own. Now, the esophageal phase is when the bolus enters the esophagus and slides down, okay? Now, final phase is when the bolus actually hits the stomach. And this is how we get, for example, a piece of chicken to end up in our stomach. We got to turn it into a bolus. There it is. This chart right here is going to explain gastric activity in the stomach. So here we go. So gastric activity in the stomach, there's 3 steps. So here's something pretty crazy, I'll tell you. As soon as we smell, as soon as we, taste, of course, makes sense. Or as soon as we see food. So we don't have to be eating it yet. We could smell it, we could see it, we could taste it. Just seeing food or smelling food causes the CNS to start the gastric activity in the stomach. We may not even be eating it though. Think about it. This is called the cephalic phase. So this prepares the stomach to actually receive the food contents because it smells it. It must be coming. Pretty crazy, okay? Now, the gastric phase is the second phase. This is where food, which is a bolus, called a bolus at this point, enters the stomach. This bolus is going to be changing names into something called chyme. Okay? This chyme is going to be moved through into the small intestine throughout. Okay? Now, this happens by producing a hormone. Okay? It's called gastrin. So the gastrin hormone, once that is released, what we have is this. We get stomach contractions, which churn and turn this bolus into a chyme. This chyme is then passed off to the small intestine. And this is the final phase, the intestinal phase. And we go through the small intestine. Eventually, we'll end up in the large intestine. And we go from there. So, there it is. Now, there are over 200 functions of the liver. But these are the three most important ones here. Now, all I've done is put the words here. I'm going to explain to you here what this is about. So first, we have metabolic regulation of the liver. What does that mean? Well, what it means is this. The liver is first to absorb any nutrients, any toxins, any excess. That is going to be the first most primary function of the liver. So before it even gets to the circulating bloodstream, it's got to go through the liver. Remember, the liver is going to metabolize everything first. Okay, that's why you think about an aging liver, it goes through a lot of stuff, right? But the liver is almost, do you think about the metabolic regulation? It's like our first offense, but also our first absorption point of nutrients. So that's the first thing I want you to know. First absorption point, but also going to take care of toxins before it reaches the bloodstream. That's number one. Now, number two, we talk about hematological regulation. Well, the second piece here, this is a two-part piece when we're talking about the hematologic regulation. The first piece is I want to give you two examples. One with the immune system, and two, we talk about regulating glucose and insulin. So if we have a blood sugar that's too high, what the liver will do is store glycogen. Okay, because we don't need it right now. Let's store it up. It's regulating, okay, on the bloodstream. Now, what if our blood sugar is too low? That storage, it will release it, right? So the liver is storing and releasing depending on what's going on in the bloodstream, okay? Hema, blood, okay? Also has to do with the part of the immune response as well. Again, it helps out with that, okay, in all of the concentrations. So this is a big way I think about the liver. The easiest way to remember it, I for my students and for you here, is talking about the storing of glucose and then of glycogen, and then the release of glycogen on blood sugar levels. That's how you remember the second part. Now, the third part is we talk about bile. Now, I talked about bile earlier. We talked about, okay, what if we have chyme, has a lot of lipids, protein. Bile is going to go help out to get that process done in the digestive system. So bile is going to help out with that. It gets released right into our small intestine. So bile production is part of the liver as well. So those are the three main things that the liver is going to do. It's going to metabolize first, meaning that any toxins, any nutrients, it's going to pick up on it. Two, it's going to help out regulate what's going on in the bloodstream. I gave you the glucose example. And the third piece is the production of bile that can get injected into the small intestine to help out with the process of digestion. There it is. So now we're moving on to the gallbladder. Now the gallbladder essentially, I want you to think about it as the liver's best friend. We talked about bile with the liver. Now, the gallbladder has one job, not 200. Its one job is to be the main storage of bile. Okay? So we talk about secreting bile and storing bile. Okay, that's going to be the gallbladder. Okay? Now, remember I talked about CCK hormone is going to release the bile into the duodenum to help out with digestion. Okay? Now, if bile salts get too concentrated, they're too concentrated inside of the bile ducts, what can happen is a gallstone. Okay? Now, a gallstone presents with right upper quadrant pain. There can be right shoulder pain as well. That's referred pain. Okay? Very, very high in pain scale. Okay? Think about a kidney stone, how much it hurts. Same with a gallstone. You may think it's a heart attack because it's an upper quadrant pain. Not going to hurt to do an EKG. I'm just telling you that it's right upper quadrant. Okay? Right shoulder pain. Now, the other thing about it is you'll get nausea, vomiting, and you'll get cool, clammy, pale skin. But if you have that bile leakage or the gallbladder was to erupt, you might get a septic patient because of the leakage into the peritoneal cavity. Now, if that happens, you're not going to have cool, clammy skin. You're going to have warm skin. So are they distended? Right? That's going to be the question there. So just a quick tip, but any right upper quadrant pain acutely could be a gallstone. There it is. After food is turned into chyme from the stomach, we then are going to reach to the small intestine. Now, the small intestine, if I give you one pearl, the small intestine is where the bulk, about 90% of absorption of nutrients occurs. The other 10% will occur in the large intestine later on. So we go from the stomach to the small intestine. Okay, so now we're in the small intestine and we are called chyme. Okay, so here we are. Now, what happens is the first section, the duodenum, is, remember, it's the closest to the stomach. It's connected. It's coming. Stomach links off to here. Okay, duodenum. Okay, it's also the loop of it encircles the pancreas. From the majority of it, the pancreas is on this side, and but a little bit comes in over onto the right as well, on the upper. Now, the next piece here, our second piece, is actually the area where most of the absorption occurs. In this area right here. This is very important. And the third piece right here meets up with the first part of the large intestine. So we go 1, 2, 3. Now, one more pearl about the small intestine. The small intestine actually makes up the bulk of our, so if you say, what's the bulk of the, for lack of a better word, stuff inside of our abdominal cavity? It actually is a small intestine. Is a large amount of space in our abdominal cavity. And remember, it's essentially is straight in the middle of our cavity. That's something to remember as well. The large intestine, which you're going to see in your worksheets, is around. In the middle is our small intestine. When people talk about the mesentery, it's a sheet that kind of lays over the small intestine. This is what they're talking about, the mesentery. This is the small intestine area. Just a quick tip. Now here we are, the large intestine. Now the large intestine basically makes a trip around, which we're going to talk about. I want you to remember this for the rest of your life. Watch this video a few times, you'll have it down cold. Now, the main part of the large intestine is that the large intestine is going to reabsorb water. It's about 10% of the vitamins, the absorption. The other 90, remember, is in the small intestine. And then finally here, the goal is to get chyme from the small intestine and then turn it over to compact it into feces. Now here it is. Right here, we have our last piece, right, of our small intestine coming in, okay? The ileum here coming in, right? Now, as it comes here, we have the ileocecal valve right here. This valve right here that brings the chyme in to this quite large space called the cecum. Now, the cecum is going to compact that and turn it into feces. And we start that absorption process. Now, the appendix just loops off right here, okay? Now, we have the ascending going up, the ascending colon, the transverse colon, the descending colon, the sigmoid colon. This right here, this sigmoid colon is diverticulitis land. This is where diverticulitis and losis all happens. The descending and most importantly, into the sigmoid. Right here, my left hand, left lower quadrant pain, it could be commonly diverticulitis, which is little pockets in the sigmoid colon get inflamed with feces. The rectum, we go out and then into the anus, and there is our large intestine. These right here are your GI hormones. So let's break them down step by step. Remember, when there is a hormone, there has to be something that happens, a stimulation effect, for it to be released. And then there's a reason why it's being released, and a target where it's being released, and an origin where it's being released. So here we go. So first we have gastrin. Now gastrin is released by either CNS when we smell, or we taste, or we see food, okay? CNS, or food just happens to arrive. Well, it's getting released. It's all in the stomach with gastrin. Now, it's going to stimulate the production of acids we got to break this down. We got to turn a bolus into chyme, okay? Now, secretin. As chyme appears in the duodenum, the big key here is this. When you think secretin, I want you to think that something with a high acid, chyme with high acidity, is lowering the pH of the duodenum. Because it's so acidic, we need extra help from the pancreas, from the stomach, from the liver. So what we get is an alkaline buffer from the pancreas. Bile actually gets secreted in to the duodenum to help out with this process, because the pH of the duodenum is going down because it's so acidic. That's the issue. We have an acidic chyme. CCK. Now, if chyme appears with a lot of lipids and a lot of protein in the duodenum, here's what we get. We get the release of some pancreatic enzymes. We get a contraction of the gallbladder. We relax the bile ducts, and because we now have lipids and proteins, the CNS goes, all right, well, let's relax our hunger. We have some good food here. Let's relax our hunger, okay? Now, GIP. Now, what if chyme enters with a lot of fat and a lot of glucose? Well, it's in the duodenum. Well, what do you think is going to happen if we have a lot of fat and a lot of glucose? We're going to tell the body that it's time to release insulin, right? We have a lot of glucose, a lot of fat. Let's do the insulin. So there it is. And obviously, we're going to inhibit that gastric secretion, okay? Because it's already gone through the system. Now we're over here, okay? We're in the duodenum. So there it is, folks. These are your main hormones. Gastrin, think stomach. Think, I have food. It's got to be broken down. Secretin, remember, think, wow, it's pretty acidic chyme. We got to help out, okay? CCK, that's going to be your proteins. It's going to be your lipids. And this is going to be your fat and glucose. We got to release insulin. Glucose, remember in our other chapters, glucose, insulin go hand in hand. There you go. What I want to discuss now is esophagitis, and I want to discuss what that is, and a hiatal hernia, what that is, and I'm going to show you an illustration, and we're going to do it live. So here it is. So the first part, anything that ends, like I tell you, in an itis, is an inflammation of whatever we're talking about. So esophagitis is the esophagus that is inflamed. Now, here's what happens. The esophagus going to the stomach, there's a sphincter, okay, that goes from the esophagus to the stomach. It's called the lower esophageal sphincter. Now, what happens is, if that becomes weak, that becomes too relaxed, strong gastric acids rise up into the esophagus. When that happens, it erodes and inflames the esophagus, causing, oh, I have acid reflux, oh, I have heartburn symptoms, right? Now, that over time can cause the inflammation of the esophagus. That is completely different, but then what we're talking about down here, which is hiatal hernias. The reason I'm putting them together is because it always gets confused. This is completely different. So here it is. An hiatal hernia, let me put this down. A hiatal hernia is when an abdominal organ, it's the stomach, okay, slips into the thoracic cavity through the esophageal hiatus. Now, what is this about? Okay. Well, I have my diaphragm, sits right around here, okay? Well, my esophagus needs to get to my stomach. There's a hole in there called the esophageal hiatus, okay? This esophageal hiatus you can see right here. This is my diaphragm, okay? This is my stomach. So this is normal. Now, here's what happens when we have a hiatal hernia. This stomach is going to protrude like this. And a piece of the stomach is going to go right through, let's just say, here's the rest of the esophagus. I'm going to have a piece of stomach coming out of here. So this is all stomach right here. And it protrudes through here. So I got puffy stomach hanging out above there. That's what we end up having. And it's going to cause immense pain if it's bad enough. And you're saying, wait, what do you mean bad enough? Well, here's what it is. Some days go unnoticed for a while. And then when it starts to show little symptoms, you go to the doctor, oh, you have a hiatal hernia. Some are just really bad right away, and they get noticed right away. So that's going to depend on your patient, but something to keep in mind, hiatal hernias. Many people have heard about it. Let's talk about ascites. So you may know it's just a swollen abdomen. Okay, well, what does that mean? Well, here's what it means. Our organs inside our abdominal cavity, it's called the peritoneal cavity. Inside that cavity, there's a thin lining, and that lining has fluid in it, peritoneal fluid. If that fluid is off balance and there's an overload of fluid, your abdominal region swells, and it's called ascites. So what ascites presents like is the patient may complain of chronic heartburn, indigestion, low back pain, abdominal pain, a swollen abdomen, because their organs are being squeezed and pressed, okay? Now the causes, liver and kidney disease and heart failure. Think of patients that have too much overflow of fluid may have it. There it is. So right here we have our urinary system functions. Now we've already talked about the digestive system. That's where we take a bolus into chyme, and then feces, and out of the body, along that pathway absorbing nutrients. The urinary system has to do with fluid. So let's talk about it. So first, the urinary system does a lot more than that. So first, it's going to regulate our blood volume. And we're going to talk a lot about that later on in the chapters, regulating blood volume. 2 is regulating the concentration of ions. This is going to be number 2. Number 3 here is stabilizing blood pH. Talk about acid base. We're going to talk about that. Okay. And then 4 is conserving nutrients. This is the last stop to conserve nutrients on the way out. Just like we talked about with digestive, this is urinary. Here we go. So now I want to discuss the actual pathways of urine throughout the urinary system so you remember it cold. This will probably be on a lot of your quizzes. Now, first, we have four players here, four main players that we're going to discuss. So first, we have the kidney. The kidney is going to be responsible for urine production, okay? Next, the ureter. And the ureter is going to transport urine between the kidneys towards the bladder, okay? Now, the bladder is going to temporarily store urine until it is ready to be expelled. And then finally, the urethra is going to flow urine outside the body. These are our four players in the urinary system as far as the pathways that urine will take from the kidneys throughout. There it is. This right here is the renin-angiotensin system. Now, real quick, the renin-angiotensin system is used in the body when blood volume is too low. Down here, the opposing system using ANP, that hormone, that is when blood volume is too high. So here's what happens, okay? Renin is released. Renin then turns into inactive angiotensinogen. Then angiotensin 1, angiotensin 2. Once we have angiotensin 2, we now have something to work with because our blood volume is too low. We need to bring it up. So what angiotensin 2 does is it causes vasoconstriction in the inside of the capillary beds. That raises blood pressure. That's great when our blood volume is too low. Good. What it also does is it stimulates the release of ADH and aldosterone, epinephrine, and norepinephrine. Epinephrine and norepinephrine are going to raise your blood pressure, obviously, and increase cardiac activity. Now, aldosterone is going to help by reabsorbing sodium. ADH is going to help out by reabsorbing sodium and reabsorbing more water. So angiotensin 2 hooks up with ADH and aldosterone all together to bring our pressure up because our volume's too low. Think about it. The body's going to let's hang on to our fluids and let's raise our pressure because our volume's too low. When our volume is too high on the other side of this line, other side of the train tracks, okay? ANP. When it's too high, a few things happen. First, we tell the body, okay, let's increase water loss in the urine. Let's get rid of water because our fluids are too high. The second thing that it does as well is it says, let's stop reabsorbing water. And the third most important thing that ANP does, what ANP does is it tells the body to inhibit renin, inhibit this whole system from being turned on. There it is. Now, like some of the sections, this is mainly a paramedic level topic. I have another video that goes over this in a little bit of a different way over in the Paramedic Accelerator. It's near the bottom of it. I talked about it in earlier videos. But I wanted to make it another way of looking at it with this little chart here. So here it is. So acid-base disorders, what we have here is we can have an acidosis, we can have an alkalosis. It can be respiratory-based, it can be metabolic-based. So let's talk about it. So here we go. Let's go line by line. So respiratory acidosis is when the pH is too low. It's below 7.35. When that happens, what we have with our patients is they are not being ventilated properly. Okay? There's a buildup of CO2. Okay? It's hypoventilation, and there's a buildup of CO2. So what we got to do if we have a patient, we need to improve their ventilations. Maybe it's a bronchodilator to get them to breathe better. Okay? In this case, we need to breathe a little faster. Okay? And the other case is going to be, they might need a mechanical support, like a BVM. Okay? So that's going to be respiratory acidosis. And now I'm just going to go to the other respiratory to see the difference. Respiratory alkalosis is too high. So that's 7.45. Now with the actual respirations, it actually kind of goes with it because the respiratory rate is too high in this case. So what's happening in this case is we are, in our body, we have too low levels of CO2, okay? We're too low on our CO2 here, and we're causing hyperventilation, okay? So here we're hypoventilating, here we're hyperventilating. Now, a way to remember that, which I think could help you, would be this is too low of a pH, and that's hypo, which means low. This is too high of a pH. This is hyper. That could help you, okay? Now, we have to reduce the respiratory rate, and if we do that, we need to get their CO2 up, okay? So hopefully it will rise. Now, metabolic acidosis. We know if the acidosis is lower, so 7.35, what we're going to have, in this case, is a buildup of metabolic acid, and we're losing that bicarbonate. So what we need to do here is basically we need to give bicarbonate if possible and figure out the primary reasons of why this happened. Now, the metabolic alkalosis, if it's a little higher than 7.45, it's not a great big emergency. If it gets a little higher, 7.50, 7.55 especially, it gets really high. Let me just tell you real quick. Vomiting and fluid loss is what's going to cause this. EMS may not do this, but in the hospital, you would give ammonium chloride to this patient. This is probably the most rare one that you're going to see, a metabolic alkalosis. These are going to be more similar as far as what you might see on a day-to-day basis with a patient. And with our end title, we're going to be able to see a lot of this stuff. Again, here's what I want you to do. I want you to watch this video over 2-3 times, and then I want you to follow up if you're a paramedic student. Go watch the paramedic accelerator where I go over this as well. Combine them together, you're going to have this down cold. There it is. I want to briefly discuss kidney stones and UTI. Now, the most common kidney stone is a buildup of calcium that creates this crystal formation that turns into a stone. Now, there are different types of kidney stones, but first let me just tell you how they present. So, remember the kidneys are retroperitoneal. That means they're behind everybody else in our abdominal cavity. They're behind that abdominal cavity. They're retroperitoneal, okay? Now, with that being said, that's why you get mid-low back pain and you get flank pain with a kidney stone, right? Now, the pain with a kidney stone happens acutely and severe. So the goal is pain control and hydration with kidney stones for EMS. But now I want to talk about different types of stones, okay? So you may see these. Now, if a patient has gout, you can get a uric acid stone, okay? So gout has to do with uric acid levels, okay? Gout is a risk factor of getting a kidney stone, all right? Now I want to talk about UTIs and recent catheterizations for kidney stones. Now what this means? What this means is if you are someone who is chronically getting UTIs or chronically needing urinary catheterization, like a urinary catheter put in place, you can get a certain type of stone called a Sturvite stone, right? So let's say someone has had a recent UTI and now they present kidney stone-like, could be that type. Now that's where we're at. Now here's UTIs. So UTIs either affect the lower or the upper part of the urinary tract. We know the upper part is our kidney, the lower part would be prostate, would be the bladder, would be the urethra, okay? Now how do they present? Well, they present, could be altered mental, okay? Could be a fever, so it could be hot skin. The other thing that we want to look at too with UTI is a foul odor of their urine. So a not very good smelling urine, a burning sensation or a pain when they use the bathroom. Again, could be restless, altered mental, okay? We see this very commonly in nursing home patients, right? Or patients that are in a community where there's infection. this is the biggest thing with UTIs and kidney stones. I just want to make sure you're aware of it as we're covering this section. Renal failure and what is hemodialysis? So renal failure can either be acute or chronic. If we have somebody with acute renal failure, that is someone who's lost a tremendous amount of their production. So let's talk about this. Now, there's three main pathways to renal failure. The first pathway that we have can be blood flow is blocked going to the kidney itself. Okay, that's called pre-renal failure. Now, if the kidney itself is damaged, like in a trauma situation, that would be renal failure due to the kidney itself being damaged because it can't work. Okay. Now, the third piece would be a blockage of the urinary pathways that we talked about earlier that would cause renal failure. Now, when I say renal failure, what do I really mean? What I mean is we have an electrolyte imbalance in the body and we have toxic substances in the body that should not be there. So it causes the entire body to be unregulated, thus causing the patient to have a bad outcome if they don't get treated. Now, prior to the 1960s, dialysis wasn't even around. Patients with acute or chronic renal failure, they just passed away, unfortunately. But now we have dialysis, okay? So how do we fix renal failure? Well, the patient, obviously, we need to regulate their electrolytes, and we need to get rid of the toxic waste. If there's a blockage, we need to fix it. If there's something wrong with the kidney, we need to fix that. So here it is. Now, dialysis is used. It could be in an emergency situation. It could be for acute. But when we think about dialysis, it's a chronic thing. With chronic renal failure patients, what we have to do is they have to go to dialysis for about 2 to 3 hours, 2 to 3 times per week. And if you do transports, you'll be taking those patients and you'll be doing dialysis here, okay? Now, what happens there is they'll have a shunt, okay? It's usually in their arm, a shunt, where that shunt will be connected to the actual dialysis machine, where what's going to happen is they're going to regulate their electrolytes and they're going to get rid of all the toxic substances. Essentially, if you kind of think about it, purifying and getting everything back to where it should be. So this is dialysis and renal failure. Remember, there's 3 pathways. I want to briefly go through some of these male disorders on the male reproductive side. Now, these could be injuries, these could be inflammations, these could be infections. But I want to talk about them because you're going to hear these buzzwords and you got to know what this is. You can't have no idea, okay? So we're going to talk about males first, then females second, and we'll do the same list, okay, like I did here. So first we have testicular torsion. So what that is the most common cause of scrotal pain is actually testicular torsion. Now this can result in a loss of blood. Now, let me explain. What happens is one of the testicles gets turned in a way. We're going to talk later about the torsion for females. Now, for males, that testy can get actually moved in a certain way. When it gets moved in that certain way, what can happen, it gets turned, it basically shuts off the blood flow to that testicle. So you need emergency surgery to get that fixed. So how does that happen? It could happen, move randomly during puberty, but most commonly the strenuous physical activity or athletic events. Testicular cancer, I'm just bringing it up because it is rare, but it most commonly happens in 15 to 30-year-olds. Okay, 15 to 35, 15 to 40 is usually the range. Now, without even saying this, okay, you can just see it here. Okay, we have an itis in the prostate. We know it's an inflammation of the prostate, but so we talked in another video about UTIs. Okay, so this is bacteria infection of the prostate itself. So the inflammation of the prostate due to a bacterial infection is most common. It can present like a UTI, but ends up being the prostate. So there could be burning urination. They could have some lower back pain, some rectal pain because it's back there in that realm. Then also here, pain on urination. Okay, so those are the big players here with an inflamed prostate. Now, finally, here we have priapism. So what priapism is, it's idiopathic, meaning it has the erection has nothing to do with being turned on by sex. What it has to do with is something physical going on in the body that's causing it. So it's out of your control. So priapism, it's prolonged erection, hours, they talk about, over 3-4 hours long. And what this is you have the blood basically staying in the penis, right? And it won't get out. It stays in there. So here's why it happens. Impotence, drugs, meaning you're using drugs to gain erection. Sickle cell disease and spinal trauma could be some of the idiopathic reasons why this happens. Okay? So there's something to keep in mind. These are the buzzwords for male disorders. Next, we're going to do female. Here we go. So now I want to go over the female disorders. We're talking about the reproductive side. Now, I'm going to start from the top here. Okay, now it's in the corner, but don't think it's not important. This is pelvic inflammatory disease. Now, pelvic inflammatory disease is one of the most common reasons for abdominal pain in women of childbearing age. Okay? Now, what this is an inflammation. It could be a bacteria. That's pretty common, but it could be all different types of substances that cause this infection. Now, with PID, if someone has chlamydia or gonorrhea as an STD, this could be what's causing the PID. Okay? Sometimes it's asymptomatic. Sometimes it's symptomatic. And it's moderate to severe abdominal pain. But this is something that I did want to touch on. It's called PID, pelvic inflammatory disease. It infects all of the main players, uterus, fallopian tubes, all the main players inside the female reproductive side. Okay? Now, Mittelschmerz. What does that mean? All that means is abdominal pain mid-cycle. That's all. Okay? Middle sounds like the middle. So mid-cycle is the way I remember it. Okay? An ovarian cyst. And here's a big one. There can be a torsion of the ovary due to a cyst. Okay? It also could be that the cyst ruptures the ovary. There can be a torsion of the ovary. That's one thing in itself. There can be a cyst on the ovary that ruptures. Okay, these are two main pathways. But they present very much the same. Abdominal pain, back pain, nausea, vomiting, and you might even get like a weakness or dizziness. Okay? It sounds almost like a heart attack almost, right? For a female. Oh, I'm weak, I'm dizzy, I have abdominal pain, I'm nausea, vomiting, right? But something to think about here, ovarian cyst. Here's the big problem. The big problem is blood could spill if it ruptures into your peritoneum, then you become septic, right? So that's the big issue. Like anything that would rupture in your abdominal area. Now, here's the big thing. TIS versus SIS. Okay, so an osis and an itis. Okay, so let's start with the itis here. This is infection of the uterine lining. There's usually a foul or bloody discharge. You can see here, there's also fever, abdominal pain. Now, endometriosis. Very interesting. Hang with me. This is where endometrial tissue is found outside the uterus. So the tissue that is normally found in the uterus is found somewhere else, usually in the pelvis or the abdomen, but it could be anywhere, okay? And that tissue actually bleeds on command with the cycle, okay? That is endometriosis. Amenorrhea. Amenorrhea, all it means, remember, A in medicine means there's nothing going on. Menorrhea, talking about the menstrual cycle, there's no menstrual cycle. Okay? That's amenorrhea. So here are some of the buzzwords you're going to hear with female disorders. Now you know them. You might need to watch this again if it's your first time ever hearing these words, but now you got them down. Good job. Now, insulin is secreted by the beta cells. When I say insulin, I'm talking about beta cells. Do not forget that. Insulin is secreted by beta cells. Insulin beta. When blood glucose is increased. So when we have extra blood glucose going on in the bloodstream, well, we got too much going on here. Let me get some insulin going. Right. Functions. It's going to increase the glucose into the cells. So insulin is the key that gets glucose from the bloodstream to the cell. Okay? Next, we have an increase. It increases glucose metabolism by cells. Talked about that already. Also increases liver glycogen levels. So remember, the liver is going to store glycogen. Right? Good. Next, where it is going to decrease blood glucose to normal levels. Let's say I take a bunch of sugar, it's bouncing around my bloodstream. Insulin's going to regulate it, we got to get back to normal. Right? There it is. Now, we have a key term. Glycogenesis is a process that turns extra glucose into glycogen to store in the liver. So now let's talk about the next piece, which is the actual glucagon. Here we go. Glucagon is a protein that is released by the alpha cells. When I say glucagon, you think of alpha. Okay, alpha glucagon, protein released by the alpha cells when blood glucose decreases. So you may have heard we talk about glucagon, right? You got a patient, they're a diabetic. They got a low blood glucose level. We hit them with glucagon intramuscularly, right? What does glucagon do? Well, it goes to Mr. Liver, says, hey, liver, you got glycogen stores. Can you release them into the body? Goes, sure. And then our patient wakes up. This is why in the ambulance, again, we give glucagon to raise the blood glucose. Now, there's two main functions of glucagon. Number one is to increase blood glucose by stimulating the liver to release glucose from glycogen that's stored in the liver. That process is called glycogenolysis, which breaks down glycogen into glucose. Now, the second function of glucagon has to do with the stimulation and breakdown of fats into glucose. This is called gluconeogenesis. Now, with this function, this would be an example of someone who, let's say, is on a keto diet. They don't have any carbs in their body, right? So what must happen? They must break down fats in order to get energy and glucose. And there it is. So now I want to talk about immunoglobulins, also known as antibodies. So first we have IgG. This is the most abundant and is 70 to 75%. So it's present in the lymph, CSF, synovial joint fluid, and peritoneal fluid. Now, this is the big key with IgG. You may have a test question on this, so please hear me. IgG is the only one that crosses the placenta plus gives the neonates temporary immunity. Okay? What antibodies have to do with is giving your body immunity. That is what this has to do with. Okay? Now, IgM, 5-10%, produced early in the immune response and triggers production of IgG in acute infections. Now we got three more. IgA is at 15%. This is found in blood, tears, saliva, the respiratory tract, stomach. This combines with protein in our mucosa to defend body surfaces against microorganisms. Now, one thing I need to talk about here, how our body reacts to, and our immune response, how our immunity, how it reacts when we have an actual allergic reaction or anaphylaxis. So hear me on this, guys. With IgE, it is less than 1%. When I say IgE, you think about white blood cells. It's less than 1% of all of these. Now, it's found in surfaces of basophils, mast cells, those white blood cells, and that is what creates, the IgE, is what creates the immediate hypersensitivity reaction. What this means, if you don't know, I was trying to plant something in your brain. When someone has an allergic reaction, the body, let's say, for example, you're allergic to peanut butter, right? well, the body, peanut butter, you shouldn't be allergic to peanut butter. But what happens is, for whatever reason, your body picks up on that peanut butter and goes, oh, this is something bad, so a foreign invader. Let's have a reaction. Right here. So basically, when we have this kind of reaction, like allergic reaction anaphylaxis, it's the body taking its defense and going wide, going like crazy. That's what we have these reactions. Now the last one is IgD, D as in delta, less than 1%, and it's an unknown function. There hasn't been enough research done yet on this one. So let's start with talking about pulmonary ventilation. So pulmonary ventilation, all that means, it's a mechanical process of bringing oxygen into the lungs and then moving carbon dioxide. Just to reinstate, remember that we are bringing oxygen into the body because we need oxygen for our tissues and cells, our body to survive. We are removing the waste, if you will, of the carbon dioxide. That's the key. That's what we breathe in and breathe out. That's the process. Now, there are two types of respiration, and I want you to think about this. So we have internal respiration, means it's happening inside my body. I have external respiration, which talks about I gotta get oxygen out of the air and bring it in my body, and how that works. So let me read this to you here, okay? Internal respiration is diffusion, talk about it in a second, diffusion of oxygen and carbon dioxide, O2 oxygen, carbon dioxide, CO2, diffusion of oxygen and carbon dioxide between the capillaries and the tissues, meaning we got to get oxygen into our body, to the tissues, and we got to get the carbon dioxide out and back out to the body, right? External means diffusion of oxygen and carbon dioxide between the air that we're breathing in the outside world, getting it into our body, and then where's it to go? Down to the lungs, to our pulmonary capillaries, where we can actually bring it in. Right. That's external respiration, going in and going out. Now, what does diffusion mean? Okay, this is very simple, and this is the big key. Gas flowing from an area of a higher pressure to a lower pressure concentration. That's all it means. So we're going to talk more about diffusion in a little bit as we go along. So now we're talking about the breathing process. There's three pressures we just have to know about. I want to make sure you're clear on this. So here they are. These are our numbers. So we have atmospheric pressure. That's the pressure of gas in the air. At sea level, that's about 760. Now the intrapulmonic pressure, that's the pressure of gas in the alveoli itself. It's roughly around 760. Now, intrathoracic pressure also could be called, in wherever you're learning, intrapleural pressure, okay? But usually it's called intrathoracic pressure. This is the pressure in the actual pleural space of the lungs, in the thoracic. Now what we have here is 751 to 754 is roughly what we have. So now I want to talk about Boyle's law and why it's so important with respiratory physiology. So here's what we have. Boyle's law, remember, it's a pressure of gas inversely proportional to its volume. So when I'm talking about a gas, my friends, what we're talking about, in this case, is oxygen. We know we're going to breathe in oxygen. That's a gas, right? So now we understand that. Now hang on here. Pressure of gas inversely proportional. What does inversely proportional mean? It means the opposite. So hang with me now, okay? Now check this out. When I take a breath in, here, do it with me right now. So take a breath in. My chest wall is going to expand, which means I now have more volume of air, which is oxygen, which is a gas, in my chest, right? Yes. Now, if Boyle's law says the pressure of gas is inversely proportional to its volume, if I've gained more volume of air in my chest, what this means, the pressure of that gas, oxygen, going air into our lungs, that means it's now going to go down. So now our intrapulmonic pressure is down when we take an inhalation. Now, I talked earlier on about diffusion, which is about higher and lower pressures. So check me out here. Here's what we have. Because of this process, atmospheric pressure is where it is. But it happens to be in this case, during inhalation, atmospheric pressure is higher pressure than the intrapulmonic pressure, which allows air from the outside to get pulled in, and that's how we actually perform our inhalation. So I'll read this here. This process makes air enter the lungs. And remember, from a higher pressure to a lower pressure is diffusion. There it is. So now we're on to our expiration, which also could be called exhalation. Now here's what we have. When we exhale, what's going to happen? Our chest wall, do it with me. We're going to inhale. Exhale. Notice your chest wall relaxes. Chest wall relaxes. You have an elastic recall of your alveoli. Remember, the alveoli is where the gas exchange occurs. Now, look what I have down here. Another example of diffusion, which is a gas moving from a higher pressure to a lower pressure. So what do we have? Our intrapulmonic pressure now increases because we are breathing out and we have the air moving out of the lungs, right? Atmospheric pressure, in this case, is now lower. That's how we have the process that air is pushed out of our lungs back out to atmosphere. And there it is. Dalton's law. Dalton's law says the total pressure by a mixture of gases, what we're talking about here is the air around us, equals the partial pressures of each single gas. That's Dalton's law. Now, what we're talking about with Dalton's law is the air around us. Now, here we go. Atmospheric pressure at sea level is about 760. We talked about that earlier on, okay? Now, nitrogen makes up about, and we'll talk about the exact in a second, nitrogen makes up about 78% of atmospheric gas. Oxygen makes up about 21%. Interesting, right? Now, there are other small gases that we're not going to talk about here. There's a ton of them, but that make up the remainder of that percentage. But oxygen and nitrogen are the two main players. Now, here we go. So, total pressures by a mixture of gases equals the partial pressures of each single gas. That's what I'm doing right here for you. Watch this. So, this is pretty simple. So, we take the atmosphere, the percentage of that gas in the atmosphere. So, nitrogen is 78.62%. Now, remember, we're timing this as a percentage. So, 78.62% times 760 equals 597. We have 20.84 times that by 760. Remember, the percent, 159. So this right here, this PO2 and PN2, this is our partial pressures of nitrogen and our partial pressure of oxygen in the air itself. So what I'm going to show you here is a visual demonstration of diffusion and how this happens with heart blood flow, with deoxygenated and oxygenated blood, and diffusion actually happening live. Here we go. So, to understand this, we first need to understand heart blood flow. So, if you're unsure, let's just go through that first. I'm going to show you how blood travels through the heart. Okay, number one, that is heart blood flow. Number two, deoxygenated versus oxygenated blood. Deoxygenated blood means that's blood with no oxygen in it. Oxygenated blood means now there's oxygen in my blood. All the tissues and cells in the body need oxygen. And this process starts with the heart pumping blood. So here we go. So this right here represents our superior and inferior vena cava, blood returning to the heart. So the SVC and the IVC, okay? So inferior vena cava coming up from the bottom part of the body, superior vena cava from the top part of the body. They're going to basically unload the blood they have, which is deoxygenated. There's no oxygen because it's already been used up. Ends up in the right atrium. Then what's going to happen is this blood is going to come through the right tricuspid valve into the right ventricle. Now the job of the right ventricle is to get oxygen because there's no oxygen in the blood yet. And we need oxygen, like we talked about. So the right ventricle says, okay, I need a pathway. What do I do? Well, the lungs have oxygen coming in. Right. So the right ventricle, we're going to draw out here. Okay, pulmonary artery. So I label that PA, pulmonary artery. Okay? So now we have this deoxygenated blood going to the lungs to gather oxygen. Now you may have heard about the alveoli does gas exchange, right? Well, that gas exchange process is something called diffusion. And I'm going to show you what it is right now. So now we're going to discuss gas exchange going on, this process of diffusion going on inside the lungs. Now, we just talked about deoxygenated blood going from the right ventricle through the pulmonary artery tracts into the lungs. We're doing this because we need oxygen in our bloodstream. Now, you can see here, I've put a window here to show you what's going on in the lungs. Here's what we have. What we have right now at this stage is we have our deoxygenated blood that was pumped from the right ventricle through the lungs, sitting right here in the pulmonary capillaries. So what is deoxygenated blood? Well, it has a lower concentration of oxygen and a higher concentration of carbon dioxide. Well, the deoxygenated blood, there's no oxygen, right? So, on the other side of the pulmonary capillaries, we have the alveoli. The atmospheric air that we're breathing in, what does that have? Has oxygen. So at this stage, we have oxygen sitting inside the alveoli. And we have a high level of carbon dioxide sitting in the deoxygenated blood. Now, with diffusion, we want to move from a higher concentration to a lower concentration. What this means. In deoxygenated blood right now, we have a high concentration of carbon dioxide. And it notices, whoa, I got a low concentration of carbon dioxide in the alveoli. I'd like to move in here. So it does. And look at oxygen. So oxygen is a high concentration of oxygen in the alveoli. And it sees that in the pulmonary capillaries with deoxygenated blood that the O2 level is low. So the O2 says, man, I would love to move in here. That's the process of diffusion, right? Now, what do we end up with? Well, here's what we end up with. Now we have our carbon dioxide in the alveoli through our process of breathing. We send that out of the body. And what do we have now? Now we have oxygenated blood on the other side of our pulmonary capillaries sending to the pulmonary vein. So what this means, now the right ventricle has done its job that it set out to do. Pass over deoxygenated blood to the pulmonary artery, the lungs, through this process of gas exchange diffusion. We've gotten oxygen now in our blood. So now what do we do? Well, now if I go like here, for example, here's our pulmonary vein, leading oxygenated blood back to the heart. Now we're in the left atria. Well, we move it down here through the mitral valve, and where we end up? Oxygenated blood is now in the left ventricle. Now, I always say, give the ventricle a job to do. The left ventricle is now going to pump oxygenated blood, partnering up with the body's aorta to pump blood to the rest of the body. So all our tissues and cells get oxygen. And there it is. So diffusion of gases through a liquid is determined by two main things. One, the pressure of the gases, and two, the solubility of the gases in the liquid. Now here's Henry's law. Henry's law is the amount of gas dissolved in a liquid and it is directly proportional to its partial pressure, represented here. We go from a higher concentration to a lower concentration. What Henry's law is saying is that we talked about earlier about the fusion. We have a higher concentration to a lower concentration, right? What Henry's law is trying to say is this point it has to stop at some point, meaning that we're going to hit an equal mixture. So what we can see here, we have gas in a higher concentration. We have the liquid down here, gas is in the liquid, the lower concentration here. We go from high to low. This process will eventually stop when we have an equal mixture. That's what we're talking about with Henry's law. Now I'm going to show you Henry's law in relation to the body. So let's understand this. Here we go. So we just talked about earlier on, remember, we talked about how in our deoxygenated blood in the capillaries versus the alveoli, with the movement of oxygen and carbon dioxide switching. We talked about that, right? So like we talked about with the alveoli, oxygen is higher, CO2 is lower, and then in the blood, CO2 is higher, and then we have oxygen lower. We make the switch. That's our gas exchange that occurs from the alveoli to the deoxygenated blood in the pulmonary capillaries. So we talked about that, right? So again, oxygen diffuses from the alveoli to the capillaries. And then oxygenated blood is higher than the tissues. So this is what I'm going to explain down here, okay? So remember, I'll say it again. Oxygen diffuses from the alveoli to the capillaries, right? So now we're here. Okay, so now we're in the bloodstream. So now, well, we have the oxygenated blood in our system. But now, how do I get the oxygenated blood to what we've been talking about this whole time is to the tissues? How do we do that? Right here. Henry's law in the body. So here's what we have. Now you see these P's in front of the CO2 and in front of the O2. It just means partial pressure. That's all it is. Okay, the mixture of what we're talking about. Now at this stage right here, the blood has the higher partial pressure of oxygen and lower partial of carbon dioxide. The tissues at this stage have a lower O2, but a higher CO2, carbon dioxide. So this is where we made the switch. So now here's the key. Diffusion stops when partial pressures equalize, meaning we make the full switch. So here's O2 in the blood. It wants to go to the tissues. The O2 looks over and goes, wow, the O2 looks a little low there in the tissues. Moves into tissues. Okay? Tissues with a higher CO2 looks at the blood, goes, it's low over here. I want to move. And then the process is all started again when we have the deoxygenated blood. Now it's going to return to the venous system, back over to the heart. And there it is. Now, oxygen is present in two main forms in the body. One, it physically dissolves in the blood, about 2%. Now the other, it's chemically bound to our red blood cells in the form of hemoglobin, 98%. So it could be a test question, I just want to give it to you here. Hemoglobin can carry up to 4 molecules of oxygen. Now just remember, folks, when I'm talking about hemoglobin, I'm talking about the red blood cell itself. So the oxygen is going to be carried on the back of the red blood cell. That's our hemoglobin. Now before we move any farther, I need to talk about carbon monoxide poisoning and what this is. Now you may have heard about someone who wants to commit suicide and they turn their car on in the garage and they let the car run and then they pass away of carbon monoxide poisoning. They find them in the garage. That is an example of carbon monoxide poisoning. There's other ways it can happen, but that's common. We think about cars, think about the home, the house. Oh, there's a leak, right? Carbon monoxide poisoning. Now, here's what it is. We know carbon monoxide, my friends, is an odorless gas that's in the air. Well, oxygen's in the air right now, too. Right. So here's the thing. Oxygen's in the air normally, but let's say I have carbon monoxide in the air now, and now I breathe it in. Well, here's the thing about our bodies. This is how it is. I got to tell you this. Hemoglobin, which is attached to our red blood cell, the hemoglobin, which normally hemoglobin and oxygen connect. If there is carbon monoxide in the air, the hemoglobin actually likes the carbon monoxide better. It likes to bind to that better than oxygen. Pretty messed up, okay? But this is what it is. So hemoglobin has a higher affinity, medical word, to carbon monoxide than oxygen. Isn't that crazy? It's crazy. Now, which means I get a pulse oximetry on my unresponsive patients where I predict carbon monoxide poisoning. It's going to read 99 to 100%. Why? Because your pulse oximetry, what it reads is what's the percentage of oxygen that's saturated to our hemoglobin, right? That's what pulse oximetry is giving you. So in CO poisoning, they're going to see, oh, saturation looks great. Yeah, it's saturated with carbon monoxide. Oh, that's not good. So we need to get, most importantly, think about this. We're in a CO environment, get the patient out of that environment, load them up with oxygen. Now, it's the wrong gas, what we're getting at. So, by the time we get there as EMS, they're likely going to be unresponsive. Again, O2 should be given and get them out of the area. You may need a specialized team, like for example, the fire department, to go in there and help you get the patient out safely. So now let's talk about our CO2, our carbon dioxide, and inside the body, what's going on. So CO2 is produced in the body based on, well, there's two main things. One is the body rate. So what are we actually doing, right? Two is the type of metabolism. So look at the body rate. Give you an example. During exercise, we're going to increase the production of CO2. Sleep, we're going to decrease, right? Now, how is CO2 transported? Well, it's different than oxygen. So plant that in your head. Okay, it's different than oxygen. It's not going to hop on the back of hemoglobin, all of it, and go for a ride. That's oxygen. So what CO2 is going to do, it's transporting the blood by 8% about is due to the blood plasma. Another 20% by the blood proteins. And in the third stage, the majority, is actually transported by carbonate ions at 72%. I don't want you getting caught off guard. I got another one for you. It's called the Fick principle. So here we go. Back to our key terms. Let's go. So Fick principle. The amount of oxygen the lungs deliver to the blood is directly related to the amount of O2 the body consumes. That is a definition of the Fick principle. Now, what we're talking here is how well the body circulation is, how well oxygen get around the body. So here's what we have. Number one, this is what we need in order to make this stuff happen. So number one, we need adequate oxygen, remember O2, adequate oxygen to saturate the hemoglobin. That's step one, which means we need adequate ventilation, right? Number two, the red blood cells, RBCs, red blood cells, circulated to the tissues. So we need blood to be circulated to tissues, which includes the red blood cells, right? So what that means, well, we need adequate cardiac function. The heart needs to be able to pump. And we need blood flow to not be obstructed, right? Number three, red blood cells that are able to load and unload oxygen. So we got to get the oxygen moving off and onto the actual red blood cells. So what we need for that is we need normal hemoglobin. And we need adequate circulation. So if we have all this, that's where we want to be. But let's continue our key terms. You may have heard about hypoxemia and hypoxia. Well, they're actually two different things. So here's what it is. If you hear hypoxemia, that is decreased oxygen in the arterial blood. Remember, our arterial blood is the oxygenated blood. So it should have oxygen in it. So if it decreases, an issue. Now, think about it, folks. It's very, very simple. The medical language tries to make it complex, but it's not. Listen here. If I have decreased oxygen in my arterial system, then of course that it can lead to the tissues not getting enough oxygen. And that's what we have here. Hypoxemia can lead to hypoxia, which is decreased oxygen at the tissues. And there it is. Now, there's many, but I wanted to write some of the main ones for you when we think about inadequate blood oxygenation. What would cause this? Head and spinal injuries, asthma, like CHF, pulmonary edema, right? Emphysema, chronic bronchitis, COPD, shock, infections like pneumonia, chest wall injury like flail chest, anemic patients, CO poisoning, and myocardial infarction. So these are some of the main things that we see in EMS, so I want to put them here for you, that will cause hypoxemia that can lead to tissue death, hypoxia. So now we're going to talk about, you may have heard about the VQ ratio, ventilation and perfusion. So that's what we're talking about right here. ventilation-perfusion ratio. So let's start with our key terms. So here we go. Now remember this before we get started. Ventilation, think air. Perfusion, think blood. We're off to a good start. Assesses efficiency of alveolar ventilation. Okay? And pulmonary perfusion. So here's what we have. So ventilation is going to assess the efficiency of the alveoli getting ventilated. Okay. Perfusion, well, what's our pulmonary perfusion? Okay. So ventilation. Ventilation, labeled by V, is air that reaches the lung. So normal would be about 4 liters per minute. Okay. Now perfusion, that is blood that reaches the lungs. Normal, 5 liters a minute. The ratio is shown 4 to 5, or can be represented as 0.8. And there it is. So now we're talking about our VQ mismatch. So here we go. Let's first define what it is. So we're talking about ventilation versus perfusion. A mismatch means we have a problem going on in the body. Ventilated alveoli, not perfused, or we have perfused alveoli that is not ventilated. So let's just go over that again. We have ventilated alveoli, which means our ventilations are good, but perfusion is not good. Something's going on wrong with perfusion in the body. What's going on here? We're ventilating the alveoli. Why are we not getting the perfusion we're looking for? The other side, we have perfused alveoli. Okay, good. Well, so with the blood flow is going well, but there's something wrong with our ventilation. Something wrong with the lungs. So is it a lung problem or is it a blood flow problem? That's the VQ mismatch. If my VQ ratio is too high, okay, meaning we talk about 0.8, it's above that, ventilation is greater than perfusion, which means we have a problem with our perfusion. We have a blood flow issue. Pulmonary embolism, well, that right there, we know we're obstructing blood flow. We know that in pneumothorax, we can also have blood flow issues. Exactly, right? Because we're pressing on the heart. So, P and pneumothorax are examples of an elevated VQ ratio. What about a decreased ratio? So less than 0.8. Perfusion's doing okay. It's greater than ventilation. So these are lung problems. Asthma and COPD, for example. We're not having good, strong ventilations going on. We have a lung issue. But with body's perfusing, with blood flow is okay, but something wrong with the lungs. So that's what we have here, and that is VQ mismatch. So now let's talk about the regulation of our respiration. One is the voluntary control. So you got to understand that breathing is mainly involuntary. As I'm speaking to you right now, I'm breathing, I'm not thinking about it. I'm thinking about what I'm doing with you here right now, right? But if I want to take a breath, I can take a breath, right? So breathing is mainly involuntary, but it can be constantly changed, right? For example, so I can voluntarily myself, I can hyperventilate and I'm going to excessively lose carbon dioxide because I'm hyperventilating. Now, if I'm going to hold my breath, this is common at children. You can see this in patients that have even anxiety sometimes, where they're just holding their breath in. You may see. So voluntary apnea, usually children holding their breath. What will happen with this? I want to share something with you. Let's say you have a young child that is having a mental health crisis, and the young child says, "I'm going to hold my breath, and I'm going to keep holding it." Okay, and they go do that. So there's nothing physically wrong with them besides the fact that they're constantly themselves holding their breath. So eventually they're going to pass out. But when they pass out, in a few moments, they're going to wake up and be breathing normally again. So that's how this stage works. And you may see patients like that because I've had them myself. Number 2 is our nervous control. So this is very simple. We have inspiratory muscles and expiratory muscles. On inspiration, what do we have? The diaphragm and the intercostals. You may have heard of C3, C4, C5 keeps the diaphragm alive. Well, yeah, because this is what's connected to the diaphragm. Right? We think of C3 and C5. That's important for the diaphragm. For the intercostals, it's T1 to T11. So there we have that. Now don't forget this. Our phrenic nerve is going to innervate our diaphragm. Now, expiratory muscles. In quiet respirations, they're pretty quiet. But if you have forceful respirations on, or breathing out on the expiratory side, when you're coughing or sneezing, for example, right, or forceful respirations, that's where we're going to use our abdominal muscles as well. And there it is. So just some more key points I want to make about our nervous system continued. So first, this is influenced by our medulla, our pons, our hypothalamus, our reticular activating system, the RAS, and our cerebral cortex. These may be little test questions, so, when we're talking about nervous control of breathing, so here it is. Now, here's a key reflex in the body. So here it is. It is going to limits inspiration and prevents overinflation of the lungs via the vagus nerve, and that is our Herring reflex. So here's number 3. It's the chemical control when we're talking about respiration. Here's what we have. So it's determined by changes in oxygen, carbon dioxide, and pH. But carbon dioxide and pH are really the major regulators of the chemical control. So remember this, folks. Carbon dioxide, okay, which is, we can see right down here. Carbon dioxide is more acidic. So this is why we're going to see some of the pH changes that we're going to see. So here, check this out. So carbon dioxide is up, and the pH is, in this case, lower. Remember, if our pH is lower, we are acidic. If our pH is higher, we are in an alkali state, right? So I'm saying to you, when I think of carbon dioxide being elevated, I think of an acid. I think of acidic. Yeah, that's what we get. So what happens in this case? Increase in ventilations to get rid of excess CO2. Now down here, we have a lowered amount of carbon dioxide. Well, we get the opposite. I said, think of high carbon dioxide, think of acidic. In this case, we're going to be on the alkali side. Inhibit ventilation to allow O2 to return to normal levels. Those are the keys for chemical control. Continuing our chemical control. So we talked about CO2 and pH. What about O2? Well, O2 plays a small role, but in certain circumstances. So O2 plays a small role. Number 1, the PO2 is low in arterial blood. So if we have a condition that causes our oxygen level to be low in arterial blood when it shouldn't be, it should be high. But if it's lower than normal, for example, like we're in shock, then the body is going to respond by an increase of rate and depth of breathing. This is why we're in shock, we start to get a higher heart rate and get more respirations. The second piece is, let's say we're in a higher altitude than normal, okay? Well, first, our PO2 in the air around us and in the blood is going to be lower. It's hard to breathe in higher altitudes, okay? So the body goes, wow, I'm in an environment where I have less oxygen available, which means I have less oxygen in my blood too. So let's increase our rate and depth of breathing to respond to that. 3, COPD patients run off of something called a hypoxic drive. What this means, they are used to living in a low PO2 state, a low oxygen state with COPD. They're used to running on a high CO2 state. With COPD, this high PCO2 state reminds them in the body to, hey, we got to breathe a little more to get rid of this excess CO2. What this means for us in EMS is very simple. Your COPD patient may know what their normal SpO2, their normal pulse oximetry, finger probe number is, okay? So let's say for them, they have a normal number in the low 90s, but that's normal for them. That's where they live at. We want to get them back to that number when they call us. We don't want to over-oxygenate the COPD patient. It does not mean we don't give them oxygen. It means you want to get them back to their normal, right? Now, here's a tip I can give you. Our goal with any patient is to get them to at least 94%. Now, with COPD, we want to ask, what's your normal? Get them back to that number, right? Now, when in doubt, get your patient back above 94% and try to hang them out there. We don't want to blast a COPD patient who is not used to having 98, 99% SpO2 and drag them all the way up there. We want to get them back to their normal. So stay on the lower side. Just a tip. Now, number 4, what are the other factors we need to consider when we're talking about regulating our respirations? Well, here's what we have. Body temperature. If my temperature increases, my respirations will increase. For example, let's say I have a fever, or let's say it's physical activity in the hot sun. On the other side, my body temperature decreases, like in hypothermia, my respiratory rate will also decrease. Drugs. If I take an EpiPen and I slam it in the side of your thigh and I give you a shot of Epi, our respiratory rate goes up. If I was the opposite and I said, hey, let's give you a shot of an opiate like heroin, your respiratory rate goes down, right? Pain, fear, anxiety, respiratory rate up. Metabolism. I have a lot of activity going on. Up. Decrease in activity. Down. And there it is. Other factors. So these are important key terms that we need to know. I don't want you to get caught up with these. So hear me out here. Tidal volume, you may have heard. Tidal volume is a volume of gas inhaled or exhaled during a normal breath. So that's a range of 500 to 600 mLs. Tidal volume simply is our normal breathing process as far as volume. So we think about our normal inhalation or exhalation and the volume of that, that's a tidal volume. Our inspiratory reserve volume, what this means. Let's say I take an inhale, then I want to inhale again afterwards. This is our number. So it is the amount of air that can be forcefully inhaled after inspiration. So the way I think about it is I take a breath in, and then once I take another breath in, right there, before I exhale, how much more could I bring in, right? Well, roughly around 3,000 mLs, okay? That's our reserve volume. Now, what about expiratory reserve volume? Well, that's the amount of air that can be forcefully exhaled after an exhalation. So I exhale and I want to go a little bit more, even more, take another exhale. That's roughly about 1,100 mLs. Now, a few pieces here that we're going to discuss in the last section. What is our residual volume? So the residual volume is the air that remains in the lungs after forced expiration. So the way you can think about it is we took an inhale, we took an exhale. What do we got left? That's our residual volume, right? The leftovers, right? Now, the final piece here, and my last sentence, it's a little closer, but I want to read it to you. The combination of these 4 that we have here, 1, 2, 3, 4, these 4, the combination of that equals our max volume of air in the lungs. So that is our total lung capacity. So we have the inspiratory capacity. So what that is our tidal volume, which we talked about is the amount of volume we're breathing in and out, plus our inspiratory reserve volume. So our inspiratory capacity, you can think about our inspiratory capacity as how much you can actually inspire, how much you can actually breathe in. This is roughly 3,500, okay? Now, what is our functional residual capacity. This is our expiratory, so breathing out, reserve volume, and our residual volume. Residual, remember, it's the leftovers, okay? Residual volume. So this functional residual capacity can be thought of as the amount of gas in the lungs after exhalation. So I take a breath out. My functional residual capacity is what's left over in the lungs. When you think about it like that, after exhalation, okay? So that's roughly about 2,300 mLs. Then we have our vital capacity. So our vital capacity is the inspiratory reserve volume plus our tidal volume plus our expiratory reserve volume, okay? So both reserve volumes plus the tidal volume ends up being, or roughly, 4,600 mLs, right? Okay, and remember, these numbers are not like exact, they're rough estimates on a normal adult, okay? So now we have total lung capacity. So this is our vital capacity plus our residual, or leftovers, our residual volume. That's 5,800 mLs, okay? Now this is probably the most important one in this whole list here. The old minute volume. We've heard it, and here's what it is. The minute volume simply is this. The minute volume is the exact amount of volume that you're bringing in and out in 1 minute. That's it. So it's talking about the amount of volume of gas is going in and out of you within a minute. That's it. That's minute volume, folks. So there's an equation with that, and it's really easy, right? So we all know respiratory rate. So we know respiratory rate is usually around 12 to 20 in most people, right? Could be lower, could be higher if there's something going on. So I gave you an example, okay? Now we take the respiratory rate and we times it by the tidal volume, which is the amount of volume that's going in and out, right? So the normal minute volume is anywhere from about 5 to 8. I would say what's normal would be kind of right in the middle of this, right? Depending on what you're doing too, right? Now, if I have someone breathing at 10 breaths a minute, so a little on the slow side, but the tidal volume is still normal at 500 mLs, what do I get back on that? 5 liters a minute. So I'm just on the edge of normal. There it is.